लोग वहां बैठे हम लोग कहीं बैठे हैं। ठीक है ना, चेयर और रखवा देना। नहीं नहीं, सही करो, 2+4 है।
So, good morning, everyone. So, coming on to the third and the final day of our Northern UCCon, starting the session of resident session. So, conveners are already on dais, Professor Samir Dwivedi and Professor Nachiket Vyas. So, I would request you to kindly proceed with the session. Thank you.
Thank you, Himanshu. Good morning, everyone, and welcome to this resident session, one of the important sessions in the conference. Recently introduced but gaining popularity, and a lot of things to be discussed and deliberated. And those of you who think that every year there are discussions, but then the things are not taken forward, I agree with you. So probably we should make an effort to take the conclusions of these discussion a step ahead, pass on it to the higher authorities. I know Norzone USI is not the body to govern the policies of education in our country, but we can definitely send our recommendations and hope that at least this is in a beginning. So for this session, we have 5 topics. We have divided into subsessions, and each subsession will have 2 senior faculty members and 2 residents/junior faculty. So I will start with the first session. I'll invite the panelists. Dr. A.K. Mandal sir probably would be joining online. So Dr. Siddharth Yadav, can you please come and take your place, Siddharth? Dr. Rishi Raj Vora and Dr. Manish Khattar. Can we have our slides, please? Mandal sir is already here. Good morning, sir.
Good morning.
Good morning, sir. Nice
Very
to
good
see you,
morning,
sir.
Dr. Nachiket.
Pleasure to see you after a long time.
Yeah, I'm here. Don't worry.
Yeah, thank you, sir.
Can we have the slides of our presentation?
सर को भी है ना PNP में, please can you project sir also inside PNP?
I can see, no problem.
So the topic of discussion for the first subsession is whether it is time to revamp the current urology residency program. And there are certain subheadings within that, and we'll try to pick up these points one by one and get the opinion from our panelists and of course from the audience. This is a free session. We have deliberately not kept any slides or anything so that we have a free exchange of ideas and free flow of information. So anybody from the audience, if he wants to contribute at any point of time, you are most welcome. But we'll try to stick to time. Yes, Nachiket.
So just waiting for the slides.
Next,
Himanshu, next slide, please. Next slide, please. Could you put up the issue slide, the next slide? Yes, so the first issue that we'd like to discuss is the standardization of the curriculum. And I think that it would be the best interest that we have Mandal sir with us, who has headed a department and who has worked closely about the teaching curriculum inside a big institute, PGI, which is one of the premier institutes. So we would like to kick off discussions with him, and then we'd like to have inputs alternately from our junior faculty and residents and regarding standardization of the curriculum. Mandal sir, so what do you think
Yes.
that this is because there's so much of difference inside the training in different institutes. Every institute has its own, strengths, if I can put this word, and weakness also regarding. So what about what are your thoughts upon this?
There is no doubt that the education curriculum and training of the students must be uniform in the country. Now we are in a developing phase, no doubt about it. Here there are various autonomous institutions. We had the National Medical Council now in place of MCI. So curriculum differs from place to place. And I must also say that teaching centers also differ in their training facilities. But there is no doubt the education started in 1965. MCH course was started in 1965. It started with a 2 years curriculum that continued almost for 30 years when it was changed to 3 years curriculum as you are seeing nowadays. Now the subject has become so vast, new technologies has come, the aspirations of the younger generations have also changed drastically, which are appropriate. So therefore, I must emphasize that it's time we must change. And it is also a question whether we start our training after masters in surgery, or we are in a time that we can change on directly from MBBS to a longer duration course of 5 years or 6 years. If you ask my personal opinion, I would say that we should change very fast to a curriculum which will be 6 years soon after MBBS, where the training for surgery should be limited to the wound management, emergency and trauma care and critical care, and rest years will be in urology itself. The last year, final year, I would say that we must keep a provision that the training by now, after 5 years of exposure, would be mature enough to choose his area of specialization, and the last 1 year should be kept for his specialization. That's in brief. So final word, that we must improve, not only change, we must improve and drastically revamp the curriculum. Thank you.
sure, sir. Thank you very much. We'll take further opinions on this. Let us start with Siddharth. What do you feel?
Siddharth, I may add that you did your MCH from AIMS, and then you joined as a faculty inside Safdarjung. So now you've seen both sides of the coins pretty quickly. So regarding the training that you received and regarding the training that you are giving now. So I mean, we want your absolute neutral assessment of things presently.
Urology is actually, sir, it's very broad specialty. First, we need to divide things into basic and advanced levels, and then standardize things at every center. Like basic has to be, it should be given and it should be done by every resident. And advanced, it depends upon whether if the resident is hardworking, he can have some things. And also, like sir, I said, for 6 years, the program should be extended to 6 years. I believe 3 years is very less, but then like making it 6 years would be a little too long. So we can have.
No, what he meant was remove the general surgery part, make it a direct 6 year after MBBS.
Yes, sir.
So that does not extend that
Extend
overall
the
time, but
curriculum,
it
but-
gets more time into it. We'll come to that. We have that topic for discussion subsequently later on. Dr. Rishi.
So according to me, actually, general surgery part is the important part of a surgeon's life. I don't want that to be skipped. The other thing is we can do it in 2+1, the residency part of MCH. We can shift the 2 to the general part of urology, and the last year for the subspecialty which the resident want to go in. They can choose endourology, pediatric urology. They have an option of going with that, and that will increase the focus of that resident to that particular specialty and will probably excel in practice.
Okay, all right. I think we are slightly deviating away from the topic. When we meant standardization of curriculum, what we meant was the way urology is being taught and the trainees are being given the training. Should we have, say, modular courses that we already identify certain areas that these are must courses which every institute has to do? For example, currently what is happening is one center is very good at doing a particular brand of subspecialty, while the other subspecialty may be slightly lacking at that center. So our meaning of doing a standardization was whether there should be a uniform curriculum which has to be followed across all institutes, that these are the basic urology courses which have to be taught at every institute. And then on top of that, whichever subspecialty is good at that center can be an added bonus for that, something on those lines. So yes, Dr. Manish, I believe.
Sir, I agree with you, sir. I think there should be a particular streamlined curriculum that one needs to finish before passing out from their institute. Like, I have no experience in transplant because in names they do it in under general surgery, and some centers they are doing extremely well in terms of transplant. So there should be some standard which should be set, and that needs to be finished before you pass out. And over that you can have some added specialties based on your institute.
Okay.
Rishi, when you passed out, I mean, you're 3 years into practice now. So when you passed out, then, you know, I'm from the same institute, was your teacher. So one of the deficiencies that we had in our department when you were training with us is that we were doing very basic lab, very or no lab at all. So I'm sure that must have come as a hindrance to you when you passed out. This is because after you passed out, then yes, we have developed lab and we have started routinely doing, and maybe we're not doing still advanced lab. We have to, we're all opening our hearts out here. But yes, we have considerably, you know, improved the lab program. So do you think that was a deficiency when you joined as a consultant?
So as a junior consultant, you get a training for another couple of years
Yes.
with a senior.
Yes.
What I got from my institute was I got a basic lab training, and I was okay with it. I coped up with my consultant and started doing basic laparoscopic urological procedures in a couple of years. Still, I didn't had any hands-on experience at my institute for laparoscopy, and I think it's most of the institute are in lacking giving hands-on to their resident. So it's a big deficiency which lacuna that needs to be filled. Otherwise, it will be very difficult for a resident to come out and practice nowadays, because the demand of the people are so high nowadays. You need to give results. You can't say that this is not possible, this is in difficulty. But I feel the resident should be given some free hand from the consultant sides to make things good.
Yes.
Okay, all right. I think I knew that we would have endless discussions on these topics and there would be shortage of time. So we'll have to move on. I think the next two issues which we have written down, they are probably not that important. They are more of a finer detail. So we'll skip to the fourth point because the session doesn't have much time left, about the examination pattern. Now, when we say examination pattern, we mean the MCH passing out exam. And like DNB, should there be a central exam? Should there be a uniform pattern? Right now, there is no mechanism at, I believe, most of the places to evaluate the competency of the residents, the surgical competence. So should there be any procedure or any method by which their surgical competence can also be assessed before giving them the degrees? So these are 2 or 3 issues, and we'll invite Dr. Mandal back into the discussion. Sir, what do you feel about this?
I strongly agree with the unified system of evaluation. Now, for that reason, it's a big thing how to organize it. But I'll bring the corollary of the National Board examination. It is conducted in a centralized fashion and it's quite standardized. So therefore, The MCH courses at this time is in different universities, different institutes. So they have got different patterns of evaluation and training. So there is no doubt that the training should be uniform. Evaluation also should be uniform. How do we do it? We can discuss, deliberate, and agree on that.
And the part about evaluation of surgical competence, sir, would you agree with that, or
See,
is-
during these examination, which may spread over 1 day or 2 day, you cannot evaluate the surgical technique by the students. So therefore, we have to rely on the certification by the institute that yes, these candidates have these minimum exposures and he has attained this minimum level of competence. The logbook is a standard proof. The logbook should be continuously updated and validated by the faculty members. I must say that at AIMS case, this is a routine. The logbooks are updated every month. So those are the pattern. In the past, there were endoscopic sessions in the examination, but that because the endoscopy was done in very few limited centers. So things have changed. So I don't think that surgery should be evaluated by watching the students to perform surgery. That's not a fairly good option.
Okay, sir.
That's it.
Yes, Siddharth, what do you feel? Can we use simulators for that purpose?
Definitely. So that is what I was going to add to it. That
Siddharth, could you put the mic closely?
Closer to you.
Closer to you.
so besides the technical knowledge, we can check the skills on simulators. And now simulators are available for almost every procedure, and the basic things can be easily evaluated in a single day of the exam.
Okay. Yes, Dr. Rishi.
Yes, a simulator can be a great help because every institute have their own type of caseloads, and it's very difficult to streamline everything in India. So simulator can definitely help in this laparoscopy and other endoscopic procedure, which will be good for the residential trainings.
What about the other 2 points? Centralization of the exam and the pattern.
Sir, actually what my feel was that DNB program is currently running under my institute also for urology. In the DNB program, there are few very good things that the resident has a 9 to 5 job. He can leave hospital at 5, but it's very difficult for the basic institutions, which are old institutions, to leave the hospital at 5. So they get ample of time to study, judging all the students in one fray will be difficult. DNB has a way of getting that logbook done. I think they have changed it to the online system now, that every case they do, they have to fill the details online for each patient, and that they need to be ticked by the consultant that he has performed or he has assisted. So good things can be taken from DNB, and if things can go streamlined in our big basic institution, which had urology courses since decades, things can go in that way of going for centralized exam.
Okay, let us hear from someone who still has to get his degree. Yes, Dr. Manish, what do you feel about examination?
Sir, I think one cannot judge the competency in 1 day. So it's a very stressful time, the
So
examination.
you want exam for 5 days, 6 days?
Yes, it's still the faculties in your institute, they can take it on your face.
What do you
value.
think about faculty bias? Do you think that you're more comfortable giving exam and inside your backyard? Would you be happy to come to Jaipur to give an exam? Do you think that centralization, would be a good thing or a bad thing inside the MCH program?
Sir, for a resident, it will be a bad thing, I think, because
Why do you think that Samir sir is going to fail you? Why is that bias? Where's the comfort?
so the comfort of your institute is always there if you're giving exam.
We'll give you real good comfort in SMS, 5-star
But sir,
treatment.
3 years you've worked very hard, and like you've done some things which are not even part of your curriculum. You've stayed, but you cannot judge a resident on just
But
1 day of assessment.
don't you think that you get too dependent on the blessings of your teachers for that? If they are going to be your examiners, then you can't afford to antagonize them, and then you have to be, since you know that they are going to evaluate you ultimately, don't you think that kind of creates a subjectiveness to the whole process?
Yes, sir. It's
But you're
It's
agreeing
not
to
an-
everything. You're agreeing to this also, and then you're saying that no, I'll still get exam inside my
Sir,
institute.
It's not an objective assessment. I'm just saying ki your examination is usually not an objective assessment of your performance. It's a combination of your previous work of 3 years, and then they evaluate you for your knowledge and your knowledge gaps. I think
So you think that in DNB, when you have to go outside to give the exam, you think that you wouldn't be, I mean, prepared for a centralized this, because centralization of examinations is the worldwide trend now, I believe, everywhere.
so once it becomes the trend, then everybody will accept
No, but
it.
you're resistant to change of that trend. You,
It
say
hasn't
that.
happened for a long time, so I think that's why the inertia that I'm presenting.
Let me take that a step forward. You said earlier that you can't judge a competence in 1 day exam,
Yes, sir.
and he said 5, 6 days. What you say, we have 6 semesters of 6 months each. And at the end of each semester, you assess that particular course which has been taught in the first 6 months. Let's have
Yes,
a
sir.
modular
That kind
courses.
of a regular internal assessment or an external validation that can be done like regularly, every 6 monthly or yearly. That can be done, I think.
Mandal sir. Mandal sir,
Yes.
so
I
what
was
do you
trying
think
to-
of, sir?
Yeah, I was trying to say two things. One, the last point of centralized examination and periodic assessment at the end of 6 months, fairly good, and should be no hesitation. And in fact, at PGI Chandigarh also, we had assessment every 6 months. Here in AMCC case where I'm working these days, is practically a monthly assessment. That's a little tougher for the students. I was trying to say 2 points. One point came in discussion that during the national board training, that the students are free to go home at 5 o'clock. Now, surgical residency is not 8 to 5 job. So let's not go with this idea that there is any laxity on the part of the student to invest their time and learn. After all, you have to perform. You can practice any amount of sessions on the simulators, but unless you handle the patient actually, your training will never be complete. So surgical training, this can be all right for medical specialties, but surgical training, I definitely disagree that no, the students has to invest their time. They should be mentally ready to work for 12 hours at a stretch, at least 12 hours in a stretch, so that they look after the patients after operation. Also, this is for your learning, no doubt about it. The third point I was stressing that the moment we talk of centralized examination, only then there will be a standard pattern and the candidates has to go out of the home center. That has to be accepted. So that's a change in mindset. I don't think that will be a big problem. Thank you.
Thank you, sir.
Sir, I just wanted to make a point regarding this. One of my first cousins, she's doing a surgical residency from Cooper Medical, New Jersey. So they do not have, they are a community hospital and they have basic training in general surgery. But then for specialty exposure, they then go to New York Presbyterian. And so I think that it's important that because they do not have everything to offer to a resident at one center, so she, by some agreement that they have, because it's a private hospital and majority of hospitals in the US, they are private. So that's why they rotate their residency also, which I think that is important. This is also part of centralization, sir. Your final comments.
Yeah, we have just a minute to go. Rather than final comments, any final comments from the panelists, and then we'll pose a question to the audience. Anything you want to add to all this, whatever we have discussed?
Sir, I feel that internal assessment and external exam should be merged, like that has been done in other entrances in India. The 3 years should have some weightage. That can be the platform to have a streamlined central exam, that a 50% goes to the 3 years training and 50% your external thing. So that will be easy for the resident to take it, for MCS student to take it, because sometimes there are some discrepancies between MCS training and DNB's training, which I can't comment upon right now. I feel that 3 years should be taken into consideration for giving external marks also.
Why can't you comment? I mean, we were having an open.
So the thing is actually
roundtable.
in a private setup and a government setup, the work culture is totally different.
Yes,
The resident doesn't do the basic work in the private setups.
yes,
They are going directly to the OTs.
yes.
They are only doing the OTs. There is nothing. They have to shift the patient. They have to take care of everything. Whatever the staff nurse take care of that.
Exactly.
But it's not in institutions.
Yeah.
It's a resident's responsibility. That thing can be taken off from that MC's resident. That gives him more time to concentrate on the subjects. I don't say that that is wrong, because you learn a lot when you are with the patient, and you can just when you are consultant, you can just pick it up that this thing has happened because of this problem. System, I might have missed that. This thing would be a lacuna. You learn with that, but in DNBs, this thing is lacking. Patient to doctor time has reduced a lot. That is not the case in MCH. This is the difference.
No, but which side you are advocating, the DNB side or MCH
Sir,
side, which is better?
Sir, I'm not saying that this program is bad or this is wrong. We need to, the lacuna for DNB is that the patient to doctor time has reduced. In MCH still, we give a lot of time to the patient.
Okay, all right. So let's have a final opinion from the audience. How many of you feel that there should be a central examination? Please raise your hands. Centralized exam. I think that the answer is very clear.
Yeah.
So we thank the panelists of this session. Thank you very much. Thank you, Mandal sir,
Thank
for
you.
giving your valuable time and being with us. Thank you so much.
I'll
Thank
be
you,
there
sir.
till the session. Okay, no problem.
Okay, we invite the next panelist for the next session, Dr. Prabjot Singh, Dr. Ankur Mittal, Dr. Sohail Masood, and Dr. Jain Tamboli. And
Could
this
you
is-
project the slides also, please, for the next?
And this is one of those sub-sessions where we are going to discuss a very important topic regarding the sub-specialty training. And when we say sub-specialty training, we mean post-MCH or post-DNB. So whether we need it, why do we need it, how should it be done, all those issues we are planning to address. Can you move the slides forward, please?
Next slide, please. Manchu, can you ask them for the next slide?
Next.
Yes, next. No,
No,
the
Go
first
back,
was a
go back. Go back.
Go back. यार आप एक एक करके जाओ.
Next. One more. That's it. Thank you. So firstly, to address the elephant in the room, do we need sub-specialty training? Yes, Dr.
Yes.
Prabhajot, we'll start with you.
Yes, I think the time has come now that we should recognize that these subspecialties already in the US they are doing they are already in this system, but our USA has now recognized 8 subspecialties. So the advantage is that with this, if we are working in one area, then you can expertise in that area, and we have so many examples in our country also. And then you can generate your data and you become stalwart of that thing. But my question is whether India is ready for that or not. This is possible in academic institution, in corporate hospital in the big cities. But is it possible to work in a subspecialty in a smaller city where majority of the urologists will go and work? That is the thing we need to understand.
Right. Ankur?
So I would say, actually, that we should add one more addition, that subspecialty exposure and subspecialty training. So if you talk about the MCH program, which is running, or DNB program running right now 3 years. So I should say that 3-year duration, I would say it is too short to cover everything what we are expecting in this session today. So a broad-based teaching, learning, which includes everything a resident should know and pass out, which is a mandate of any curriculum, standardized curriculum, probably will be if we able to give a subspecialty exposure to those candidates in their training of 3 years. And then a subspecialty training. Also, I say yes, but that again is, I think we will discuss it further how we can. But I think subspecialty exposure, it is good to have subspecialty exposure in every field. It will be the ideal thing for every institute to have all the fields, a model like that like you have all subspecialties, 8 subspecialties where Dr. Prabjot has said, someone is doing in that institute and reason is being rotationally posted on those, and we have an exposure. So answer is yes for both subspecialty exposure and subspecialty training. And I would say, sir, this is just to add on, I would just a bit differ with Dr. Prabjot that if we divide our reasons into, like, if they pursue their career in academics, if they pursue their career in private, I think it is important for both of them. It is how we look for and how we choose our subspecialty exposure and subspecialty training. Some subspecialties are very important, which even a private practitioner who will pursue his career is important for them. And some specialties probably maybe for academics, but both of them will go through.
I just wanted to add one thing that Prabjot was saying. Sorry to cut you off, Prabjot. You said that majority of our urologists now would be going to tier B or tier C cities. And you said that you don't know how much, of specialty, subspecialty patients they would be, getting. Totally agree with you. But however, I think that the concept of subspecialty inside, say, a tier B and tier city is that it's important in a tier B and tier C cities to be a generalist. For example, for my resident who is sitting actually Ganganagar on the border. But if he can, subspecialize in a particular subject, then it's not that he has to totally give away with his general urology, but maybe he can have, say, if he has an interest in andrology, then maybe an andrology clinic. He can, run an andrology clinic because he's interested in that, or a female urology clinic, he's interested in that, or maybe a pediatric urology clinic. So I don't think that it totally means that you're gone as a general urologist. You'll not be maybe not handling your basic prostate problems or basic stone problems, but I think that
Yeah, so that is
subspecialty
another
can
distinction,
coexist.
yeah, whether you're
Yeah,
doing
you
it
cannot
for
be doing exclusively that
Yes.
specialty, but you have to be general. You should be knowing basics also.
Yeah,
Yes,
Agree.
yes. I mean, you're Dr. Sohail or Dr. Zain?
Doctor
Dr. Zain, sir.
Zain
Okay,
Tambuja.
all right.
Yeah, am I audible? Yeah, yes. Sir, can I opine, sir?
Sure.
Yeah. So I come from a mid-tier B, tier C city from Maharashtra. There are already 6 to 7 urologists in this one city. It's a small city wherein I can go from one end of the city to the other in 10 minutes. I was advised that you just do basic urology, come start your practice. But in the future, I do not think that that is the way forward. Irrespective of the saturation of urologists in today's age, I believe that subspecialty training is very important. Coming out as a resident, I would rather be a master of one rather than a jack of all trades. So,
When you say that, if you do that, are you willing to forego all of general urology and focus only on one thing in a small city like yours?
so it can be an amalgamation of both.
Yeah,
I
that's what
agree.
we are saying. So you would still do general
Yes.
urology.
Yes, sir.
Now, the second question that we have, is it really the desire to gain subspecialty skills or the fact that our training is simply not enough? The residents are not getting enough surgical exposure. So therefore they go in for post MCH, post DNB, subspecialty training just to gain more surgical experience. And
Sir, I don't think this is the second. The second is the case. The first is there is a desire now. There is a peer pressure. There is a competition. You have, if you want to be in the limelight, you need your name. Then you have to excel in one specialty. That is that is not the case that you need additional training. Then you do some fellowship. Then you can stay for maybe post MCA senior residency or some kind of pool officership. But for the training purpose, I don't think this is the case.
for example, somebody from AIMS, I think Manish, said that since we do not have exposure to renal transplantation, so for that reasons, maybe he would prefer to go in for a 6 months or a 1 year fellowship in transplantation after his MCH, so that if he goes to a hospital where transplants is being done, then he'll get the
Yeah, I
necessary
agree with that
exposure.
point.
So,
Actually,
in
For the
that background. Yes, Ankur.
Sir, actually, again, if you come back to the point, like specifically, I should address the transplant issue, which resident has, this is a very important concern from the part of residents. Like an institute, we are discussing about 7 or 8 subspecialties today. Answer is yes for them exposure or training, whatever possible. One of the subspecialties is transplant. So if you don't have an exposure in training for transplant in some centers, and definitely we have some different guidelines for different subspecialties. Some specialty have some guidelines we are following. Some specialty don't have any guidelines right now. That at our disposal. Transplant have some guidelines. So those candidates with that guideline, that 3-year clause, once they complete their MCH, if they are not eligible, they are not following the eligibility criteria. So now to get another 3 years after their MCH just for one subspecialty and leaving their basic specialty, which I strongly agree that basic things always go hand in hand with subspecialty. You cannot forget that basic at all, whether you are in tier 1, tier 2, tier 3. So I think we should really think that the centers which don't have that, if we have at least exposure, maybe they are not trained enough. And this is true with, you are saying the adequate number of surgeries. So answer is both the things. The adequate number of exposure also is lacking in our training for all subspecialties. It can vary, and definitely a resident will add on to that exposure, and he suddenly find these options to gain the exposure hands-on in that. And also the settlement, whether he's going in private or he's in government. So definitely he want to choose one subspecialty area where he want a proficiency. He don't just want an exposure, and proficiency cannot come in 3 years if whatever curriculum we make.
Okay. Dr. Tamboli, in which year are you presently in?
So I've just gone into third year, sir.
You've gone into third year. So, I mean, was 2 years of exposure of general urology at your institute, was it enough to maybe plant a seed in your mind that, okay, you might have an inclination towards a particular specialty? How much of work inside your institute, how much of your consultants, they were able to, have a bearing upon that thought process? And do you think that 2 years was enough? Or do you think that, no, it's too less of a time to think about a super subspecialty?
Initially, I had come into urology with expectation of going into andrology further on. Unfortunately, that exposure is not there at any such premier institute in India, much in volumes. Fortunately, at our institute, we have had a good exposure to most of the broad subspecialties. So per se, personally, I'm satisfied with whatever I've been exposed to. And yes, I have had an inclination of what to do and definitely what I would not like to do later on in life.
So how did the seed of andrology get implanted when you didn't have volumes to see at your own
My
center?
parents are infertility.
Sorry?
My parents practice infertility.
Oh, so a new perspective. We should have called your parents over here then also with you. A new perspective, yeah.
Yeah, let's move to the next point. So I think more of all of us agree that some kind of subspecialty training is required, is a need of the hour. So how should it be done? Should it be a part of the 3-year program, maybe 6 months dedicated for that? Should we add another year to MCH program for a subspecialty training? Should it be a kind of exchange program that one center is not doing transplant, the other is doing it, so the residents can go for 3 months or something? How should we go about it? Dr. Prabhat, what's your
I
idea?
think which we discussed, that if there are any subspecialties lacking in that institute, we can do exchange program. I think this is a very wonderful idea to go about that. And
Faculty exchange.
yes, faculty
Using
exchange is
faculty
also
exchange.
required.
Okay.
To some, like the Manish raised the issue of transplant. If you
Mhm.
don't have exposure as a faculty, then you can go and bring that specialty to your department. But all these, if you want to do some kind of fellow, you want to be very much trained in that specialty, I think that we need additional 1 year or 2 years, the 3 years course.
Okay.
Yes, Umesh. Umesh, can you speak in the mic, please? Mic, Vijay.
Sir, as Dr. Prabhu sir is saying that faculty exchange can be you can go and faculty exchange for the transplant programs. But sir, with due knowledge that there are transplant program cannot be run in different institutes. For example, in a UP state, you cannot label the Agra or medical college to run the transplant program. So faculty exchange is not, it cannot be possible. What we can do is that the resident can be exchanged. We can, in the second year, we can rotate the resident. We can make a pool in the state that all the residents, all the teaching DNB or teaching, whatever the centers are there, we can make a pool of all the residents in the second year, and we can rotate the residents in a group. For example, KGMC is doing or SGPGI is doing, then Agra, Meerut, Gorakhpur, these all medical colleges.
So I get your point. Sorry to cut you off, Prabjot. What's the fun of you coming to Jaipur to teach everyone or my residents a robotic when I don't have a robot myself?
It will be excellent opportunity for me.
No, but I can't offer a robot to you at SMS.
If you have, then I can come.
Yeah, I think that
But
question
if
is
the,
good.
if the institute like SGPJ is having, or whatever institute is having regional transplant, why can't I go and then learn and come back?
Yeah, exactly.
So that depends on what program are we talking about and which center we are talking about. That's going to vary from place to place.
Center to
But
center.
for example, somebody said, Nachiket said that in Jaipur, at that time they were having very basic laparoscopy when Rishi passed out. So it is possible to get somebody from outside a faculty who can do few advanced laparoscopy cases. Those kind of things are possible.
Yes.
Because you already have the setup. See, the number of residents are increasing tremendously. We have not kept that as a topic here because there is a separate discussion. But you can't keep on sending 10, 12 residents to each center for 3 months and then expect that they will be quite good and picking up things from those 3 months. So getting a faculty to come from outside and demonstrate those procedures and get the residents to assist them might be a better idea to gain exposure of that
Yes.
wherever feasible. For transplantation, it's not feasible, as he said.
Yes, I want to add one thing, sir.
Yes, sir.
I think we are talking about faculty exchange and student exchange. What I feel is this is bi-directional. We should start with faculty exchange because you see, our institute always, all institutes have some deficiencies, some part of lacunae for subspecialties. They will, until unless we make every institute capable of some sort of subspecialty exposure, if that institute take a call of exposure of faculty first to those subspecialties, unless when the faculty is trained, they cannot expose the resident on their center. So faculty exchange is bi-directional as a mentor also or as a learner also. Even a faculty can go to SMS Jaipur to learn something from them for a short while from other institutes, and similarly for the students.
Yeah, you have inadvertently brought us to the last point that we have for discussion. So how do we ensure which centers to do it? How do we standardize the process? What should be the duration of such specialty training? What should be the courses and modules? So do we need a proper certification the way it is done in European countries and US, or just a 6 months training with a certificate is good enough? So should we have a formal process like we have for MCH and DNB, or just a working experience is enough?
I think we should have some formal, some kind of curriculum, so that after finishing the fellowship, he should have some certificate, and then he can show to the, like day before yesterday, it was discussion about the certification course for robotics. So should we, at the end of the day, we should be having something which carries us and which can label us that yes, he can do that.
Okay. Yes, Tamboli.
So I would like to say that whether it is incorporated inside the 3 years MCH program or after the 3 year MCH program, it would be better if it would have been after the 3 year MCH program, so that if there is unequal distributions, like more number of people are inclined towards oncology and more want to go towards a subspecialty training where they want onco training. So suppose out of 100, 80 want to go there. So there should not be any limitation ki 80 residents are going who will work at the other centers. So it should be post in MCH in the subspecialty.
Yeah, I think that point we have already decided upon, that probably it should be post MCH if you really want to do it in a proper way.
So what do you think about the duration of subspecialty? Because I think that recently one of our faculty might go to AIIMS for a subspecialty of uro-oncology for 2 years. So do you think that, I mean...
Sir, I think 2 years is too long.
Yes, exactly.
1 year should be sufficient. In 1 year, you will, because you are already have your basic training, you just adding on to that. So 6 months to 1 year is sufficient. I think. Most of the US fellowships are also of 1 year. 1 year research and 1 year clinical.
One thing that Dr. Tamboli was saying is that there should be no cutoff of the number of people who go to a particular subspecialty. For example, out of 100, he said that if 80 want to go to uro-oncology, then, I mean, how does an institute then work from there? I mean, it cannot open up, subspecialty post for 80 people out of every 100 coming. So then, this, because again, the problem of volumes come. The number of residents which are coming out is tremendous now presently. So I don't think there has to be a capping also on the number of subspecialties, sir. Number of subspecialty
when we
sheets.
say that we want to standardize the training centers and the curricula, that will automatically mean that a certain number of seats or posts will be there, that there are 2 posts for, say, uro-oncology subspecialty or 2 posts for robotic. So only those number of persons can apply. It can't be unlimited, because the training also has to be of some quality and we cannot compromise on that. So
Ashok
Alright.
Shapan, sir. Sir, any comments about this? Anurag Yadav, sir.
I would feel that post MCH subspecial training will be better. If you do it during MCH, only the 3rd year can go. 1st year, 2nd year are busy in other things, and they are too immature. They have not even learned the basics. So 3rd year can go, but 3rd year is the time when you have to study and you get the surgery. You get to do the surgery, the general urology.
Exactly.
So they'll be too busy. And if you send all the residents within 1 year time, maybe 3 months time, then who will look after the patients? So it is better to have it after the MCH and not mandatory. Whosoever wants some specialty exposure, then he can go, and not necessarily in those MCH institutes only. There can be places of excellence like Sanjay Kulkarni, and so many people go there. So you want to learn something, but the thing is that the government or the NMC can have a certification or a fellowship program certified, recognized that this institute, maybe in private, is offering transplant certification program or fellowship. And then anyone can go and get that certificate and then start practicing.
Yes, sir. Ashok Sharma.
Yes.
Can you-
After
Practicing subspecialty, I think we'll have to leave general urology. Even if you go to a 2-tier city or 3-tier city, you'll have to say, I don't do stone, I don't do lab, I just do andrology. You may start for 6 months or 1 year, but after 6 months or 1 year, you will keep getting the patients of only andrology, and ultimately you will be practicing andrology. Because I faced this problem. I was probably the first person to go to a center where there was no exposure to urology. I used to get the IVP done in my own presence. IVP nahi hoti thi wahan par. But when people used to say, mere colleague नाराज हो गए when I refuse for appendectomy or some sebaceous cyst or some hydrocele operation or hernia operation. Say, I don't do, I am a urologist, I won't do, please go to this general. So I didn't create enemies among the general surgeons. So if you want to establish as a subspecialist or practice of exclusive subspecialty, you will have to make those general urologists as a friend, not foes, by refusing their material and accepting your material only.
Neeraj wanted to say something, then Kim Memon sir. Neeraj, pehle aap.
So we are talking about exchange program for the faculty as well as for the residents. If I can share the experience of my own institute, we have had our residents visiting some centers in North India like Nadyad and All India Institute, Delhi, PGI Chandigarh. And I happened to get the feedback of the residents, like what was their experience. And most of the residents, they were said it was okay, sort of. They were not very enthusiastic about it. And the main reason being was that it was more of an observership sort of thing. 7 days, 15 days, or at the most 1 month, they hardly get to, except for observership and knowing the protocol, there is little gained from such exchange programs. So all these things, I believe they can be very well, gained by visiting these workshops and short-term 3-day courses, which are being organized all over the country in various subspecialties. So I don't think resident at the level of the residents or the faculty exchange programs are feasible or for that matter beneficial.
Thank you, Neeraj. Kim Memon sir.
I think for a 3-year DNB or MCH course, it is mandatory to get an exposure in all the subspecialties. And for this purpose, I think the USA has 34 overseas travel fellowships instituted. And second is, out of this 3-year course, I think NMC has agreed for, I think, 1 month or 2 months of observership in different centers. So this exposure is mandatory. That is one. Second thing is, one of the drawbacks is 15 days observership in transplant is not adequate to get legal accreditation or permission to perform transplantation. You have to have a 3-year training in transplantation, and you have to be a member of the transplant team for 1 year to legally get permission to perform transplantation. So that is one hurdle which the USA has to sort it out with the NMC. But I think exposure to all subspecialties is mandatory during the time of training. Otherwise, the candidate also will not get an opportunity to decide which subspecialty he should opt for and specialize. Thank you.
Thank you, sir.
Thank you, sir.
Any final comments before we call it a day for the
Can I
session?
make?
Himanshu.
If time allows-
Yeah, Himanshu, please.
So, although the comment may be some pertaining to administrative posts, what Ankur said, like PGI is not having.
I think your mic is not on.
Like AIMS or PGI is not having transplant program running in the urology department. So isn't it the time that all the institutions in the India, medical institutions in the India should fall under one umbrella as far as the standards or the norms are concerned? Because AIMS or PGI or JIPMER like institutions who are called as Institute of National Importance, they are allowed to not to follow the NMC norms, while the other medical institutions have to fulfill the NMC norms like training, transplant hona chahiye, MCH chalu karne se pehle, all those things. So there are dual standards in our own country with the medical institutions. So till the norms for all the institutions are not equal, we can't say, like sir, when I was in AIMS Jodhpur, we started MCS training program with 2 assistant professors only. Otherwise, agar मैं medical college में होता, तो I think NMC wouldn't have allowed us to start the MCS program.
Yes.
So in the name of Institute of National Importance, we should not allow, rather.
Yes, so I think that you just touched the last part, which was standardization of training centers, and your point is well taken. Totally get your point.
Dr. Nachiket.
Sir,
I just want to just respond to what Dr. Neeraj was saying.
Please, in brief.
Actually, he said the resident exchange program and faculty exchange programs are not feasible, which I have a different opinion. But faculty exchange program, actually, you don't need to go and because the faculty have a different exposure. If you just go and observe what's happening in other centers, by that also you can get an exposure and come back and practice the same thing. So the resident, as he said, the residents, when they went back, they said it was just okay. Because the purpose of that, actually, it was not an exchange program. They just came for observation. So obviously, if somebody come for the observations and just stayed there for a week, obviously he will not have that sort of exposure and go back and actually practice that.
Yeah.
So to have a resident exchange program, it has to be a structured program, structured curriculum. If he's coming there for 3 months or something, then he has to be a part of that residency program there. He has to scrub, he has to work up the cases. So that's the way the resident
mentorship,
can
you're
learn.
saying
Yes.
that he has to be
Just by coming there for a week or 2 weeks just to observe what's happening in that center, that's not actually going to help the residents.
Okay.
But the faculty, it's different. If the faculty goes there for actually 2 weeks or 3 weeks, only observes, the faculty can pick up actually what he sees. So for
Okay.
the faculty
Yeah.
and resident, it's little different.
I'm coming to you, Nayak. I'm going to stay for 3 months now with you. Yeah. Thank you, Nayak. Thank you. Yes, Neeraj. Yeah, exactly. So I think that we're way over our time inside
Yes.
this.
So,
And
any final comments before we move?
I would like to say that what about those subspecialties, those you don't have exposure in most of the institutes, and also you don't have any sort of training modules or fellowships also that doesn't exist for that right now in India. If I say female urology, just giving example, female urology, how many institutes they have exposure as of now? How many faculties are trained in those institutes with the teaching hospitals? And a reason, if they have an interest in this field, which is really a very good field right now in we don't have even the training fellowships available right now in that, not on a single female urology from a urology department available in India right now. So what about these domain where you don't have exposure, you don't have even a training fellowship or a certified course available right now, which should work?
Yeah, that's where we need to identify and maybe frame a network, where can this be done? Yes, anything else from Dr. Prabhjot?
Even for the exchange program for the resident, I think that is a very good thing. The USA has started in 2009. I fortunate to went to the Perth as a resident training program. There because Dr. Kim was recommended my name. So I think that is a thing in which you can broaden your horizon. You can see what is happening outside your institute. It's not like talab ke daddu ban ke rahegi. So that kind of exposure is also required. You will see what are the things you can do in the future. So that kind of exchange programs are required, which USA is already doing.
Right.
Thank you, Prabhjot.
Okay. Tamoli, you want to say something?
No, sir. I would like to take home the message that less is more. So subspecialize and have good subspecialty training.
All right. Thank you very much, all our esteemed panelists. And
thank you.
You can
Thank you, sir.
Take your leave now. So we'll call upon the panelists for the next session. Dr. Pamposh Raina, he is professor at Shimla Medical College. Dr. Yashashvi Singh, he is assistant professor at IMS BHU. Dr. Ankit Tyagi, he is a senior resident at Gangaram. And Dr. Nikita Srivastav, she is a senior resident at AIMS Jodhpur. So
So now we come, can we change slides, please? Can someone change the slide? एक एक करके. So after doing your training, then the $1,000,000 question. So now that I am a urologist, what should I do? This is, I think, many times our residents come to us and they ask us for guidance, what is the way future? So how to choose and what type of decision they have to take, whether they have to join, continue as an apprenticeship, maybe inside a private, or maybe they would like to seek a continuance of their residency inside the institute where they have worked or another institute. Should they go directly into practice, or is it better for them to go into an academic institute? So Rena sir, I think we'd start the discussion with you. I am sure as head of department, many of your students come to you with this burning question. So what are your thoughts and what do you advise them?
I would like to advise them that whenever you do complete your MCH, you are not a finished product. You cannot practice. Urology is a huge subject. As we have discussed, it involves 8 or 9 subspecialties. So in 3-year training, you cannot be trained in all these things. So you have to first introspect. The resident has to introspect himself or herself. What is his or her level of training and what he or she wants to do in future. So depending upon that, probably it would be a wiser thing to work for some time under mentorship of a senior person for maybe 3 months or 6 months or 1 year as a general urologist, not as a subspecialist. Because once you are off your own, if you are stuck in a surgical procedure and if there is no one supervising you or no one above you, it is going to be very difficult. So I would recommend you first, resident has to introspect himself or herself. What are his or her strengths, weaknesses, and improve upon your weaknesses before venturing into private practice or a corporate setup.
Okay, so I remember that 2 years back, I got a call from one of my residents who had joined somewhere inside a big corporate inside NCR. And he was feeling very frustrated and said that, sir, you told me that. I told them exactly. I think that the thought process of all teachers is the same regarding this, that you still need a little bit of time to maybe polish yourself off before you think about, starting your own practice, group practice, freelancing. So this is, I think that we're all maybe on the same page regarding this. I would not still advise my resident to directly go into practice. So he said that, sir, you told me that to join with a senior urologist, and I've come to NCR and I'm just another glorified resident. So the only thing that I've been doing for the last 1.5 years is that filling files, taking consents, and he was a little not very happy with the present situation that he was, and he was asking that what should I do from here. So Dr. Yashasvi, what is your take on that?
Sir, my take would be, as I have experienced all these things myself after passing out, sir, one needs to decide his or her clinical and academic goals and personal goals. Sir. In the clinical or the academic domain comes his or her surgical proficiency, previous subspecialty training, or a desire in his or her mind to achieve something in a specialized field. In the personal goals, we have to look at a very important issue is the spouse career, children education, whether you want to live in a tier 1, tier 2, tier 3 city, you want to travel in a metro for long distances, or you want to settle in a tier 2, 3 city with your own setup where you just have to go down and take your practice. So it is about deciding what you have in your mind. And as the question of so one has to wait for his or her time and observe things patiently, because patience is the key. I myself.
How much time? This guy is in 2 years and he said that I'm a glorified. resident post
Sir,
MCH. So what time?
Sir, I am not such experienced to tell about the time, but you will have to wait for your time, and there is no point
Yes.
just crying about that.
Yeah, I will tend to agree with most of the points that Yashasvi has said, because a lot of times we don't focus on non-neurological aspects. For example, the career of the spouse and education of children, the quality of life that you want. So those things are equally important. So it's a highly individual decision-making process, what a person thinks and expects from his career or her career. So let us hear it from the young ones. What do they expect? Yes, Nikita.
Good morning, everyone. I would like to sum up the decision factors as a pentafactor, as already pointed out by our esteemed faculties. The number one is the quality of work, the hands-on, and the second thing is the mentorship, whether you want to be on your own or you want to mentor. The third one is the personal life, the time you get for your hobbies, relaxation, and time to family. The fourth one is the choice of family, as sir rightly pointed, that the choice of a spouse and children's education. And the fifth factor is the money factor, that whether you want to be on a fixed salary basis or on a professional work production basis. So these are the factors.
Why not money on top? Money get you education, money get you a lot of things. So why did you keep number 5 money?
So these are not the hierarchy, these are a pentafactor. All are equally important. We have
All
to
are-
balance
okay.
all of them.
Okay, that's not number 5 for you.
Yes, sir. And so the sixth one, which I want to add, people like me in present scenario of residence is the bond factor. There is no bond in the AIMS Jodhpur Institute in which I am currently there, but I have a leg of my MS General Surgery training in Raipur, Chhattisgarh Government College, where I have to serve 2 years bond. I already served 10 months duration during my preparation, and now the 14 months are remaining. So after I become a urologist, I have no other choice other than go to Chhattisgarh and to serve there, and where the institute and the position which I would be getting is not on my hands. So this is also a very important factor which the youngsters like me would be facing, that most of us, 80% of us are now bonded laborers. So for the initial most productive years of our life, we might not have a choice. I may be pushed to some rural CSC or PSC as a general surgeon. That is not on my hands. So this is also a very important factor I would like to bring out.
Yeah, actually, that is something which we have missed out in our deliberations, which you have brought out regarding the bond thing. But I guess there is nothing anybody of us can do about it. I mean, that's a government policy, so we have to take it as it is for the time being.
Sir, one thing I want to add, sir, the bond thing, they should not personalize it to a particular state or institute. They can make it compulsory to practice in any government institute of choice, or can include government fellowship programs also in the bond.
Everybody wants to say go to AIMS or your choice.
Yes, Dr. Pankaj. Yes,
yes.
Just a small point. So I've not experienced the bond problem in my career as yet, but I would take that as a silver lining, because that bond is going to give you the freedom to do what you want to do in your general surgical practice. For 14 months, you're the boss. Do not let that opportunity go by.
Sir, but I may not have the armamentarium, sir.
You have to improvise. You don't need a robot every time. You learn open urology. Don't tell me it's going to get relegated, right? So I did an MCH from a prestigious institution. I did a 3-year repeat MCH from another prestigious institution as a pool officer. I didn't need to, but I did that. It gave me a totally different perspective. And then I went out and I worked in a really small hospital with practically nothing. And I tested myself for 2 years. And I figured I can do everything that I need to do. I would use that opportunity.
Yeah, that's a good point, actually.
Yes.
The time to test your self-confidence, build upon it, operate independently, provided you get a place where at least you can do these things, not a CHC kind of thing. Yes, Dr. Ankit.
Good morning. Dr. Samir, I just want to add to this bond issue.
Yes.
Recently, 2 of my residents, they passed out from my institute, and one of them has to work in Kanpur Medical College and another in Noida. As the resident has pointed out, there is no armamentarium. what they are doing, just seeing the patients. So they can just see the patients, just do consultations. They don't have the cystoscope. They don't have any armamentarium. So for the first 2 years, their hands-on experience, I think that will be nil. So it's only you see consultations. Consultation is not the part of a surgeon. So that the bond issue, it's not so trivial. I think the Urology Society of India, it's a body, it's a government policy, but the USI should take lead and discuss this, because when a person does MCS, he is, I think, 30 plus, and then he devotes 2 more years to that, a kind of slavery of 2 years. So the bond issue should be taken into consideration.
I think I would just want to put something regarding the bond, and that is the bond, it is not a uniform bond, and the policy of the bond is variable from state to state. Inside my state, the bond is not enforceable because the government does not have the money to give every senior resident who passes out 75,000 rupees, 80,000. So ultimately it's diluted. This is the same situation even after post graduation, MS and MD, and also after MCH. It is, even though they get you to sign the bond, but however they don't enforce the bond. But unfortunately, it's there inside, as you said, Chhattisgarh. It's enforceable, and you have to. And as Dr. Ishwar was saying, Neeraj has a point, and then Meman sir has a point. And Neeraj.
I was just trying to say what you just elaborated regarding the bond issue. It's not enforceable in Rajasthan.
Yes.
By signing a bond, it is mandatory for the government to, when you pass out, to adjust in a equivalent position of your specialization. And that being, talking about urology, it has to be a tertiary level institution. But sadly, the government does not have that resources or, the monetary things to compensate you. So it's really not enforceable as of now in our state. And most of the times it gets diluted, and the residents who pass out from our institute, irrespective of whether they have signed the bond, they go to their place of interest.
Yes.
So
Sir, in our state of Chhattisgarh, sir, I have personally given a 50 lakh surety to them. If I would not go and serve the bond, they will take away my property.
50.
One
Okay.
more thing, sir, the administration is those sitting at the top are IAS officers. They just want a doctor to treat illness. They don't know about specializations. They
Yes.
don't know the hierarchy of MBBS, MS, and MCH. As a general surgeon, I was posted in a small CSC of Mahasamund, where there was no jelly to do per rectal examination. There was no anesthetist. There was a compounder who only gave spinal for patients for LSCS. And there were no general surgery. So we have no other option other than referring the patients. And I was just giving medications for scabies and dengue there.
Yes.
Then I was posted there was an epidemic of dengue in Bhilai. So I was posted as a medical officer. Me, a qualified general surgeon, was posted as a medical officer just for observation of the dengue patients 8 hours a day. That was only my job. I was sitting there idly and watching their monitors.
Yeah.
So actually that's not in our hand. And this is a very sad part. In such a rural states from where I belong, such as Chhattisgarh, where the enlightenment is lacking. So I don't know
Meman,
that
sir.
after doing urology from such an esteemed institute, such as James Jodhpur, I may be pushed to another CSC, PSC, and I must be writing prescriptions for scabies. So you never know.
So Meman sir wanted to make a point. Sorry, sir.
I think that's okay. I just agree with you.
I think just 2 points. One is, see, on the whole game of urology training and practice, money is also important, because you will need, if you are going to do on a solo practice, you need money for investing on resources and equipment. It is expensive these days. So you either need a rich parents to support you, or you need a rich father-in-law to support you, or you have to take a loan from a bank, and you don't know how long it will take to repay the loan. Now, these things are extremely important, but many times in the coming years, it may be even difficult to get a job in a high volume center because there are so many applicants. That is one comment which I would like to make. Second is, nowadays, a lot of young urologists are going abroad for higher training. And that again involves money for the initial part of applying. And once you get into a training job abroad, then life is much easier. And third is about the bond. I was in Tamil Nadu for an MCH exam. There the bond is 2 crore. In Tamil Nadu, it is 2 crore. And I think in Karnataka, it is 1 crore. That is the bond money. Now, how can a candidate get money for repayment and come out of the bond? It is difficult. So this is something which has to be, the government's justification is, this is the actual fees we have invested on the candidate, and we have given them subsidized fees. And therefore, this is the penalty for breaking the bond. But that needs to be discussed at higher levels, administrative levels.
Actually, that is not quite true what the government says, sir. Because it's not the money spent on the training of a urologist. You also have to look at the service that urologist has provided for 3 years during his residency. He has operated on many patients. He has done so many OPD consultations, all that for free. So he has provided services in return for whatever has been offered to him. So it's not that clear a case. Yes, Dr. Sanjay.
As far as the bond is concerned, we have to change our mindset. The policy of the government is to provide health everywhere, in every city, every remote area. So we have to look at it from their perspective, from the perspective of the WHO, like the health for all, health everywhere. So if we have done any training under the bond, we'll have to complete it. Otherwise, we have to pay. So we have to be ready to serve in that way. They don't bother whether we have done MCH or MS or MBBS. They want a person, they want a doctor of that level. Suppose they want a doctor at CHC. So they are not bothered who is MCH and who is MBBS and who is MS. So I think we have to be ready for everything once we fill up the bond. If you are well prepared beforehand, then you will not have to face the frustration. Because everybody faces this kind of a frustration if you are put in a wrong slot. So you have to see it beforehand and you have to be prepared mentally so that you don't have to face it.
Yeah. Dr. Ankit Tyagi,
yes.
I think that you're from Gangaram doing your DNB. After your DNB, 2 options.
Yes.
Continue in Gangaram as an assistant, 1.5 lakh rupees a month. Second is Taranagar Churu, 10 lakh rupees a month. No good schooling for your children, no discotheque, no restaurant. What would you prefer?
Sir, actually, I'm a resident from Delhi only. I've done my MBBS, MS, everything I've done from Delhi only.
Yeah.
My family is here, all my relatives are here. So I would definitely prefer a premium institute like Gangaram to continue. And I will try
But you're getting an opportunity in Taranagar for 10 lakhs a month.
Sir, with time.
But your quality of life is nil. No good education for you. This is actually one problem that my residents come to me and say that, okay, I have an opening there. And your money is important because I'm already 32, 33. But however, the wife is against going over there. The education is not good. There's no coaching center for my children. I can't take my wife out in the evening. So what do you think is important perspective?
I think quality of life is very important for the in the long run. Also, children's education, my personal time after I'm free. You have to think various points regarding this. I would rather prefer to stay in a city or a second-tier city also, but which should have all the basic facilities and where.
So now government has to give some basic facilities to all cities of the country now.
Sir, it's my personal choice. I would prefer.
No, we respect that.
Yes, yes.
So how do you get urology inside Taranagar then?
Sir, I think some other doctor will have some different ideology or some different.
Freelancing. What do you think about the third point? Would you be open to freelancing?
Sir, I think I will prefer, depending on the opportunities I'll get. If I'm getting a good hospital with getting adequate compensation, I may just continue that. If I'm not getting a good hospital or I'm not getting a good unit in which I want to work, then I will go ahead and will go for freelancing and will start up my private clinic also, maybe in future.
Okay.
Yes, back to the seniors on the panel. What do you feel about this, Dr. Renas?
I think freelancing is an option, but there are some medico-legal issues also involved in this. But I have seen freelancing from a very close perspective. I have worked for 2.5 years in Ludhiana in a corporate hospital. So I was not doing freelancing, but all my friends were doing freelancing. But the biggest drawback of freelancing is that at times you generally work with in the hospitals of general surgeons. So what happens is general surgeon has decided that this gentleman needs TURP. He has posted it for TURP, and you are just wandering here and there. You are about, when you are around 30 kilometers away from his station, you will just advise him on phone that when I reach your hospital, patient should be under spinal. So biggest drawback is you have not seen the patient you are operating. So that is the biggest drawback. Even if you are doing freelancing, all residents, you must make a personal rapport with the patient. You must see him preoperatively, whether he needs TURP or not, you decide yourself, rather than jump into the OT and start doing TURP. So freelancing also, I would recommend, it is not bad at all, but you should be involved in preoperative assessment of the patient. And surgery, obviously you are doing, but you must also be involved in post-operative follow-up of this patient. How you can do it, this you have to decide. But please don't do that type of freelancing where you don't have any contact with the patient in pre-op period and also in the post-op period.
Okay, thank you. Last
I
final
think
comment.
a thorough
Dr. Anwar.
discussion should be done with the junior doctors over there. Junior
I think
doctors.
everything has its pros and cons, but the best thing is put a hand on your heart and think what you want. If you are academically oriented, go to a medical college. You want to teach, you want to go write papers. If you are not academically oriented, go for practice. There you decide. If you feel yourself quite confident, then you can do an independent practice. If you are not confident, then you join a corporate hospital. In the independent practice, if you have money and or your parents have already a nursing home, then you start there. Otherwise, you go for freelancing. But follow the ethics in freelancing, as you said.
I think that summarizes it very well. And with that, we come to the end of the session. I thank my panelists. Thank you very much. And we move on to the next session. Thank you so much.
Thank you.
I'd invite the panelists for the next session, Dr. Neeraj Agrawal. He's a professor at SMS, Jaipur. Dr. Yasir Ahmed. He is an associate professor at SKIMS, Srinagar. Dr. Sahil Singla. He's a senior resident at KGMU, Lucknow. And Dr. Ajay Gandhi. He's a senior resident at Bikaner Medical College. And this is one of those controversial topics. Can we have the next slide, please? Next. When we were finalizing the program, a lot of people said that you should not keep this topic for discussion. It's not proper. And probably you should have something else in this place. But then after a discussion, we thought that probably it's time to address the issue. So we put it up here. This is regarding the performance of urology teachers. And do we need to have a mechanism, a system by which their performance can be reviewed? There should be some appraisal process and maybe some accreditation. So on those lines, we have kept this session. So,
Neeraj, would you put yourself online for a scrutiny by your students? Should there be some standardization and, that for the teachers?
First of all, thank you organizers for giving us an opportunity to speak and be a part of this very unique discussion on accreditation and appraisals for teachers. And in my personal opinion, I think accreditation and appraisals are the need of the hour, and they should be done for medical teachers. Medical education, and it is progressing at such a vast pace, and there are new developments coming in every day in and day out, and you have to keep abreast with the latest knowledge that is happening all over the world. And being a medical teacher, it is your job not only to treat the patient, but to teach your residents also. And that cannot be done unless you have accreditation and appraisals for the faculty. So I'm all for this evaluation, if you may call it in simple terms, evaluation of the medical teachers.
Okay. If you remember, we passed through the same process of the RPSC, And there used to be one senior urologist, and I guess that the majority of people, there was one physicist inside a panel, and there were two political people.
Yeah.
So do you think that it is fair enough for people who do not have, say, no knowledge or hearsay about urology to be assessing who to be made a teacher into a big medical college, say ours like SMS Medical College? Because if you remember, the chairman of RPSC, the member, they are usually political MLAs or
So you're talking about the
selection process.
selection process of a medical faculty in teaching institutions.
Yes.
So I think the procedure is more or less standardized in all the states and institutes across the country. That is, the government of that particular state advertises for a faculty post, and then you apply for it, and then there is the process of, you know, a written exam, after which you clear it, and then you appear for an interview. So coming to the interview part, I think the majority of your assessment is taken up by the subject expert, and that is what he's called in your particular branch. I remember when I appeared for my Public Service Commission examination, Professor S.K. Singh and Professor Kapoor, they were the subject experts. And contrary to what people may say about, you know, favoritism, nepotism, and, you know, political influence, all these things, I personally believe that the assessment was more or less fair. It was standard, and it was in the hands of the subject experts. The majority of the assessment was in the hands of the subject experts, and only a minority of the questions, and they were in the hands of those PSC people and the chairman of the service commissions. Okay. So, and it's not only my opinion, it's the opinion of my other colleagues also who appeared for other faculty positions. Of course, we live in a country where all these things are being talked about, and some of these things may happen. But by and large, I think the selection process is fair and standardized. That's what my opinion is.
Yes, Dr. Yasir.
Thank you, sir, for calling us here. So regarding the appraisal of the urology teachers, I feel that is the need of the hour. We should go with it. And my opinion on that is, like, bodies like USI, NB and NBMS, they should come together, make a common board. There are like national exams, JRF types and NE types. We can do that annually for urology teachers. And the more you keep those teachers in touch with the curriculum and the activity and whatever is happening in the world, the more it's beneficial for the students. Because I'm working in a tertiary care center, and we have multiple teachers there. So if you keep them in a run, they do well, and that helps the students also. Some of the teachers, with the passage of time, maybe there may be other factors in their life, so they lose a touch with the subject, and they are not interested in the academic curriculum and all those things. So if we introduce all those things in our curriculum, so that will definitely help the society, definitely help the students. So
our endpoint are basically our students.
Yes.
So how comfortable are you and your performance be appraised by our students? Forming a board is a separate thing, which I totally am with this, because, you know, the board, you should go for a, say, a reassessment of your clinicals as happening inside the US and maybe inside Europe. But our endpoints being students, how comfortable are you letting the students have a say inside, you know, your performance as a teacher?
It's a good question. Like, I can answer it. We can put up a 360 feedback. 360 feedback is, you take the opinion of your colleague of that doctor, the opinion of his senior, opinion of his junior. You take feedback from the nurse, you take feedback from the OT technician, and you take feedback from the students. And you add up and compile all of them, and then you can come with a sustainable, good opinion about that teacher, how he is doing. It should not be only the student. It should be a 360 feedback.
Okay.
So that is the need of the hour.
Okay.
Definitely.
Yes, Dr. Sahil, what do you feel?
Sir, I do think
you can talk your heart out, you know, you don't need to be worried about nobody.
No need to hold your punches.
Yes.
Sir, I think there should be some kind of assessment at least for the teachers, because many times, sir, they misses out the this academic parts and training part. Few teachers, they are really interested in teaching you, but others don't care whatever is happening out. They just come and operate their patients and go. They don't care what resident feel or what they have to teach at, because you are at an educational institute. And you have to, you are there to teach resident, you have to train them. So there should be an accreditation process, but I don't think residents are mature enough to rate their teacher to.
How much more maturity? You must be 30, I mean, so how much
But
more
still, sir,
maturity? do you need?
we will be biased.
Okay.
There will be a bias, obviously. We will favor the teacher who cares for us, who talks to us, who teach us, who give us a hands-on training.
But isn't that a part of training? That's what you should do. According to me, a resident, when he enters any institution, he is a fairly neutral person. He doesn't have any biases towards anyone. So if you find a particular teacher to be good to you, both in his behavior and nature, as well as his teaching and hands-on training, if you are favorable to him, then what is wrong in it? I mean, to me, that is perfectly acceptable.
So, but over time, sir, you will get to know about other teachers, all the teachers, or whatever happening in the institute. No? So maybe some teachers are good enough, but others maybe not.
So that is the kind of feedback that we are talking about from the residents.
So there should be some process that we can actually.
Okay.
Okay. So basically, I think that we were talking about an open system of education. An open system of education is, you know, a system which will fairly accept change for the better. So if you give feedback and we're able to inculcate or maybe incorporate that feedback, it will be better for the teacher, for the students, and subsequently we're getting from, you know, a better position as far as teaching goes. So Neeraj, you wanted to say something?
One of the issues I think that he's talking about, or the concern that he has, is the question of anonymity, you know.
Okay,
So-
I'm getting the
So you
point.
don't want to let your name out, or you have assessed your teacher, so they can be, you know,
Yeah.
hidden appraisals or hidden
Yeah.
assessments of
We
teachers,
have,
like
we
they
have this system in BHU.
like they
but
have in
it's-
the Western countries
Yeah,
also.
it's
they
not for
have.
super specialties, but
Yeah.
for MBBS and other faculties, the students are given feedback forms.
Yeah.
And they submit it, and it's anonymous, of course.
So
You
it
can't have
has to
people
be
signing.
anonymous. That's
So
right.
Sameer
So
sir,
that-
I mean, I never knew that BHU had this kind of a system. So what is the feedback that the teachers and the faculty they gave regarding this? Has it been able to like improve, you know, I mean, some, as you say, some teachers might be as.
Yeah, what I would
anything.
say is, it does not factor in directly during their promotions or other things,
Sir.
but at the back of your mind, you know that your students are going to rate you.
Okay.
So that plays a part in improving your performance.
Yes, maybe it's a mental thing that you
Yes.
feel that I have to.
It's not that they look at all the feedback forms when you are being considered for promotion.
Yeah.
But when you teach a class, you know that the students are going to assess you and they're going to give you a feedback. So you make that extra effort. to
Extra
be-
effort. So maybe it gives you that impetus that, okay, I have to improve myself as a teacher. That's a very good thing. And I think that the other institutions should
Yes.
also.
Dr. Rishi.
Well, this evaluation system actually works both ways and cuts both ways.
Yes, it does.
So whether the student is evaluating the teacher or teacher is evaluating the system, it will be a double-edged sword both ways. The issue here is that there should not be any exploitation based on this. We should actually look into how we can establish a system whereby this exploitation doesn't happen. Say
Exploitation, I mean, can you elaborate?
so if we have a system that a particular resident gets these many surgeries, definitely.
Okay.
He gets to assist these type of procedures, definitely. So basically, there is no favoritism involved in any of the surgeries or teachings
Okay.
either way. So this is immaterial how we evaluate each other. If we have a proper system whereby there is no exploitation, no favoritism, then that should suffice.
So that should, I think the point that you're making is coming to standardization of curriculum.
Yes, that's
I
what
mean,
he is
that
trying
is,
to
you
say.
have to have
Yes.
this number of
Yes.
surgeries done, this number of surgeries assisted,
So
this
if
type
we
of
have- so
surgeries
if we
are
have
done.
that kind of a system, evaluation would really become irrelevant.
So you're thinking that if we are able to standardize the curriculum
Yes.
and every individual is given, I mean, there's no nepotism in the system.
Yes.
And everybody is given the same like thing. So again, that that comes down to, is it a problem of the teacher or is it a problem of the student?
No,
The
so
student.
see, each individual would be different. We cannot have every individual working in the same way.
I think that you're
So-
sitting on the bench. You have, is it a problem of the students? Is it a problem of the
It
teacher?
is a problem of none. it is a problem of the system.
You're still
If we-
sitting
so-
on the
so
bench.
if we have a proper system,
Okay.
then we don't actually need these evaluation system either way.
Yeah,
Okay.
If I can just make a point, sir, just,
Everybody has a point.
yeah,
Everybody
Just
has
a
a
minute, I
regarding
think-
the issue.
First,
Okay.
let me see,
Yeah.
Dr. Tamboli wants to say. Take the mic.
A resident will be never comfortable criticizing his teacher. In MBBS, it is possible because he does not have a face in about 200 students. In a batch of 2 or 4, the entire batch will be sacrificed. So we will never be comfortable.
Why are you calling it criticism? We call it feedback.
Feedback? So I'll change my words.
A feedback
or
can
a
be
critical appraisal.
feedback can be good also.
Feedback.
It can
Yes,
be
sir.
bad also.
But
So
a
why-
resident will always be afraid of.
But
having the
it's an
backlash.
anonymous evaluation.
I
Anonymous.
think, I think that feeling has to go
Yeah.
from your minds
Yeah.
at some point. The residents do not have to be afraid of. their
You're not
teachers.
disclosing
That's a very
yourself.
bad thing to
Sir,
have.
but no one will like to take a chance of hurting someone's.
See,
feelings.
somebody has to bell the cat at some point of
I'm
time.
gonna
You
see
cannot
you.
continue like this. Yes, Dr.
Tamboli,
Neeraj.
I'm gonna see you. I'm gonna see you. I'm not gonna do
No,
that.
I was
man.
just trying to
Anand sir has a point. Yeah, Neeraj.
respond to what Dr. Rishi said regarding favoritism and, about residents. I mean, you have so many residents in the department. You can't, be good to all of them. Some residents are good, some are very good, and some are excellent. And I would not call it favoritism for a particular resident, but a person who is good or a resident who is good at his job always gets the benefit.
Gives the benefit.
Yeah, he gets the extra
Important point.
benefit from the
Yes,
teachers. Yeah.
Hardworking.
Sir,
Yes, sir wants to say something.
So,
I want to describe 2 situations.
Sir.
One is the real life situation. It's
Sir.
not that I'm making it up. Where this kind of evolution is also there. Now, I just, without naming, like in Sanjay Gandhi, if like you are head of department, you want to regulate that teaching starts exactly at 8 o'clock, student should come, student who is to present a seminar or case he should prepare. If he has not done, then you reprind him that you have not done the good job, should have done this, that. In who's coming late should be told that you should be in time, or who's supposed to be in the theater to do that. So, and basically it is all going to help them.
Yes.
Because that way they'll prepare better, prepare, they will do that, or they'll be there in time for things. But only some of them like it. Most of them will criticize it and criticize the teacher who is enforcing things to do that.
Okay. Yeah.
Okay. So that is also a factor, and they may keep the grudge for long.
For long.
This is also a reality. I'm
Yeah, no,
telling
this
you.
is a reality.
Okay.
So this is.
And but that teacher is not at a fault.
Yeah.
Their student is at a fault.
Okay.
Yes,
Yeah.
that's true.
Maybe the teacher sometimes may be at fault that he has not used appropriate word, which he should have avoided and should have not used the harsh word.
Sure.
But sometimes it's probably unintended, it happens. That is
Yeah.
one thing.
Yeah.
Now I give you a second situation. I am running a DNB program. Consistently, we have only 3 days a week we keep a DNB program. My DNB students, I don't know whether they are here or not, but they will vouch for it. So there is like one day there is seminar, one day journal club, and one day case presentation. So teachers have come, but the students is not there.
Yeah.
When you ask them why you are not there, so they will have some excuse. More often, if they are finally you caught him, so he's there, he is not even prepared. And then they won't answer, they'll remain quiet. And if then you say once, twice, thrice, then you think, how do you enforce that they should study?
Yeah.
Then you tell them, okay, if you don't present the case, you will not be given the allowed to come to the operation theater. Like, what can you do?
Yeah.
So like you
Exactly.
just,
Getting
even
your
if you-
point.
Yes.
but you need them, because without them you cannot do the
You
operation.
cannot. Yeah.
So even if you
So-
threaten.
Yeah, so it can't be
So-
a
So,
generalized.
Govind, we have to get Dr.
So what-
Gandhi. He has not got a
So
chance.
what I'm trying to say that now these students are DNB students are not doing the studies which for them, and somehow they have passed. So they think, oh, without study we can pass. So like this is also, then they'll say, oh, this teacher is very strict, he is doing that, but that evaluation is also not right.
Yes, yes. So it has
Yeah,
to
so
be the evaluation or the, I mean, it's bi-directional. It's so,
Yeah,
so
Dr.
we haven't
Ajay-
got Dr. Gandhi
Ajay
till
Gandhi
now.
has
Sorry,
just
we'll
not-
take comments, but he has to be included. So Dr. Gandhi has been set in a unique situation He was lecturer of general surgery. Then he did his MCH in urology. So now he became from a teacher to a student and then again a teacher. He has joined Bikaner. So Dr. Gandhi, what is your perspective upon this? So I believe that in the last 1 or 2 years, you've sailed the boats 2 or 3 times.
Yes, sir.
So your perspective on this?
So definitely the appraisal should be there.
Hmm.
I have studied in Australia who claim that their education system is best in the all over the world. They do the appraisal system, and it should be in the form of resident feedback as well as the senior person like the dean in the institute.
Yeah.
And it should be confidential. It should not be publicized that this teacher has got these remarks and this teacher has got these remarks, but should be confidential between the dean and that teacher. The dean should inform that your performance is that and you should improve that. And the performance improvement in the form of like what time he spends to solve the problems of the residents, what time he spends in the newer learning, newer teachings, and what time he spends to give the opportunity to the resident for the surgery or as well as the teaching schedule.
Okay.
So, but it should be confidential.
Okay. Yeah.
Okay.
So you were something bordering on what Samir sir was saying, that about the appraisal.
Yes.
And
Gautam wants something. Yes, sir. Please. After Gautam. Yeah.
Suppose HOD made some strict curriculum for the resident, and then they may give the negative feedback. So to mitigate that, HOD can, decentralize the things. It can be rotatory basing that for 1 year or 6 months, someone is making the curriculum for the resident or teaching schedules, then shift to some other faculty.
Decentralization, that's very important.
That should be there.
Yeah.
All things should not be at the head of the department. They should
Yeah,
be
yeah, yeah,
decentralized.
yeah.
And I
So
strongly
if
feel-
I can interrupt you, I think that you made a very important point from the perspective from a junior, because being a junior teacher to maybe a professor now. I used to think, when I was a lecturer, that there was too much psychophancy for the residents. They think that the HOD is the most important thing. Lecturer, I don't know what the hell, why you here, Sometimes when you talk to residents and, so you start to get that feeling of that maybe the psychophancy from the residents is too much towards senior faculty. I mean, I'm speaking my heart out.
So
what is your
that's
perspective on
what that's what should not be there.
So that's what you were talking about, decentralization.
Yeah,
So
things should be decentralized in the faculty, among the faculty members. And
what-
the manager should be, of course, the head. Undoubtedly, for all things, if something happening,
I think what you're saying is correct, but that undercurrent is always going to be there.
sir, because nothing is right and
Yeah,
nothing is
so-
totally wrong. We need to manage. So here, my point is, yes, the residents should give the feedback to the faculty.
Ankur,
It
before
should
that,
be
Anand sir
anonymous.
had to say something.
It's a very important thing because I'm also talking about my experience in Australia. It reminded me. See, the feedback and an evolution is very important, but
Sir.
then there should be a method to correct it.
To
If you
correct
are
it.
just doing like in BHU, it doesn't affect your promotion, then probably nobody will bother about it. Because I can tell you example. I gave a feedback for one student, like teacher give feedback and student give feedback. So then the dean called me and he was discussing about that. And then I came to know that the dean has gone into talk to the student, their family, their friends to find out what is the problem of this student. And then dean told me, this is the problem of the student. This is his personal problem.
Okay.
And so we have to help him out.
Okay.
And that day I was very impressed that he found out the problem. Then he told me that what you are doing, you have to do in this way. So that day I was very much impressed
By the
way
system of
the
the-
system is
Okay,
working.
yeah.
And same way, the students are, then I was also told that while you are talking it, you are not exactly looking at the eye of the student. You are talking and seeing somewhere else. So like lot of feedback the student has given and he
Okay.
has told me. So that day I was very,
Yeah, sir.
I was
Yes.
not even aware of that what is happening. So if you are doing the feedback and then it has to be some corrective measures. to be
Corrective measures,
taken
yes.
To improve it. The whole
Sure,
idea
sir.
should to improve.
To improve.
Sir, can I make a brief?
Okay.
Yes.
I think this feedback has to be taken in a positive sense, both by the faculty as well as by the residents. The residents, by writing the feedback, they should not have this thing in mind that I'm criticizing the teacher, I don't like him. It is for the betterment of the teacher or something that he feels is not right. From the faculty's perspective, I think it is for their own betterment. They get a valid assessment from a person that these are the areas that I need to work upon. These are the areas where I'm lacking. Suppose I'm not taking good lectures or my operative skills are not up to the mark. It is always for your betterment and they have to be taken in a positive frame of mind.
Thank
So,
you.
thank you. Ankur, last comment you want?
Yes, sir. So just to one point to add, what we are talking about, probably I think we are more talking about clinical only. Our academics, our training is just not clinical. It is clinical research and academics. And the most important part is patient care, which makes it 360-degree. Like your communication skills, your soft skills, your aptitude, only knowledge and clinic, soft skill and aptitude, we are missing somewhere.
Okay.
So I think totally it is not one-to-one feedback. It is a system feedback. I think it's a system. It is a system.
So you're saying that the para-educational thing regarding your attitude towards your student, how you're caring for your student, how you're caring for the system, that has to be two ways.
And what happens is sometimes when you take care of these 2 points in some institutes, or in all institutes, about soft skills and communication skills and way of your rearing up as a resident, which is also, that is taken something negative and it is kept back over clinical. Clinic is cutting is most important and making taken it back.
So I think that Dr. Yasser, last comment by him, we won't be taking,
now. Yes.
we're already over time. Last comment by
Thank
you,
you, sir. So I just wanted to add to the point that sir mentioned about students making mistake and all. I just want to share experience of our institute. We have 12 MCH per year. So it's very difficult. We have a big family. So what we have done, we have created a system of memo, sort of. So if any resident makes a mistake, that is undertaken by a committee. A committee is set on that, and then they decide whether we should give a memo to the student or not. So we have a system of 3 memos. After getting, if the student gets 3 memos, on the 3rd memo, he is then referred to the dean committee. Then they take a final look over that. So the system is just to keep the resident aware that if he cannot take things lightly, and then if he takes things lightly, then a memo system is there. So they are every time under a run, and they every time try to brush up themselves. So
Is there a similar system for teachers
For
as well?
teachers, yes, a memo for teachers. We were talking about accreditation of urology.
It is not there. We have an APR system there, but this 360 feedback is not there.
Okay.
Okay. All right. So we thank our panelists. Thank you so much.
Thank you, sir.
And we'll move on to the last subsession of this. And I invite the panelists for the last subsession. Professor Ishwar Ram Dayal, he is the professor and head at RML Lucknow. Dr. Umesh Sharma, he is a professor at RML Delhi. Dr. Hari Shankar Singh, he is a 3rd-year senior resident at IMS BHU. And Dr. Akbar Salim, he is a senior resident at Medanta, Gurgaon.
So the topic is deficiencies in the current urologic training and how to, next please, next slide. How do we course correct? So Ishwar, the first issue that we kept inside this is, what do you think about the present 3-year program? I think we pondered about this initially about standardization when we were discussing standardization of urology program. Do you think that the 3-year program is sufficient, or do you think that we have to change it to an extended 5-year program? Would it be a total 5-year program for urology, or would you include super specialty, subspecialty training in it? What is your thought regarding this?
And good morning, everyone. First of all, it's quite clear from our earlier discussion that 3 years course is, I think, quite insufficient.
Okay. So if you remember, sorry, I mean, just advocates, the devil's advocate, previously MCH everywhere used to be a 2-year course.
2 years.
And the quality of the MCH that we used to get 30 years back, sir, I think that it was tremendous, actually tremendous. So, I mean, then they shifted to the 3-year course. So how would you say that the 3-year course has benefited? We have great urologists coming out from the 2-year course.
Yeah, but at that time, there were few institutes.
Yes.
And the number of students was not, now the numbers has increased.
Yes.
In many institutes, like even-
urology has grown as a field. There are so many things which have been added on to urology now.
So if you remember, or you can remind, in SMS, there are a lot of seats.
Yes.
In KGMC, there are a lot of seats.
Yes.
So the quality of teaching, the hands-on experience is not you cannot cater on each and every student. Suppose you have 11 seats in a department and you are running 2 or 3 OTs per day. So I think, and in the earlier times, like in All India Institute, I think still there are 3 seats, 2 in May, June, and 1 in December. So 3 students coming, they get more experience.
I think
as
that
compared-
you've pondered on a very important thing. So instead of the next faculty, if you can introduce a student upon this. This is because I think that
The number of seats you mean?
the number of seats. This is because I think our Hari Shankar Singh, you are from IMS BHU. And how many students are there per year?
Sir, till our batch, there were 2 seats per year. Now
Hmm.
we have 4 seats per year, sir.
So do you think that when you talk to your other colleagues, do they say that the hands-on training that they're getting now that they are 4 is less as compared to 2? Because I can say this for my students that many of my students come, we have 10 per year now. And I remember the training that we were giving to 2. I remember the training that we were giving 4. And on account of government pressure, now I know the training that we are giving 10 and it's definitely deficient. So do you think that the amount of hands-on work that your colleagues are getting now that they are more, is it affecting training?
That is true, sir. The hands-on experience, what
Samir
we
sir is
get-
not going to say anything. Don't worry. He's not going to keep it against you. You speak your heart out.
Yes, sir. I know about, sir.
Yeah, sir is a great man. Yeah.
Sir, that's true that when we are 2, we get more hands-on experience, and when they will be 4, when they will be in our position, then they will be half. What we get on hands-on, they will be getting half, at least half of what we get. Maybe at that time, maybe if the number of OTs increases, they might be getting a more hands-on. But right now we have 2 OTs, 2 senior resident operating in each OT. So we have more hands-on as compared to them when they will be 4. If the number of OTs increases, then they will have a better hands-on. That's what I feel, sir.
So now you want Samir sir to increase the OTs, the tables, he has to run around for more tables inside his.
I
So
think,
that
sir,
is a very pertinent thing, very difficult,
I
if
think
you're
sir will
working
be
in
happy
hospital.
for that, sir. And,
Yeah, he'll be more than
because,
happy.
because
Umesh, your take on this.
Sir, the issue here is 3-year versus 5-year program.
Yes.
So I don't think the 5-year program is going to solve the problem.
Hmm.
So later on, you can suppose the residents will increase more in the near future. So you make the program 6-year, 7-year. That is not the issue. Issue is that urology is.
No, it's not about the number of residents, it's about the adequacy of,
Yeah.
training that they get. Are they adequately trained in 3 years or no so, or do we want to go for 5 years?
Sir, they are not going to be fully equipped with all the ways of doing the PCNL, all the ways, micro PCNL, mini PCNL. There are a lot of things which are coming in subspecialties, or a lot of things are coming now with recent technology in each surgery. Standard PCNL, mini PCNL, micro PCNL.
Mhm.
So thing is that we need in 3-year program, the student should know what are the basic ways of doing that things, and for dealing sub or more procedures, there is the fellowship programs, the 6 months or 1-year fellowship programs in subspecialty, where he can get she can get more in-depth knowledge.
Okay, Dr. Salim, sorry, sir.
Yeah.
Dr. Salim,
Yes,
students come to us and say inside first year, I'm doing nothing. I'm just making OT notes. I'm just making admissions. So practically it's still a 2-year course. And the first year, there is an unsaid rule among the residents that the first year OT नहीं जाएगा. आप बाकी सब काम करो, मतलब prep करो, ये करो, वो करो, but you will not go to OT. Second year, third year क्या करेंगे? So what do you say about this? I mean, is it practically true? Do you have an unsaid rule amongst yourselves that the first year will not go to OT?
yes, sir.
You have that unsaid rule. Even our residents say there is an unsaid rule that second year and third years bully you कि यार तू ward का काम देख. So do you think that this type of a mentality among the residents also affects your training? Naturally, I think it does. But your perspective?
Yes, sir. There is an unsaid rule that the first year is mainly for ward work and everything other than the OT stuff. So coming to this question, whether it should be extended to a 5-year program or just a 3-year program, I think anyone who is coming into residency is either in the late 20s or early 30s. So already the better time of the youth has completed. And whether even if we extend the 3-year program to a 5-year program, I don't think after the passing out resident is a complete product. even after passing out residency, there's a lot of thing to be learned. Until and unless you start practicing by self, he won't be completed.
I think,
So-
let me clarify here.
Yes.
When we say 5-year program, what we probably mean is rather than having a 3+3, MS 3 years plus MCH 3 years,
Okay.
we have a single 5-year club program.
Okay.
So would you rather prefer that, or would you prefer the current 3+3 program? That's what the
I
question
prefer
is.
the current 3+3 program because I don't think a post MBBS graduate is mature enough to decide his super specialization.
But let me commit it from the opposite side. Whatever you learned in during 3 years of your MS surgery, how much of that is useful when you pick up urology as a subspecialty later on for MCH? A
So
lot of
wait-
things that you have been taught in your MS days are of practically no use to you. So why do you want to waste time learning about neurosurgery and cardiothoracic surgery during MS?
So I won't say that it is not of any use. The basics of general surgery is, and basics of any surgery is the same. So we have to learn the basics. We have to learn the, ultimately, whatever the specialty, whatever the organ you are operating on, the basics will be the same. How to find the plane, how to deal with the hemostasis, and everything is the same. So there is basics in general surgery is a must. I don't think.
Do you think that the program of MCH that they have for 5 years, so you're saying that it's a wrong program to have?
So I won't say.
I mean,
it's a-
that is a time-tested program. Because, AIM started it first and subsequently a number of centers started it. So there must be some merit inside that program that they said, okay, so let's start after MBBS, a 5-year MCH program, which you are aware of. Do you think that there is less merit and they are, they don't get basic training? So that's why you're against that program, is it?
No, so in my personal opinion, after my MBBS, I didn't know anything about urology.
Okay.
I knew about general surgery because I had experience in my ward rounds and everything else. I never went into a urology ward during my MBBS period or into a urology OT during my MBBS period. So I won't be mature enough, confident enough to select my super specialty after my MBBS.
So not confident in urology, but confident in neurosurgery. So that is a little bit of a dilemma of thought.
Yes,
Okay.
Ankur.
Yeah, so just want to add on. See, 5 year versus 3 years, 3+3, or so basically, see, we need to understand that we are evolving. It's not that we make a decision on the based on 10 year down the line when we took a decision of 3-year program. In last 20 years, things have changed. So things have changed in many aspects, right? So I think we should take decision, keep on changing. Even a curriculum which is made for any course, we have made a curriculum 10 years back or 20 years back, we are following still there. They should be mandated, revised every 3 years. Similarly, we are the question here is, so I personally feel that the basics of general surgery, which we are talking about, are important. But does that 3 year for general surgery suffice for your basic? Why the advanced part of general surgery, which is not probably mandated for urology, can we use that 1 year or 1.5 year for your urology training to make it 3+1 indirectly? So it is basically 2+4. You will get 4 years for urology and 2 years for basic general surgery. I think this is a point of discussion and we need to evolve.
Okay.
So most of the programs which are run in USA, like in abroad, they are basically in combined programs. What I thought earlier that 5 year is for the MCH, but you are talking about MS plus MCH
Yes.
program,
Yes.
the 5 year program. So I think from that point of view, 5 year program is a good option, because in this you will have a basic surgery for 2 years and 3 years will be devoted to urology.
Yes.
Instead of 3 years for surgery and 3 years for MCS. So 1 year you are like Dr. Ankur has said it correctly, that instead of learning the higher end of other surgical procedures, you devote that year in learning the urology procedures.
Yes. Coming to the second topic, Dr. Ishwar, do you think that we should have kind of modular courses within urology? Say, predefined set of modules that these number of modules have to be covered during 3 years and they have to be assessed separately.
Yes.
Presently, we don't have such options.
Yeah, that's
but,
why the question. Should
yeah,
we have them?
This should be, actually, a person cannot be all jack of all trades. So we have to emphasize on subspecialty training. As we have discussed earlier also, As Dr. Ankur has mentioned, we are evolving. 15 years back, we required general urologist who can do general urology. Now, I think the general urology means that is synonym to endourology probably, because in a 2-tier or 3-tier city, a general urologist is usually doing endourology, URS, URP, PCNLs, and a chunk of these surgeries are being done by even general surgeons also nowadays. So we have not touched that option also. So to develop subspecialty, I think there should be modular programs like pediatric urology, transplant, uro-oncology, female urology, reconstructive urology. There should be modules, and there structured modules that there should be simulator training. There should be, as I think everyone is agreeable with that, the 5-year course that can be accommodated in that 5-year course. First 2 years you give the basic general surgery and basic urology skills, then the last 3 years in the structured program. And in the first 2 years, the student should be able to identify his strengths or his or her interests of subspecialty, and we should because now the number of seats are increasing. So as we don't need number of number of general urologists, we need subspecialist of urology. So I agree with this point. This is a very innovative.
Yes, Dr. Umesh, what do you feel?
Sir, program content as far as concerned, we need to change it from the institute level where I am as an educator, and some changes should be at the national level. As an educator, like he has said that first year by default is dedicated to ward, but in our institute, we are not doing this thing. We have divided our beds, and that has been distributed among students. So 4 beds goes to 1 student. He do all the things from history taking to examination to pre-op and then OT.
So he will assist in the
year,
OT also?
Yeah, he will.
There's
he will-
nothing
he
like
will
of
go.
the rule
Yeah.
that Salim said that, okay, first year will not go
Yeah.
inside.
That is
OT.
not the case in even BHU.
This is first-
No, sir.
Dr. Hari
That
Shankar?
is, that is not the case at all in BHU, sir.
Dr. Hari Shankar, sorry to interrupt you. You're inside your 2nd year right now?
I just ended my 3rd year, sir.
You ended your 3rd
Sir.
year. So how much of your training in your MS General Surgery did help you inside your MCH training?
Sir,
I mean, you would have assisted, say, gastrectomies, you would have assisted thyroid surgeries,
Sir,
breast surgeries, plastic surgeries.
if I
How
ask
much of that?
personally, I will definitely opt for this 5-year program versus a 3 years program. There are reasons for that. One of the reasons is that why to learn unnecessary things which we are not going to do anytime in our life.
Exactly.
Like you pointed out, like thyroid, like breast, which we are not do any time of life, like soft tissue sarcoma, thigh. We are
On
not
a
going to operate
percentage level,
anytime.
Still, my
thing-
answer is, I wanted answer on a percentage level. How much of your MS General Surgery training did you get to imply inside your MCH?
I think it would be
10%,
around
50?
20 to maximum 30.
20.
If we combine all the specialty, pediatric surgery, cardiothoracic, vascular anastomosis, maximum it will go up to 30%.
So can we have 1 year of general surgery followed by 4 years of urology? Do you think
Sir,
that is a good idea?
I think 1 year won't be sufficient for that. Maybe
Then you're going and contradicting yourself that you just apply 20% of your general surgery skills to urology, and then you say that 1 year is going to be insufficient then.
It could be more than a year, sir, because in a system like India where
1 year, 3 months.
At least I would go for a 2 years program.
You're taking into consideration the first year syndrome on 2 occasions.
Sir.
For MS surgery, the first year syndrome of only collecting samples
Sir.
and writing
Yeah.
notes. And then first year MCH again, same thing.
Yeah.
But if you have a single course, those 2 years will be combined into 1 year.
Yeah, then
First-
then this program is definitely better than that. The other thing is that already in a country like India where doctors are deficient, we are wasting lot of time in preparing for various exams at every
Doctors are
level.
deficient. At one, we just discussed right now, there are too many urologists in every year, 12 coming out from SMS, 6 from BHU. Why did you take 6 when you had 2? So.
But sir,
again,
we
you're
have a
contradicting your
deficiency
own
because
self.
we are wasting lot of time in preparing for 2 exams. Like if I go for this 5 years program, I will be saving at least my 2 years for that, because I have to prepare for one exam and just go for that.
Okay.
The third point is that many of the people, when they finish their MBBS, don't opt for surgery. Even the
Yes.
good brains who are the diehard fans for surgery, they think, why to take surgery? Don't know I will get urology or not. Better take dermatology, radiology, and have and enjoy your life. Why to
Yeah.
go for these all things? So for them also, it will be a boost that direct to have a 5 years urology program, just go for it.
I remember there used to be a time in MS General Surgery in the first year used to have Campbell's urology in hand, because he was already thinking about giving the entrance exam for different institutes at a time. So the first year used to have Campbell's, and whenever he used to have a little bit of time, he used to read Campbell's. So there was
Yes.
that time also.
Nachikeet sir, I
Yeah,
think we are
Prashant.
mixing two issues,
Yes.
5 year and 3 year, regarding, we are all urologists here, and we are retrospectively thinking like it should be 3 year or 5 year. Because when we enter into 3 year course, we don't know what I want to do. Like me, in third year MS, I opt for super specialty rotation like cardiac surgery and plastic surgery, because I don't know I want like to be a urologist. When I go to CTVS surgery, 3 months training, I come to know that it is a difficult branch. There's a very long time to come up with a patient and direct for operation, because nobody is going to give your heart for operation in your 40s of age.
That, Prashant, can be managed if we have rotation in the first year. First year may send them to
Absolutely,
cardiothoracic, send them to
So,
pediatrics,
then-
send them to urology, then maybe they'll
And
be able
after
to
my
decide.
super specialty rotation, I come to know that GI surgery and urology would be better
Would be
than
better,
plastic
okay.
surgery and cardiac surgery. So I
Sir-
think
sir
it should be
wants to
3 plus 3 is okay.
Yes, Anand sir, and then Ami sir wants to say something.
One practical problem is ignored in 5-year course.
Sir.
So that when in 5-year course, what happens? The guy is sent to the general surgery, and general surgery guy, that department also have the 3-year course. So their students of 3 years are their main baby, and this is a step baby. So the boys doesn't get that kind of exposure, and that program is not basically made for him. He just he just goes rotation. So his training is also, the training is inadequate, because he is like treated as a step child
Okay,
rather
yeah.
than the.
Sir. Amin Lal Bhatt sir wants to.
last
sir,
comments.
Behind sir. Last comments from sir.
You see, the program, at present program is invented in such a way that decides what is to be. The implementation has that gone wrong. Internship is not going on. Internship is for this purpose, that candidate is rotated in all departments, so that the boy can choose or girl can choose the specialty he wants. So that is the thing. Second one is, you see, it's not only the urology. Urology has to have, any urologist or any super specialty in surgical branch should have the basic surgical principles. And if you start directly, I'm not against it, but the thing is that pros and cons when you are thinking, then basic surgical principles. You see, when the thing goes on, when you have started laparoscopy, you are not exposed to open at all. You do only laparoscopy. When it comes to the opening up, you are nowhere. You will have to call somebody. So when we are training has to be to the basics, exposure to the basic. So train first surgical principles. It may not be necessary that he has done to all type of surgeries, but what basic surgical principles are. And then when they are rotated in all specialty, as he has correctly pointed out, I have examples in my own department. The person who was inclined to neurosurgery, when he came to me, rotated, and he chose urology and become urologist. And initial interest was in neurosurgery.
Yes.
So that's what happened.
Yeah.
Exactly.
When they join the department, the internal feeling which comes up is after seeing the full department.
Right.
Thank you.
Yeah, we get your point. Thank you very much, sir. We are already beyond our time limit, so we'll call an end to the session. But before ending the session, just an audience question. Those in favor of a 5-year course, please raise your hand. Okay, all right. Those in favor of a same 3+3 system, please raise your hand. So I think 3+3 have it right now.
Yeah.
Thank you very much, all the panelists and everyone. Thank you so much.
Thank you, sir.
कॉमन दे दो लोग
Wonderful, sir. बढ़िया. पुराने वाले तो ठीक बोलेंगे.
Thank you, everybody. May I request Professor Anant Kumar, sir, Dr. Samir Trivedi and Dr. Nachiket, please come on the dais for a moment. Anant, sir, please, sir, please. Next session. Good morning, everybody. We move on to the next session, and may I request Professor Shivam, sir, and Dr. Raman Tanwar to kindly come on the dais and start the session.
है तो
A very good morning to all of you. So again, we have an andrology session today. So this time we have tried to put the theme, which is usually not discussed in our most of the andrology sessions. So this time the theme is difficult problems in andrology. We know there are many topics which we do not know answer of. And most of the clinicians are in a state of dilemma, and we'll try to discuss these topics. So we have 3 international faculty who will discuss these 3 important, difficult topics in andrology. And this will be followed by a panel discussion, again, on a very difficult problem. There's a patients who relapse after PDE5 inhibitors in patients with erectile dysfunction. So I'm fortunate to have a co-convener, Dr. Raman Tanwar, with me, who is such a young and energetic and dynamic urologist and andrologist. So welcome, Dr. Raman.
Thank you so much, sir.
So now all these 3 international faculty will be online. So we have their video recordings, and we would request a person here to start the first international faculty, please. So Sijo. So the first, he is Mr. Dr. Sizo Parakatil. So Dr. Sizo Parakatil is Director and Associate Professor of Urology at the University of Central Florida. And one of the interesting thing about him, he was an electrical engineer before he joined his medical services and training. And that's why he is so interested in surgical techniques which incorporates technology, robotics, and microsurgery. He had his fellowship from Cleveland Clinic Foundation, and he had numerous awards and published several articles in the field of robotic microsurgery. He is editor of many textbooks. He has been the pioneer in robotic and office-based microsurgery in urology. He had some novel treatments for chronic groin and testicular pain, which is the topic today that he will present. He has been the founding board member of Robotic Assisted Microsurgical and Endoscopic Society. And so welcome, Dr. Sizo Parakatil. And please go ahead with his video recording, please.
So he may be joining online live also. So we might have some question and answer if he has joined live. So you have to, yes, video recording of Dr. Sizu Parakat. No, not this one. Yes.
I'm a urologist in Florida and have an interest in managing patients with chronic testicular and groin pain. So I'm going to go ahead and share my screen now so we can get this talk going. This is basically just an intro slide. I was an engineer before I went into medicine, so I have a real interest in pursuing technology solutions for some of the issues that we're dealing with. So chronic orcalgia, a contemporary management. Chronic orcalgia is a condition that many of us see in clinic. So the purpose of this talk is to present an outline or an algorithm that we could utilize to treat these difficult patients. I have no disclosures. We're going to go over an introduction, then the pathophysiology of chronic testicular pain, how do we assess these patients, a treatment algorithm, and some conclusions. So introduction. When we talk about chronic orcalgia, chronic stool content pain, we're talking about pain that persists for more than 3 months. This also includes post-vasectomy pain for individuals that may have pain that's going on for more than 3 months. There's no definable pathology in exam or scroll ultrasound, and these individuals who are refractory to conservative treatment options. When you look at published data, chronic CSP or chronic scrotal content pain is seen in up to 2.5% to 5% of all urology clinic visits. So what's the pathophysiology? We know from the neurology literature that in individuals, for example, patients who have chronic pain in the arm or the leg, if they have Wallerian degeneration in these peripheral nerves, that can lead to chronic pain. Thus, treatments targeting or ligating these nerves may offer benefit to patients with CSP. OKL have done some eloquent studies looking at the neuroanatomy of the cord and found that it's not that quite simple. It's not just 1 or 2 nerves running down the cord. There's a whole complex interplay of nerves running in the whole cord. So about 10 years ago, I did a study where I took about 50, 60 men who had pain like this, and then 10 healthy controls, guys who had no pain, but we were operating for other reasons. And we did biopsies on this spermatic cord. And what we found was that in about 84% of men who had pain, they had some significant changes with Wallerian degeneration in at least 2 or 3 nerves in the cord area. We saw this only about 20% of healthy controls. So this is the first paper that shows a significant structural difference between men who have pain versus those that don't. Now, the 3 primary locations of these nerve abnormalities, we call this the trifecta nerve complex, was in the cremasteric muscle fibers right around the cord, the perivasal sheath right around the vas deferens, and the posterior cord lipomas tissues behind the cord. So after we found these changes, we then did 3 human cadaver cord dissections to further validate the presence of these nerves and the location of these nerves. And again, this is the first study showing a structural difference between men who have pain versus those that don't. Now, how do we assess patients who have pain? How do we measure their impact on quality of life? Polakowicz et al. And Dr. Shosky have developed a really unique pain assessment tool called COSI. And this allows us to basically compare or assess how much of an impact of pain this pain is to these patients. It measures their quality of life in terms of how it affects their sexual function, impacts their ability to enjoy activities, and whether it impacts their ability to perform regular daily activities. It's a 12-page question assessment tool, just 1 page, and very simple, and really allows us to quantify the degree of pain that they have. This is the COSI form, and this is available for download online and in the publications listed there as well. The tool was invalidated and at multiple institutions, and this further proved that it was reliable in terms of following up patients before and after treatment therapies. We could see that there was a response to treatment and show that there was inter-user stability as well. So basically show that this is quite an effective tool in terms of quantifying pain in these patients. So now we move on to the treatment algorithm. I did a query on PubMed for keywords for chronic localgia and reviewed over 2,400 articles and basically looked at various different treatment algorithms, everything that has some evidence-based assessments out there in terms of how to manage these patients. And then we crystallized this or came down to one treatment algorithm reviewing most of these options. So here's the algorithm. Now I know this is a busy slide, but we're going to spend some time here going over the algorithm. So again, the surgical treatment algorithm is really only for patients who have failed conservative treatment options. So initially we start with obviously antibiotics, anti-inflammatories, neuromodulators, anxiolytics, physical therapy, acupuncture, all types of conservative treatment options. Once the patients have failed this, and they're interested in still pursuing treatment, they've got significant pain, that's when we switch into surgical modalities. Now, right off the bat, there's a small group of individuals, for example, those who have post-vasectomy chronic pain. Those individuals, vasectomy reversal is a very good treatment option for these individuals. And success rates range in the 69 to 100% range. So if you have an individual who's coming in with chronic pain, and they've had a vasectomy, or they have chronic post-vasectomy pain syndrome, then vasectomy reversal is a good option for these individuals. Now, let's say you're dealing with non-chronic post-vasectomy pain syndrome, so the idiopathic or pain from other causes, the general patient that you usually come across. In these individuals, we first start with a targeted spermatic cord block or ileal block. Usually there's about a 78% positive predictive value of the benefit of targeted denervation treatments to a cord block if they respond to a cord block. So a cord block is very important in terms of identifying individuals that may benefit from some of our surgical interventions. There's about 80% chance that if they respond to the block, that some of these surgical treatment options will help them. So what's the first step if they respond to a cord block? If they respond, then we would recommend a targeted or standard microsurgical denervation spermatic cord block. So the success rates with targeted or standard microsurgical denervation range anywhere from 77 to 100%. This is quite a durable response, and most patients who respond to targeted or full microsurgical denervation usually have a long-lasting effect. However, if this initial stage fails, or if they have a recurrence of pain after one of these interventions, the next step would be ultrasound-guided targeted perisomatic cord or ileal cryoablation. The success rate of this approach is about 59 to 75%. Now, the technique for cryoablation is basically we make a small incision in the groin area or the upper scroll area and replace a special cryo needle subcutaneously medial and lateral to the spermatic cord, and we ablate the nerves in this area. We can also do the same thing at the ileal nerve area higher up in the groin area if they have groin pain. Usually we get about a 70% response rate with this treatment option. If this fails, the next step would be targeted perisomatic cord and periepidermal Botox ablation or Scrotox. The success rates for this range from anywhere from 56 to 72%. For about a 3-month period. The problem with Botox is that the response is usually not long-term. It lasts anywhere from 3 to 6 months, but many of these patients require retreatment after that time period. If this fails, we could try targeted ileomiddle or iliohypogastric peripheral nerve stimulation. There are a number of peripheral nerve stimulators now, and the success rate of this range is anywhere in the 60 to 70% range. If this fails, another option is radical orchiectomy. Usually the recommended approach is an inguinal approach because there's a much higher success rate if you do the inguinal approach versus doing a scrotal orchiectomy, where patients can develop pain at the residual stump. So if you're going to do an orchiectomy, we recommend doing an inguinal approach. If this fails, there is targeted robotic-assisted intra-abdominal denervation, where we go inside the abdomen and ligate the nerves up higher up. The success rate of this is about 70%. However, there is a small risk of peripheral neurosensation where the pain can shift towards the leg area or the medial thigh area. So usually we only offer this option in limited cases where there's really no other option and the patient's really miserable. If this fails, then chronic pain management with medications, spinal and sacral neuromodulation, spinal blocks, physical therapy, acupuncture would be the best approach. And so usually in these situations, we refer the patient to chronic pain management. If the radical orchiectomy is always a bit of an aggressive approach, epididymectomy is also an option that could be offered before orchiectomy with similar success rates. But we try to do the targeted nerve therapies first before we do more aggressive extraoperative surgeries. Now, office-based target microsurgical denervation. I've always been trying to push the envelope in terms of using new technology for microsurgical denervation and somatic cord. We usually were doing this with the Da Vinci robotic system. However, one of the issues with this is cost, and it can be quite cost prohibitive, especially in our current medical environment. So at this point in time, we've also started to now use office-based target microsurgical denervation, where we use the new digital microsurgical tools to try and perform this procedure in an office-based system or approach. We've had quite a bit of success with this. We've done over 100 patients now. Initially, our outcomes showing about 75% of these individuals had a significant reduction in pain. So very similar to published data from other approaches. And we found that we're getting very comparable outcomes. Now, why is this important? The office-based approach is significantly cheaper than ambulatory surgery or hospital setting approaches, and therefore there's significant advantages to offering patients office-based surgery. We do this just with a local block and some IV sedation to make this as comfortable for the patient as possible. And what's the technique for office-based microsurgical denervation? This video illustrates the approach. We make a sublingual approach, and then we bring up the spermatic cord. It's now supported under a tongue blade. Again, this patient is just under IV sedation with a local block as well. The main steps are ligation of the premostric muscle fibers, which you can visualize here, and then some of the posterior fat component as we're illustrating here. And then we'll identify the vas deferens, have the assistant pull it over, and then ligate the perivasal tissues with care taken to preserve the deferential artery. In this particular patient, patient had a varicocele, so a varicocelectomy was performed as well. This is the same procedure now performed on the contralateral side. And it's a very, very simple procedure. Now, for many of these patients, we can do the entire procedure skin to skin, especially if we're doing one side, in about 20 or 30 minutes. So it makes it very comfortable for the patient. And since we're doing this in an office setting under IV sedation, allows us to perform these procedures in a very cost-effective manner. We do use a microdoppler to verify locations of arteries and veins, and that helps as well. But this pretty much completes the procedure. So as you can see, it's quite a simple, effective procedure. In conclusion, CSP is a challenging condition to treat, and it's seen quite commonly in urology clinics. About 5% of all patients have this, and has a significant impact on quality of life. But there is evidence-based data to support a structured treatment algorithm for patients with CSP, and I think there's a lot that we can offer these patients. So with that, I'll conclude. And again, I want to thank you all for the opportunity to present to you. And if you have any questions, you can always reach out to me directly. My email is sijo, it's sijo @avantconstitutional.com. Again, thank you for the opportunity, and look forward to meeting many of you in person in the future. Thank you.
Thank you very much, Sizo Paraket. He is in United States. He will try to be online at 1 a.m. in United States.
Can you guys hear me?
But still he wants, yes. So Sizo, are you there?
Yes, can you hear me?
Oh, wonderful, wonderful. Thank you very much. So we have a full hall here, and if I have a question, I will just let you know. Anybody, if you have any question, please, you can go ahead. In the meantime, I would ask Sizo,
you said that if you do a microsurgical denervation and then if it fails, then you probably would do a neurolysis or radiofrequency ablation, and then probably at the end, a robotic intra-abdominal nerve ablation also. So do you think after even microsurgical denervation, all these methods can help?
It can, especially if you do the targeted denervation. So initially after the cord block, we start with the targeted denervation. So that way there's very minimal side effects, very minimal hydrocele, lymphocele formation. And so because it's so targeted, I think that's why cryoablation and Botox have a place after a targeted denervation. Now, if you do the full-blown aggressive, micro denervation, and you cut most of the cord, what's interesting is I still have individuals who respond to Botox and cryo. So there may be some nerves outside the cord that we're targeting. So yes, I think there's still some benefit to these accessory techniques.
Thank you, Sizo. We have Dr. Rishi in the audience. He wants to ask a question. Please go ahead.
So a lot of these patients also have any other psychosomatic somatic kind of disturbances. So does this cord block also help in those kind of patients? How does it differentiate whether it is a psychosomatic disorder only or there is some organic cause in the cord?
So usually by the time that these patients come to see you, they've usually been through several urologists, because by the time they reach me, I'm usually like the 6th or 7th urologist. They're getting multiple opinions. They've had lots of imaging. So you're right, there is some psychosomatic component, but if they respond to a cord block and they feel a lot better, then I think that, there is some nerve basis to it. And part of the psychosomatic situation might be because there's a lot of frustration, there's a lot of self-doubt, and so many of these guys, when we do a really nice cord block under IV sedation, if they get relief, it's really dramatic. I mean, they really feel like, well, maybe somebody's listening to me. But you're right. I mean, there's definitely, it's when you're dealing with patients with chronic pain, right? It becomes a bit of their kind of syndrome, right? They're focused on this all the time and everything. And so, but I do use the cord block to kind of differentiate who might benefit. There's some individuals that have had so much chronic pain, it's become such a part of their life that even when I do the block, it doesn't seem to help. And I tell these guys, if the block doesn't help, then there's no need in pursuing, some of these target therapies.
Right, Sizo. My co-convener, Dr. Raman, has a question for you. Please go ahead, Raman. Yeah.
Hi, Dr. Sijo. It's a pleasure to, again connect with you. Thank you for waking up till 1 in the night without wasting much time. My simple question is, now a patient comes to me, he says that I have pain and we're looking at denervating him. Now, what should I counsel him about as a side effect of it? In the sense that, should I be telling him that if you have a lesion later on, you will not know about it, you'll have to be more careful about it, you have to keep doing your TSC, the testicular self-examinations. What else do you, counsel the patient about? Because I think doing it is one thing, and then, so please, if you could enlighten.
Yeah, so some of the side effects are, usually they're not going to have a numb testicle. So if they get kicked there or they get a malignancy in the future or infection, they'll still have full sensation of the testicles. So it's not going to affect them that way. But one thing I've noticed is that the testicle does lower down by about 1 inch. So it's very important to let them know that since we're cutting the cremasteric muscle fiber, that's going to hang a little bit lower. And I think it's really important to say that because I have seen 1 or 2 guys that got upset that it kind of starts hanging down lower, and I've heard one individual who came to see me, he had a denervation elsewhere, but then that became the focus, because then he was like, well, I didn't know that my testicle was going to hang down lower, and so we ended up doing a scrotoplasty on him, and so there's definitely some psychosomatic issues, and these are guys that you had to be really careful with, and so I tell them right away that, hey, things are not going to look normal down there. It might hang a little bit lower. So, what's more important, the pain or how it looks? And so, I kind of have a little bit of that discussion so that, it kind of protects you, with that issue.
Thank you, Sizo, very much. We do not.
I'll take one.
Okay, just go ahead. Brief.
Thanks.
Yes.
Yeah. Thanks, Sijo, for an excellent talk. A very quick question. You get younger men with chronic alcalgia, and you're looking at doing a denervation versus preserving their fertility status. Do you change your algorithm there? I didn't notice the age range of patients that you were doing. And one of the concerns that we have when we're doing a complete denervation is affecting their fertility status. What do you change? How do you manage that?
So that's why I really push for the targeted denervation. So this really protects the individuals because we're just cutting 3 areas, just taking the cremasteric muscle layer, the perivasal sheath, but preserving the vas, and then the posterior fat component. So when you do it that way, it should not affect the fertility at all. And many of these guys, if they have a concomitant varicocele, I'll fix that as well. So we've got some data, about 300 or 400 patients that we did denervation and varicocelectomy on. And these individuals actually had an improvement in their testosterone levels and improvement in their sperm parameters. So the targeted denervation is really safe. And we've got data that shows that it actually protects their fertility. So you can do all age ranges. We've got 3 age distributions, generally young kids in their 14, 15 till young teenage years, young guys in their 20s to 30s, and then some older men in their 60s to 70s. So it's kind of an interesting distribution.
Thank you, Sizo. Thank you very much. And thank you for sparing your valuable time, and that too past midnight. So thank you very much. So we move ahead with the second topic, which again is a very difficult treatment in a case of premature ejaculation, how to manage PME beyond SSRIs. And for this, we have Dr. Egezen Serefolu. He has already joined online. He's from Turkey. So welcome, Egezen Serefolu. So we will move ahead with your video recording, please. Go ahead.
Thanks so much.
Thank you.
Invitation to participate to Urological Society of India meeting. And in the next 15 minutes, I will be mentioning about management of premature ejaculation beyond SSRIs. After a brief introduction, we will be summarizing current treatment options, and then new treatments, which are not SSRIs, will be summarized. Let's start with introduction. Ejaculation is the expulsion of semen from the urethral meatus, and it has 2 phases. Phase 1 is emission, is basically the ejection of semen into the posterior urethra. And then phase 2, expulsion, it's the ejection of semen from the urethra. In this slide, you can see the basic physiology of ejaculation. When the sexual intercourse happens, those stimuli is taken to L3, L4 spinal ejaculatory generator via the ventral nerve, and then it's transferred to the central nervous system. Once the inhibition over ejaculation is removed in the central nervous system, the same pathway is followed, and then ejaculation occurs. There are 2 centers which are very important here. The secretory center is responsible for the emission process, and then the mechanical center is responsible for expulsion. Whenever this reflex is sooner than expected, we are talking about a very common problem, which is premature ejaculation. It affects 3 to 30% of the male population, according to the definition used, and it is classically cited as the most common form of male sexual dysfunction. We know that it causes important psychological problems such as diminished self-esteem, anxiety, embarrassment, and relationship problems. Nowadays, there are 2 most common treatment alternatives for premature ejaculation. We can either inhibit the sensation of the flancid penis via topical anesthetics, or we can increase the serotonin activity inside the brain, therefore increase the inhibition over ejaculation reflex. And there are some other alternatives which I will be summarizing now. Topical anesthetics are the first treatment suggested for premature ejaculation. Lidocaine plus prilocaine containing sprays, gels, creams are commonly used for the treatment of PE. They are moderately effective in delaying ejaculation. However, they have the risk of penile hypoanesthesia, transvaginal absorption, resulting vaginal numbness, and female anorgasm. However, current guidelines recommend their use. Over the past 20 to 30 years, the treatment of choice became antidepressants, and many SSRIs are being used for the treatment of premature ejaculation. Dapagliflozin is a special SSRI because it's the first compound specifically developed for the premature ejaculation. Its unique pharmacokinetic characteristics, which is fast absorption and fast elimination, makes this molecule a perfect drug for on-demand treatment of premature ejaculation. Today, level 1A evidence exists to support the efficacy and safety of on-demand dosing of dapagliflozin, and it's the only approved medication in European Union in addition to topical anesthetics. However, there is no FDA approval. Many studies demonstrated its efficacy and safety. However, in spite of these beautiful pharmaceutical company-supported clinical trials, post-marketing studies demonstrated that significant amount of patients do not want to take drugs to delay their ejaculation, and those who initiate the therapy discontinue this therapy after 1 year. Approximately 90% of the patients are dropping the treatment. And the reasons for treatment non-acceptance and discontinuation are effects below expectations, cost of the medication, side effects, loss of interest in sex, and lack of efficacy. PDE5 inhibitors are the third group of medications, conventional treatments for premature ejaculation. Sildenafil, vardenafil, and tadalafil have been used for the treatment of PE. Their results are conflicting. However, currently available systematic reviews and meta-analysis revealed that PDE5 inhibitors are effective compared with placebo, and patients report better satisfaction due to increased confidence, shorter refractory period after first ejaculation, and harder erections in the second or third intercourse. Tramadol is the fourth medication, oral centrally acting opioid analgesic. It's also indicated for the treatment of moderate and severe pain. Its efficacy in the treatment of PE is reported. However, it's not recommended due to the risk of addiction. As you can see, the currently available treatment options for premature ejaculation is not that effective, and there is currently ongoing researches to identify optimal medication for the treatment of premature ejaculation. And these are the recently suggested treatment alternatives. DA8031 is a potent SSRI developed in Korea, and it has been associated with a significant delay in ejaculation latency, and its clinical trials are currently going on. GlaxoSmithKline also developed a molecule which is a 5-HT1A antagonist, because we know that 5-HT1A receptors are associated with facilitation in ejaculation. So if we can block those receptors, then we can delay the ejaculation. The authors managed to demonstrate statistically significant delay in ejaculation latency, and they have presented their data in the AUA and EAU meetings. However, they did not publish their data in the form of an original article yet, and we look forward to reading more about this molecule, GSK95819. Glass penis augmentation with hyaluronic acid is another minimally invasive but still invasive treatment option. Although the authors reported that it's a safe and effective modality to reduce sensory of glass penis, there is not a lot of data to support this idea. However, many studies show 3 to 5-fold increase in ejaculation latency, and 5-year follow-up studies also demonstrate long-term efficacy. The clinical data about glass penis augmentation with hyaluronic acid have been recently published, and the authors injected 2 milliliters of hyaluronic acid in the shown fashion to the glass penis and the corona of the glands. And in a crossover design, double-blind placebo randomized clinical trial, they managed to demonstrate that the hyaluronic acid injections are associated with a significant ILT increase starting from first month, and then the efficacy can be observed up to 9 months. However, as I have said in the beginning, glass penis augmentation is not without risks, and many of those patients are reporting recurrence of premature ejaculation, glass pain or paresthesia, edema, and hematoma, scar formation, and wound dehiscence. Modafinil is another agent which is used for the treatment of premature ejaculation. However, it's a vague promoting agent, and exact mechanisms for its efficacy are still unknown. In an animal study published in 2010, modafinil is initially demonstrated to be effective in delaying ejaculation. And of note, the greatest delay in ejaculation was observed in animals with shorter baseline ejaculatory latency. So it can be more effective among patients who are having very short ejaculatory latencies. In a clinical trial conducted by our research group, we have included 55 lifelong PE patients, and we have demonstrated that modafinil administration before noontime was associated with a significant delay in ejaculation latency, and the patient reported increased in mean self-estimated IELTs, and they have also improved patient-reported outcome measures. Alpha blockers are also being used for the treatment of premature ejaculation. As we know that ejaculation is a sympathetic spinal cord reflex, this reflex can be delayed by alpha-1 adrenoreceptor blockers. Several authors reported beneficial effects. However, current data is confusing and conflicting. The most effective medication in delaying ejaculation among alpha blockers is silodosine. And our Japanese colleague, Dr. Sato, has demonstrated that silodosine administration is associated with 3-fold increase in ejaculation latency. So he suggests using silodosine for the treatment of premature ejaculation. And also silodosine administration was associated with improved patient-reported outcomes. Oral oxytocin receptor antagonists have also been used for the treatment of PE. As we know that oxytocin facilitates ejaculation, blocking oxytocin activity may be associated with delay in ejaculation. The first oxytocin antagonist which has been developed was apelsiban, and in a double-blind, randomized, parallel group, placebo-controlled, stopwatch monitored phase 2 multicenter study, the authors assessed its efficacy and safety. And unfortunately, apelsiban 50 milligram and 150 milligram were well tolerated, but they were not able to establish a clinically or statistically significant change in men with premature ejaculation. The authors suspected that lack of efficacy is due to the big structure of apelsiban. So some other researchers developed smaller oxytocin receptor antagonists which can penetrate to the central nervous system and can exert their efficacy there as well. So cligosiban was developed in Pfizer laboratories in Sandwich, and it was acquired by another company in 2013. Two clinical studies have been recently published in 2019, and in those studies, the names of the clinical trials were PEPIX and PEDRIX. In the PEPIX trial, the authors were able to demonstrate a significant increase in ejaculation latency, twofold. However, the other trial, which was PEDRIX, the authors could not demonstrate a statistically significant delay in ejaculation latency. This conflicting results can be explained with few differences in methodology, because the authors, the subjects in the PEPIX trial were allowed to increase the dose by themselves. So when they increased the dose, probably they felt like that the efficacy of the drug is better. However, the PEDRIX patients had stable doses from the beginning, and they could not achieve any significant delay in their ejaculation. Botulinum toxin A injection is another treatment alternative that our group has introduced. Since ejaculation is a reflex, injecting Botox to the muscles which are involved in this reflex may paralyze those muscles and may cause a delay in ejaculation latency. We have tested our hypothesis in rats, and we have injected Botox into the bulbospongiosus muscles of those rats, and we have demonstrated a statistically significant dose-dependent delay in ejaculation latency of rats. Another group from Turkey also showed that Botox injection may delay apomorphine-induced ejaculation in male rats. Considering the promising results of our animal studies, the company which produces Botox initiated their clinical trial. Although they have never published their outcomes, they put their results on clinicaltrials.gov. And if you look to the graph, you can see that some doses of botulinum toxin A was effective in delaying ejaculation until 12 weeks. So we seriously look forward to reading more about these outcomes when they are published in the form of clinical data. Another research group from Israel tried neuromuscular electrical stimulation for paralyzing those muscles which are involved in in premature ejaculation. We use those neuromuscular electrical stimulation in the treatment of muscle weaknesses and neurological disorders, and also we use those neuromuscular electrical stimulation for the treatment of several urological problems such as lower urinary tract symptoms, stress urinary incontinence, and erectile dysfunction. So the technology has been developed in 2014, and the first paper came out in 2018, and the other papers are coming out. In 2019, our research group tested its efficacy in the treatment of premature ejaculation, and we have demonstrated that mean masturbation ejaculatory latency time values increased 3.5 folds under transcutaneous electrical stimulation, and the other paper is going to be published soon. So in conclusion, physiology of ejaculation is complex and incompletely understood. Current medical treatment offers several effective options such as topical anesthetics, SSRIs, clomipramine, PDE5 inhibitor, and tramadol. There are many more in development and trial, and continued research will identify mechanisms which control ejaculation and serve to identify new therapeutic targets for premature ejaculation. Thank you so much for your attention.
Thank you. Thank you very much, Egezen Serifolu. He was from Istanbul, Turkey, is online with us. Sorry to have missed your introduction. I will just introduce. Please, the introduction slide, please. So he is presently the professor of urology in Department of Urology at Biruni University, Istanbul, Turkey. He also had a research fellowship at Tulane University, Department of Urology and Andrology at New Orleans, United States. He received many awards, which includes Amsterdam Young Scientist Award in 2012 and European Society for Sexual Medicine Award for Excellence in 2018. And he presently is the editor-in-chief of International Journal of Impotence and Research. So thank you very much, Egezen. So we will take 1 or 2 questions only. If anybody has, go ahead, Shailendra. Yes. Yeah, go ahead. Go ahead. We can hear.
Paralyzing the muscles, whether it delays ejaculation or causes anejaculation, but with the orgasm, as we say, it is a mental or the brain mechanism. By locally paralyzing, it really gets the patient has a sensible delaying of ejaculation, or it is the orgasm come and it is an ejaculation only.
So, Egezen, did you get the question? The question was that if you inject Botox in the bulbospongiosus, it may probably cause an ejaculation or delay in ejaculation, but the orgasm probably would not be delayed.
This is an excellent question. To be honest, we don't really know the exact answer until we have seen the clinical data. However, we have experienced that in our animal studies, those animals were keeping on having intercourses, and they were showing orgasm-like behaviors in our animal study. And in my very short, very limited clinical experience, my patients were not suffering from any orgasmic difficulties, any orgasmic problems, but they were complaining about the lack of force in ejaculation, because when we were paralyzing those muscles, the intraureteral pressure, which is necessary for the expulsion phase, was not there. So the patient was dripping the ejaculate, and they didn't like that one. So this is the thing that we should be warning about our patients. But I have none of my patients experienced any sort of orgasmic difficulties. But we know that bulbospongiosus muscles are also involved in the orgasm feeling. So we definitely need more data.
Yeah, thank you, Egezen. Yeah, so because orgasm and ejaculation are 2 different physiological phenomena.
Absolutely.
So, right. So a very good question. Any other question? Otherwise, I would just have a query regarding there are some studies which show selective neurectomy or cryoneurolysis or radiofrequency ablation of the dorsal nerve of the penis. Do you think they do work?
I have no clinical experience about that. I did not put those slides on purpose because the societies that I am involved, such as International Society for Sexual Medicine or European Association of Urology, guidelines do not recommend the use of the application of those neuromodulation techniques, because cutting a nerve is irreversible, and it may permanently damage the erection physiology and ejaculation physiology. So the patient may actually gain 2-3 minutes of extra time while he is ejaculating, but he can lose the sense of penis forever. Several studies from Russia, Ukraine, and China demonstrated that cutting those nerves selectively may actually result in excellent outcomes. But again, cutting a nerve is a serious decision. And prior to doing such an irreversible surgery, we have to have more data about that.
So thank you so much, Dr. Egejan. I missed you because you were supposed to come to Bangladesh. We were supposed to meet, but it's still good. I just wanted to share my experience around it, that the neurectomy, when you do it very close to the corona, when it's going down towards the urethra, there, if you remove the fibers, if you cut them with a gap of say about 2 to 3 mm, then you can give 30 to 40% of patients what they really want. This is coming from my personal experience only. And another small comment was that if you could try the creams first locally before we do the injection of the fillers, that can be a very good test to understand if the patients can benefit from the fillers eventually. So that's something that we'll share about when we meet again, my friend. Thank you.
Thank you. Thank you very much, Egejan. It was really nice of you to have joined online from Istanbul, Turkey. Thank you very much. So
it was my pleasure. Thank you so much for your warm invitation. And really, I look forward to being there physically and have such fruitful discussions face to face. Thank you.
Thank you, Egejan. We'll just look forward for that physical meeting. Thank you. Yeah. We'll go ahead with our next talk, the last international faculty talk. This is from Carlo Betocchi. So he will be speaking on regenerative medicine in andrology. Again, we know there are a lot of dilemmas in the treatment part also. So let's hear from him. What's the future of andrology treatment? So Carlo Betocchi, he is Associate Professor of Urology. He is from Italy. He is presently the President of European Society of Sexual Medicine, and he's director of the Department of Andrology and External Genital Surgery. And he's also the board member of EAU, ESAU. So welcome, Carlo Betocchi. Let's have his video recording, please.
Dear colleagues, dear friends, it is my pleasure to be together to talk about regenerative medicine in andrology today. And I'm very pleased to do this on behalf of the European Society for Sexual Medicine. What is regenerative medicine? It's a process of replacing, engineering, or regenerating human or animal cells, tissue, or organs to restore or establish a normal function. And this is very much applied also in sexual medicine, and we are going to see today something about erectile dysfunction mainly, but also infertility. The hot topic about regenerative medicine for erectile dysfunction are platelet-rich plasma, low-intensity extracorporeal shockwave therapy, amniotic fluid matrices, and stem cells therapy. With regard of infertility, we will discuss about stem cell therapy. As you know, there are different causes for erectile dysfunction, and the most common is definitely the age. But in this webinar, I will present also studies about erectile dysfunction induced by diabetes mellitus and cavernous nerve injuries. The first leads to a severe damage of cavernous endothelial function, a decreasing of smooth muscle content, and neuropathy under hyperglycemic conditions. The cavernous nerve damage leads to a double consequence: the antagonist effect on the sympathetic nerve, which makes the penile cavernosal smooth muscle diastolic disorder, and the neuronal Wallerian degeneration of the major periodic ganglion and the cavernous nerve, which is the cause of fibrosis in the corpus cavernosus. Although first-line therapy of treatment is highly effective, some patients require a second and a third-line therapy. So the first example is the platelet-rich plasma, or PRP, that is autologous blood plasma rich in many growth factors, having the role of improving erectile function. But how does it work? First of all, the VEGF-induced erectile function recovery appears to be mediated through the endothelial nitric oxide synthase pathway. Then secondly, the growth factor promotes cellular interaction with some kind of differentiation and proliferation of some localized mesenchymal and epithelial cells, which lead to a connective tissue regeneration. In some crushed bilateral cavernous nerves, improves intracavernosal pressure, and preserve the myelinated axons and reduce the apoptotic index. But on the other hand, there are some limits in this kind of treatment, and they are mainly due to the extensive clinical studies that are still required to support this therapy condition. And the current AUA guideline states that the PRP therapy should not be offered to men with erectile dysfunction unless administered within the context of an institutional review board approved experimental research protocol. So basically, they are allowed to do only for research. And finally, the last point that is a limit is the cost of this treatment that is still quite high. Low intensity extracorporeal shockwave therapy is a second kind of treatment. And as you know, shockwaves are used and delivered to the corpora and the crura of the penis using the probe. And there are different protocols and different numbers of waves that you can use. But basically, although there is still not a protocol of the number of sessions, usually this treatment has a duration of about 10 weeks. But how does it work? We know that shock waves cause microtrauma. Microtrauma stimulates the release of growth factors, such as vascular endothelial growth factors, and these lead to an angiogenesis, so the creation of new vessels that may improve the blood flow into the penis. So an upregulation of neuronal nitric oxide synthetase, which can also be responsible for the improved erectile function. And we can have also a stimulation of the recruitment and activation of stem cells. And finally, there could be a synergistic effect of PRP and low intensity shock wave demonstrated in order to ameliorate the erectile function in our patient. Currently, we know that ESWT exists and they've shown no adverse effects and also no complications in literature. But there are some limits, again, due to the significant effect of shock wave on nerve regeneration in erectile dysfunction pathophysiology, and also with regard of more clinical studies required in order to make a better standardization of this procedure in terms of a number of sessions and number of waves to be distributed to our patients. Another treatment that we can discuss about is the amniotic full matrices, that is a day-directed human amnion or chorial membranes, a source of implantable neurotrophic factors and cytokines. So how does it work, the treatment? Implementing as a wrap around the neurovascular bundle during radical prostatectomy. This has been described, first of all, by Patel and other colleagues in 2015. And the results was very good and very attractive because basically they found that these wraps put around the neurovascular bundle, put in 58 patients, basically they have in a period of more or less 4 months, they have a good numbers in terms of return to potency, but the only problem was that the number of patients was really very small, and so they designed to repeat this study with a bigger number of patients, and the studies are still going on. There are some limits in this treatment, and the limits are that randomized controlled clinical trials are needed to further advance this new and novel technology. In the last 30 years, stem cell therapy has emerged as a promising regenerative option due to its ability of proliferation and multi-differentiation into specific cells to repair damaged tissue. Stem cell therapy involves isolation, subculturing, and proliferation, followed by sorting and finally delivery of stem cells at injury cavernous nerve and post-treatment assessment. Recently, numerous studies revealed that the transplant stem cells exert treatment effect through paracrine secretion, delivery of microRNA or other proteins within vesicles, and synergic collaboration between different stem cells. There are many kinds of stem cells, and the most involved for the property are the mesenchyma, the adiposities, and the endothelial stem cells. How do they work? Paracrine effect is a form of cell-to-cell communication which consists of releasing growth factors and functional cytokines from stem cells, which is the principal underlying mechanism of erected tissue regeneration through stem cell therapy. It was demonstrated in different studies that all these bioactive factors improve the MED by stimulating the recovery of damaged tissue and vascular injury through chemotaxis, activity, neoangiogenesis, antifibrosis, stimulation of growth factors, and decreased apoptosis of other cells. An example of paracrine effect is shown by the study where in the diabetic rat model of cavernous injury induced erectile dysfunction, the injection of adipocyte-derived stem cells into the corpus cavernosus improved erectile function. And this effect was attributed to the secreted factors rather than differentiation into different cell types. Recently, many researchers focused on the effect of mesenchymal-derived exosomes of for erectile dysfunction. What are the exosomes? They are membrane vesicles secreted by muscle cells containing proteins, mRNAs, microRNAs, and which regulate intracellular signaling pathways. The results, as you can see, was demonstrated with a decrease in apoptosis corpus cavernosus loose muscle cells and improvement of erectile dysfunction in diabetes mellitus rat model. And the co-culture is a cell cultivation where two or more different population of cells are grown with some degree of contact between them, feeding and stimulating each other. Some previous multiple research studies reveal that the combined transplantation of mesenchymal stem cells and endothelial progenitor cells is more effective than single-cell transplantation for cardiovascular disease. In this study, endothelial progenitor cells have been applied in co-culturing with mesenchymal cells, and EPC have been proved to participate in angiogenesis and microvascular neovascularization, as well as serve as a trophic mediator for MSCs engraftment with paracrine semen. The synergic effect results is a greater improvement of the erectile dysfunction, and this probably will lead to a new start point for future studies. These are the stem cells most involved in the recent studies for stem cell therapy. Mesenchymal stem cells can be obtained from not only connective tissue and mesenchymal, but also from almost every tissue. Instead, adipose-derived stem cells are mesenchymal stem cells with multidirectional differentiation potential. Compared to other stem cells, ADSCs have a lot of advantages, such as a huge storage, easy to isolate, high speed of proliferation, and low homogeneity. Endothelial progenitor cells are mononuclear cells circulating in the blood and participating in vascular repair. Although diverse stem cells were applied, the mechanism behind this approach was very similar, including improving vascular injury, recovering the smooth muscles, restoring neuronal cells, inhibiting the generation of inflammatory cytokines, and also decreasing the apoptosis in the corpus cavernosum. Main limits about stem cell therapy are the ethical issues and the tumorigenicity due to the risk of chromosomal integration, which leads to malignant transformation, and the low transfection efficiency and some kind of lack of evidence in humans. And for this reason, we talk about stem cells 2.0, the spermatogonial stem cells that are quite used in the infertility. The spermatogonial stem cells are a subpopulation of type A spermatogonia located at the basement membrane of the seminiferous tubules and they play a pivotal role in spermatogenesis. So the skill are that they can acquire a pluripotency, and they could be utilized by loading essential factors which a control release mechanism to stimulate the testis Nike. Several new technologies have emerged in the past 25 years that may allow patients to use their cryopreserved testicular tissue to produce sperm and have biological offspring, including spermatogonian cells, sperm cells, transplantation and derivation of germ cells for induced pluripotent stem cells. So basically, they have a potential to colonize the testicular niche and regenerate the spermatogenesis. In fertility preservation centers that provide testicular tissue cryopreservation services, approximately 20% of testicular volume from one testis is typically biopsied. Hence, the number of spermatogonian sperm cells obtained from small biopsies of prepubertal testis could be a limiting factor in the successful application of this technique in the clinic. One way to overcome this limitation is to isolate and enrich spermatogonian stem cells from the testicular biopsy and expand the numbers in vitro before transplantation. So characterization of human germ and testicular somatic cells through single-cell RNA sequencing may help shed light on additional factors or signaling pathways in human spermatogonial stem cells that might be manipulated in culture to promote this kind of technique. In conclusion, stem cell therapy is a new horizon in regenerative medicine, and in particular by combination of different kinds of approaches already used, such as PRP and low-intensity shockwave. Thank you very much.
Thank you very much, Carlo Betocchi. He has not been able to join us live online. So definitely regenerative medicine is probably the future of medicine. And thanks, Carlo, for giving us an update on this medicine in both management of erectile dysfunction and male infertility. So now I would invite our co-convener, Dr. Raman Tawar, to start the panel discussion. Dr. Raman.
Thank you so much, sir, for the opportunity again. And I would like to, without wasting much time, because we just have 20 minutes and it's going to be an exciting discussion. So I want to invite all our esteemed panelists, Dr. Ajit Saxena, sir, Dr. Vineet, Dr. Manu. Aditya is with us live, so we can hear him out virtually. So hi, Aditya, thank you for being around. So I would like to introduce our esteemed panelist. Dr. Ajit is a very, very senior consultant in andrology. We know him from ages working on and talking about sex. So what he typically says is sex and Saxena is how he introduces himself. So then Dr. Vineet is again a very senior andrologist, and he's been working in SCM Hospital and also at Dios Hospital. And he's been a panelist for the male infertility guidelines for the USI. Dr. Manu, a very, very dear friend, senior consultant andrologist running an IVF center. So somebody who's really working into andrology and at Gangaram Hospital and GRIPMA. And Dr. Aditya is associate professor at PGIMER Chandigarh. He's running the clinic there for men's health and andrology. So somebody from the institute as well. So I want to introduce the scenario of a 30-year-old gentleman. He works in a corporate firm with a 9-to-9 job, the common patient that comes to us. He's been married for the last 2 years and been on treatment, already visited 5 sexologists, 2 urologists, and finally comes to you for his advice. Now, typically when you ask him, he says morning erections are there, off and on. The erectile hardness score is 2. When he takes tadalafil 10 or 20, the erectile hardness score is between 3 to 4. He's able to penetrate with the medicines. But once he discontinues the medicines, that's when the frustration comes. It comes back to EHS 1 to 2, and he wants a permanent treatment. Now, his evaluation has already been done by a lot of people earlier. So all the tests possible that you could imagine are already with him in his file. And he's got a penile Doppler with Papavine, which was done, and it is absolutely looking normal. The cardiac evaluation is normal. So now the big questions that I would like to put forward I think first, Aditya, if you're around, can we know about what else you want to know in this patient based on history and the examination? Aditya, are you around with us?
Dr. Aditya would be joining probably in lab. Otherwise, we can just.
So if so he's already there, but I think there's a lag. So let me put this question forward to then Dr. Vineet. So we'll start with the history and evaluation. Anything else you want to know, sir, in this patient?
No, I think you've covered pretty much the fact that he's got his basic investigations correct. Though I wouldn't have wanted to investigate him so extensively. And the fact that he has a response to the PD5 inhibitor, which is actually the first pragmatic approach that we use. So he's pretty much covered with the investigation.
Any investigations? No other investigations?
I would
also, that
actually
question
half
is-
the investigations that were done on him.
Okay. So Manu sir, what do you feel? Why this patient keeps relapsing? And
Staying in a big city, most likely. I don't think anything more than a psychogenic cause for his erectile dysfunction is there at present. No more investigations are needed.
so, sir, how would you like to manage this case? Because now he wants something permanent.
No,
and-
because you ran with the history very fast. So I think I would, when I see him for the first time, I would like to go into his social history and the number of times he has sex in the month. And what is his partner's level of satisfaction? This is very important. I mean, we have to have a talk with his wife, with him and without him also. And if we can, just satisfy his partner once or twice a month and they're happy with it, taking the medicines, I think that would be a good thing for him at the moment. And also the fertility aspect also, he's been married for some time, as you said, and he wants to have a child also. Is that there also? So that has to be looked into, because there is a social pressure on these patients who have not been performing and they've been married for a few years. So that has to be taken into account.
So, sir, the next question, which is quite related to what you said, which I would like to ask from all the panelists, is that he doesn't want to take these permanent things. He wants a permanent cure. So, what do you think? How long does he have to take these medicines? Can we cure his ED as a andrologist? Can you? How do you really counsel this patient about when he asks, "Sir, I want a cure"?
Dr. Saxena will start that because he's been teaching us all along.
Dr. Ajit, Dr. Manu just said that the partner should be satisfied before starting the treatment. So any comment on that?
Sorry, partner.
So what I asked was, how much is the partner satisfied with his performance? Because that is what is guiding him. Sometimes it is the partner which is coaxing him ki do better, and that is getting into his head.
Yeah. This is the changing trend that's now coming in. More and more women are demanding their rights. And in fact, if you go to the clinics nowadays, more and more women are bringing the men and be theek kar do.
So I think one of the things that you asked right now was, how do you counsel? And I think that's so important when you're dealing with men with ED. My approach to them is, if you had diabetes or if you had hypertension, would you question the need for lifelong medication? You wouldn't. Neither would the woman nor would the man. Now, when you treat a chronic condition, now, first thing that I tell someone who comes to me with ED is that you have a chronic condition, not a disease. You have a chronic condition. Please understand that. Once you understand you have a chronic condition, you will accept more easily that there's no quick fix to this. You have a condition which responds to a variety or variation of how your psychological moment is. It responds to what situation you are in. It responds to what dose may work at one time, not another time. At what with one partner, not another partner, because your arousal will be different. So many factors that will affect it, especially at this age. So if they understand that this is a chronic condition, they'd probably accept it better that they would intermittently require medication, sometimes which would be lower dose, sometimes which would be higher dose. They could switch that, they could switch medications, they could look at different options. Because remember that, there was a brilliant slide put in the beginning by someone who was talking about treatment for ED that mentioned the actual treatment which is applicable currently. You have only 3: first line, second line, third line. That's standard therapy. Anything beyond that is experimental, should be in the format of a clinical trial. So there's no permanent cure for ED other than penile implant surgery. And that's not an option that should be used easily at all. Unfortunately, being used very easily, but should not be used easily at all.
So we must counsel our patients that you will require long-term treatment. You may or may not require treatment which extends beyond, just the first few visits that you make to us. And if you're accepting that, then.
So if I were there at your place, I would have given the same answer.
So
Because that's
basically,
what-
Raman, what
Can
you
I-
were pushing
can I-
us to say.
Can I intervene?
Yes, sir. But we want opinion from everybody around
So,
it
Raman,
because it's a
what-
difficult problem. To
What
do.
you were pushing us to say was to offer him permanent treatment. Nobody over here is going to put an implant in this patient. So it is going to be a long-term kind of a low-dose tadalafil with boosters of a little bit more on the
So,
day.
so
day of,
in
yeah.
case he says, no, I want a permanent solution. How do you
No,
counsel that? Basically, I just want to
think
learn
there's one
from the.
big problem. And that is that we are overlooking lifestyle modifications. Some of it Vinith has touched, but that's a major chunk of
Yeah.
erectile dysfunction treatment. How many of us spend time with the patient, counseling the patient at all? We just give him a tablet of Viagra, not even explaining to him that foreplay is important.
So
And
what
you have to take
happens, what happens in my clinic is that when I am seeing a patient, he takes 15 minutes, 20 minutes, then maybe they would sit there for an hour. But you know that there are other people waiting, and those people are there for a ureteric stone, which is going to pay you more. So, I mean, I am biased because I am charging 2,000 rupees from this patient and 2,000 from the next patient also, who's going to pay me more for his surgery. So there is an inherent bias with us urologists. Not I'm speaking about myself, but you don't spend that much
Manu,
time
when-
with them.
When you
So-
come to my age,
Sir, then
you
what-
will get the experience of how to.
So, sir,
treat
what
it.
sir does is to keep the wife in front also for a long time. That's a different thing. So, but this
But I
is
look
what
at the man.
happens. This is what happens in practices. So you either you have a very dedicated kind of a sexual medicine clinic where you give an hour or half an hour and then charge accordingly and then look into these things. Otherwise, it has to be done very quickly.
I
And
think
to be
you don't-
honest,
you don't have to fall into this trap question of can ED be cured, because you're giving a wrong solution. And unfortunately, this point has to be hammered today because we are getting patients that want their implant removed. He's had this, I've
Yeah.
had this. 25-year-old unmarried man came with the first complaint, went to the practitioner, said, I want cure of ED, and he put in an implant. Now this man is running after every one of us, we know that, and he wants his implant out. We cannot call this treatment. We can't allow our ethic to allow this.
So I think we need to take Aditya's call on this also because he's not with us, unfortunately. Aditya, are you around? Dr. Aditya?
Till he comes, I would just ask the panelists, can I just ask the
Yes,
panelists,
why not, sir?
About what's the role of, because you think this case is probably a psychogenic case, and then we have
Absolutely.
a lot of sex therapy and sex counseling plays a very important role. So we haven't done that. So I would ask Dr. Ajit about sex therapy and counseling and how important it is in this case.
I think it is important, but today the patient has no time. He wants a quick fix to be done. And therefore, counseling is never going to work in the modern circumstances. They don't have time to swallow a pill of Viagra. They want chewable Viagra.
So exactly that kind of counseling is required, that this
Yeah.
doesn't have a quick cure. You have to be very perseverant. You have to change your lifestyle.
to
You have
bring-
to-
There's a via media.
Yeah.
And that is 7S.
Yeah.
Smoking, spirits, sugar.
Yeah.
These are no. And you
Yes.
can tell them in very quick terms of that.
Also, sir, I mean, society, the way it is now, anybody who gets married has had multiple sexual experiences prior to that. And a lot of people compare their previous experiences with the one when they get married, and then they fall into that trap key. And these advent of these gyms and all these gymnasiums where boys go and girls go and people, kind of flaunt their sexual prowess, and then they get this thing in their mind that we are nothing. And with the advent of porn, people come to us and say that they have been doing it for 1 hour and we are just over in 5 minutes. I mean, so what's wrong with us? So the society is like degenerating at a very fast pace. It is very difficult to control these things. To
Manu,
counsel them is very important.
Manu, you opened up a big chapter of porn.
Aditya, please go ahead.
We have Aditya. Yeah, please.
I think, am I audible right now?
Yes, you are audible.
Not audible.
You were audible in between, Aditya.
Yeah. Not audible.
Usual electrical dysfunction.
Yeah, but his mic is on actually. I think
Mic
it's a
is on,
problem
he
for
is
now.
not muted, but still his
But
voice
basically
is
what
not.
he's trying to say on WhatsApp is that why not involve a clinical psychologist and
Yeah.
psychiatrist at this point? That much I can convey on
So
his
Raman,
behalf.
Raman, the patient that you took in this, the first patient.
Yeah.
Raman,
Dr. Himanshu says that you can remove your AirPods, and I think that can help. You can just go on to the.
Yeah. Hello, Aditya.
Is it working right now?
Perfect.
Thanks.
Thanks, Himanshu. Go ahead.
So my question is, in this case, it's a typical case which we see in our tertiary care center. The patient has moved around a lot. And what we typically follow is a biopsychosexual model. So I work in conjunction with a clinical psychologist and a psychiatrist who typically looks after the sexual medicine part of it. Because as a urologist, it's very difficult to dissect. We are not wired to dissect out all those things which a psychologist or a psychiatrist can do. And the majority of these want to have their spontaneity back. It's not about taking the pill, but the spontaneity needs to be back in the sexual in the room itself. So that part needs to be dissected out, and they need to be counseled whether it's a side effect profile, it's the spontaneity loss, or no response to the tadalafil, which is not the case here. So all those things needs to be addressed, and psychologist or a psychiatrist can do a better work. If Manu sir is spending 20 minutes, definitely that's the thing which we need at this point of time. But you are not able to cater to all those patients and give time to the addressing those issues.
Thank you, doctor. I think we should just move to the next case because we have only 6
Raman,
minutes left.
just last
Yeah.
thing. Was this a made-up patient or it was an index patient you had in your clinic? And what did you do?
I
You
don't
have
need to
tell us
make this
that.
up. I think every one of us has
Yeah.
had this patient.
Yeah.
Okay.
Yeah.
So another case is a 62-year-old diabetic. He's been diabetic for the last 20 years, and he has had ED for the last 15 years. Can I please have my slide so that the panelists can see it? So he's been on tadalafil again off and on, and now he's been taking it regularly, and now also uses a combination therapy with SOS sildenafil. Now, initially the EHS was 3 to 4. Now he's able to achieve only 2 to 3. And we tried Tramix. He was having a good erection, but he's not able to self-administer. And penile Doppler does suggest some sort of an equivocal result here with the EDV of 9. And the patient also does not want to go for any invasive options because he's had his time with the with the intracavernosa injection. So the questions are basically, what can we do to further help this patient with medicines? Is there a role of any other medicines that you feel, as this is again a very common scenario? So again, starting with Ajit sir probably for this.
I think there may be a question of venous leak in this case, and therefore none of these medicines are going to work. What is going to work is a mechanical thing, like a use of a rubber, just the rubber of a device, a vacuum device. And if that can hold on to his directions, then that's the answer. And maybe surgery for the venous leak if it is required.
So yeah, pretty much, I think a vacuum addition to the medication, but I think also the fact that you mentioned he's actually be able to manage his trimix. The only thing is he can't self-administer. So it's very easy to teach his partner how to use the trimix.
So partner
or the
education
Vonage.
becomes one, vacuum
It
erection
becomes-
devices
yeah.
become another option.
Yeah. Raman, this is a good patient for some testosterone replacement, I think. 62-year-old.
Okay. So we should look into his testosterone
Yeah. We should
levels
give
as
him-
well.
we
So very
should
good
give-
points. Aditya, anything that you would like to add? I think
it's
we've had
summarized
3
everything.
on-spot answers from 3 panelists.
Exactly. Everything is summarized. Thank you.
Right. So basically, if this patient wants to continue with phosphodiesterase inhibitors, maybe at higher doses, do you feel there's a role of increasing tadalafil to beyond 20 or sildenafil to beyond 100? Have you ever tried doing it as experts?
I've tried it, but I don't recommend it.
You don't recommend it. Anybody who recommends this, because a
So
lot of
basic-
people do give it.
No, so I would actually agree with what Manu said. So if we're looking at testosterone deficiency there, then testosterone deficiency with the maximal permittable dose. I mean, on a forum like this, I would never want to say that I've tried anything more than that. It's never advisable. So the maximal permissible dose of the particular PD5 inhibitor, and you can switch between all of them.
A very peculiar question this patient has asked me is, so how long can I take this phosphodiesterase inhibitor safely? Now I'm taking tadalafil daily. So, sir, I would like to ask Ajit sir, so how long have you been giving this medicine safely to your patients?
There's a big
What do
drop-
you say? How do you commit?
There's a big dropout after 1 year.
Okay.
But I would go on with it as long as you can take it.
So any idea about the longest your patient has ever taken tadalafil for the experience of
On
younger?
and off 10 years.
So is it possible to make this patient free of phosphodiesterase inhibitors without implants?
Oh, yes.
So VED was one of the options.
LISWT.
Raman, also, once you do the technical things, but also you have to remember who is the partner of this patient also, you know. A lot of elderly gentlemen are coming, they don't have sex with their wives because women don't have sexual interest after some age, I mean. So they say that we can't do it at home. So we go out and we go to these massage parlors, or we go to Bangkok or to places, and then we just need it for 1 time or 2 times, once a month maybe or something. So that is a very important history you have to take. Whom are you having sex with? Because if you're having sex with your wife, you may not be having that good an erection now after 30 or 40 years of marriage. But when you
One
go
very
out,
important point.
yeah, this is very important whom you are having sex with. And
I-
he says, "Ki sir, bas ek baar ho jaye, that is it. Matlab, I am happy. Matlab, I have this secretary in my office and just once a month is very good for me."
Yeah, but the partner
So-
is not happy. So it's a very important point brought out that erectile dysfunction is a
And
couple's problem. It's not an
interesting-
individual problem.
Interesting
That's
point
right.
that I'd like to
Yeah.
add.
So
Yes,
that
yes, please. Yeah.
Senior citizens require more change of position than the younger ones.
Younger ones, right.
Wonderful.
So
Points
for
taken.
these men with, you know, the older age group, we're talking about, actually, if you look at intracavernosal injections, they are a fantastic form of treatment. If they are able to self-inject good. I had a gentleman who was 72 years old who had only hired a nurse so that she could, and there was a lady, and she would inject him before the act that he was doing with someone else. And this was not his wife. So, you know, you have different men who are capable of different abilities. Don't make judgments yourself. If you can find someone to inject them, if they're not doing it themselves, this is actually the most satisfying. They have a natural erection. They get a fairly tumescent erection. They get some arousal over it. So some glandular enhancement also after that. So, you know, it's a fairly satisfying erection, far more satisfying than the vacuum device. Vacuum device, you know, in spite of the fact that we're talking about it, you'll find such a high dropout rate with that.
6 months.
So, sir, just the last minute left. So I would just like to ask quickly about any experimental therapies that you've tried, because there's a lot of hue and cry about these. So
I use LISWT for men that start losing response to PDE5 inhibitors so as to keep them responding to it. That's
and
the
what
only-
regime also, sir, for the sake of the audience?
That's the only indication, which means mild to moderate vasculogenic disease where a response to PDE5 inhibitors has become less. So they are the men that I'm seeing. And again, very importantly, remember that it's a variable response. You cannot define it. You must tell the patients this is still experimental domain. You don't know how long it will last. You don't know how many sessions are required and how often you will repeat the cycle.
Ajit, sir, anything that you would want to comment about? So you've been using LIESWT for a very long time.
Yeah, I've been using it for the last 8 years, and it is very good for the first year. After that, it wanes a bit. 75% of the cases do respond to it. Unlike Dr. Vineet, I don't demarcate the patients. I put everyone through it because it's harmless, painless, and a bit of a hole in the pocket, but otherwise it's okay.
Aditya, would you like to add something, and then we'll be closing this wonderful panel discussion?
We are not using any of the experimental therapy as of now, but in process of starting a low intensity shockwave therapy soon and a stem cell therapy.
Wonderful.
Can I just make a short point? Can I just make a short point? I think the audience has to go back with the information that lifestyle modification is very important in the treatment of erectile dysfunction, and you have to devote some time to it to get better results. Thank you.
Thank you very much. We
I have
can't
a
take, because we are running short of time. People are after us. So yes, Doctor, I would thank my co-convener, Dr. Raman Tawar, all the panelists, Dr. Ajit, Dr. Vineet, Dr. Manu. Thank you very much, and thanks to the audience for their patient hearing. Thank you very much.
Thank you, Shivam sir. Now the session comes to an end. May I request Dr. S.K. Pal to kindly come on the stage and present a memento to the conveners, please.
Thanks for 6 in the morning.
Manu and sir, please stay back also, sir. The chairpersons also, please. Sir, please. Sir. Dr. Ajit Saxena. Manu and Dr. Ajit Saxena, please.
So that's what he said. Dr. Ajit also said, they usually continue for at least maybe a few months or a year or two, but then the dropout rate is quite high. Intracorporeal injection, there are many patients who are on home self-injection program. Half of them will drop out. The reasons are multiple. One, they may not like it now after that few months. Secondly, sometimes people would develop spontaneous erections after giving them home self-injection program for a few months. So and some of them may develop a little bit of complication, which could be the reason for dropout. Yeah, thank you. Right.
So can we have everyone once on the stage for a
wife-assisted
group
home
photo for the
injection program.
andrology session? A group photo, please, sir.
I have a simple request to make to two senior members of our fraternity, Dr. Bhatt and Professor Bhatt and Dr. Arvind Goel. I request you to kindly convene the next session because me and Himanshu both have to go for an urgent council meet, sir. So I would like you to come and start the pediatric urology session, sir, please. On-floor staff will be helping you out. I have told them how to do it.
Morning, sir. Session कैसे?
Good afternoon, everybody. We are already running late, and at last we are convening this recent updates in pediatric urology. So I think this is an important session, and more youngsters will have to pick up this specialty. So this specialty develops. With these few words, I ask the convener, Dr. M.S. Ansari, who will be online, to convene this pediatric urology session.
Good afternoon, sir.
Good afternoon, Anil.
So very nice to see you, sir. And this really to hear any word, it is just like blessing for all of us, sir, because you have been an inspiration for all of us. So as you rightly said, that pediatric urology is one of the most upcoming branch of urology. And we are having very interesting topic for discussion today is the megaurator. Primary obstructing megaurator will be discussed, and the panelists for this we are having the eminent people known in this field, Dr. Massimo Gariboli from Evelina London Children's Hospital. And we have Dr. Amila De Silva from Royal Manchester Children's Hospital. And of course, we have Professor Bhatt along with us. Welcome, Dr. Amila De Silva and Dr. Massimo.
Hi. Hello.
Hello. Hello. And Dr. Anil Takwani is already logged in, and Dr. Malika Arjun from Hyderabad. So we may start with first talk with Dr. Anil Takwani. And the first talk is about the modern issues in diagnosis of primary obstructing megaurator. So without taking much time, Dr. Anil Takwani, you may please go ahead.
Dr. Ansari, introduce Anil Takwani. I don't think he needs an introduction. Still, it is convention.
Yes, Dr. Anil Takwani is one of the most vibrant pediatric urologists in India, and he has enormous contribution in the field of pediatric urology over the last 2 decades. We all know him, and I think with this we can go ahead.
Yeah. So good afternoon to everyone. Am I audible, Dr. Ansari?
Yes, very good.
Perfect. Thank you. So good afternoon to everyone. And thanks, Professor Amilal Bhatt for this, and Professor Ansari for this introduction and opportunity. And thanks to North Zone Council also for keeping the pediatric urology for 1.5 hours and giving us opportunity. So my topic of today's talk is the mega ureter, and my convener has assigned me to speak on the modern issues in diagnosis. So I will try my best. So almost 20% of the structural anomalies picked up into the prenatal sonography constituted by the genitourinary system. So we can say that the most common structural congenital anomaly which is picked up in prenatal sonography is of hydronephrosis, and that is 2 to 3% of all pregnancy. The serious problem here is that we understood of late in last 3 decades that almost 50% of UPGO-like and 85% of the mega-ureter-like changes resolve spontaneously. So it is a very important task to separate these two entities, whether it is obstructive or non-obstructive. So coming to the definition, mega-ureter is an abnormality of one or both the ureters of the child. A mega-ureter refers to an expanded or widened ureter that may or may not function normally, and whereas a normal ureter is about 3 to 5 millimeter, the size of mega-ureter is usually greater than 7 millimeter in diameter. So this implies from 30 weeks of gestation to the less than 12 years. So coming to the issues, we all know the mega-ureter, if we picked up in a prenatal sonography, the baby will born with the presumptive diagnosis, not with the symptoms. And therefrom onwards, the whole issue starts. So 25%, as I discussed, constitute mega-ureter-like of USG in antenatal or prenatal sonography, which we face postnatally. Its clinical significance is matter of debate since more than 50 years. And as it compounded with the age of diagnosis because of advent of the prenatal sonography, even in the most peripheral area of country like India, and even the smaller countries, the age is now almost 4 months, which was almost 25 months before the 90s. This is from the review article, Luis Braga, and probably this was reviewed by the Massimo, if I'm not making mistake. So this is working as a double-edged sword and requires a lot of balancing act. On one side, there is the advantages of like early detection, and that's why we can start antibiotic prophylaxis in a couple of indicated cases. Or even if there is a urinary tract infection, we can pick up the urinary tract infection very much in time, and we can start antibiotic to prevent the pyelonephritis and its sequelae. On another side, it can push the patient for unnecessary medications, excessive invasive investigations and radiations, and family also can go through the stress for almost no reason. So the challenge is definitely there is a system which is dilated, whether it is obstructed system or reflux system is one side of the right ROP, and seconds on another side is that dilated but non-obstructed, dilated but not refluxing, or even if it is refluxing but not significant. And this is also recognized very much into the literature. If you look at the literature before the 2000, in couple of guidelines as well as consensus statement, we're not talking much about the presence of transient hydronephrosis entity. We're talking about the 70% incidence of UPGO and 20 to 25% with the reflux and UPGO. But since 2010 onwards, because of excellent work carried out by our peers, and they published it, and we changed gradually, and we started talking 2000 onward, 2010 onward about the transient hydronephrosis, almost present into the 80% of patients. So now classifying the mega-ureter, it can be non-obstructive, non-refluxing, it can be obstructive or refluxing and obstructive, any of these four. And it can be primary or secondary, as our convener said, we'll be focusing only on the primary this time. So in the primary means that we have a pathology at the lower ureter or VUGO. We are not going to talk about any bed bladder or intravesical obstruction. So traditionally, what is available with us in asymptomatic patient? If the patient is symptomatic, the story is completely different. But in asymptomatic patients, we have a magnitude of mega-ureter present in the sonography. On renal scan side, we have a differential renal function and response to the furosemide, the diuretic curve. drainage curve and the VCUG to check for the presence of reflux in cases of mega-ureter. But here, again, issues are which of these investigations. We have not to prescribe these investigations blanketly in all cases when its timings are also very important to avoid the unnecessarily investigations as well as the unnecessarily jerky investigations and proper interpretations of these. So we'll go through quickly a couple of examples. This is one of the case where prenatally right hydronephrosis, mild hydronephrosis was picked up. The postnatally, you can see that again it is UTD-P1 means mild hydronephrosis, no UTI, no voiding issue, but the patient was subjected for the VCUG in the first week, and there you can see there is no reflux. And this is I'm talking about the around 2007 or something like that or 9 at that time. In at least our area, the IVU was very much commonly practiced in these kind of cases. And based on the IVU, this patient was diagnosed with the obstructed mega-ureter and was advised surgical intervention. Now, questions here is that it is just UTD-P1, mild hydronephrosis, asymptomatic neonate. Hydronephrosis trend is not established with the serial sonography, whether it is progressive or whether it is staying same or it is regressing. So question is there any need of VCUG or IVU? And nowadays, people have gone further forward that rather than IVU, they directly send the patients for CT IVU, which carries a lot of radiations in these small neonates or infants. And there we want to address this issue that this diuretic scan was done almost in that particular period. It was the case of around 2009. And there you can see split function is of normal range and the diuretic curve is non-obstructive. So what we can derive from this is the VCUG and diuretic scan can wait till the trend of dilatation in couple of sonographies done little later into the 2 to 3 month span. And we can avoid invasive investigations. Now, another example that again, antenatal detection of bilateral hydronephrosis in 3rd trimester, normal amniotic fluid, no other issues, child born without problem, and UTD-P1 sort of dilatation on 4th day of postnatal sonography. Here again, the issue or question comes is, do we need VCUG in this child in a very early months of the life or weeks of the life? In this patient, at 2 weeks, VCUG was done, and it has picked up the low-grade non-dilating reflux. And the DMSS scan was done almost at 6 months, which is suggestive of any evidence of infection pyelonephritis. So here again, question comes is that we have issue comes is that we have diagnosed clinically insignificant reflux in asymptomatic patient. And are these investigations likely to change the line of treatment? The answer is no. And the child is exposed to invasive investigations and radiation. Parents exposed to the costs and the stress. The continuous antibiotic prophylaxis for first 6 months with close follow-up with the sonography were probably the answers in this case. So what I'm trying to conclude with these 2 examples is that the magnitude of upper tract dilatation at the kidney level as well as the ureter level in immediate postnatal sonography decides the further trend for the investigations, and the main investigation stays in a couple of next weeks after the birth sonography. So this is something from the literature. The monitoring with careful ultrasonography avoids unnecessary invasive and irritating examinations. The first 2 ultrasonic scans within 1 to 3 months of the life are highly accurate for defining the presence or progress of renal pathology. And in infants with the 2 normal or improving successive scans, obstruction or BUR are rare, and if present, it is likely to be of clinically insignificant. Another example of bilateral mega-ureter, again, antenatally, this hydronephrosis was picked up bilaterally. Postnatally, this patient was scanned on 2nd day. Good urinary stream, no history of fever, abdominal mass, no blood palpable. The issues which we would like to address here, that when will you advise serum creatinine? Will you consider AB antibiotic prophylaxis? And when you will do postnatal, again, USG and VCUG. So creatinine should be checked earliest at 72 hours because the maternal blood along with the creatinine along with the maternal blood transfers to the fetus through the placenta. And so whatever if we do creatinine in this first 72 hours, it reflects the maternal level of the creatinine. And if obstruction is unilateral, then ideally creatinine should be checked after a week. Regarding antibiotic prophylaxis, no prospective data, but most of the investigators propose the antibiotic prophylaxis. Even in my institution we follow the antibiotic prophylaxis in hydronephrosis cases for first 6 months to 1 year, as they are high risk. And specifically, they are considering the male patients who are having a prepuce. They are not knowing exactly the preputial hygiene, their social condition, economical conditions, availability of general practitioners or pediatricians nearby, or lab investigation. So considering all this along with the literature, though in paucity of the prospective data, in our practice, we follow the antibiotic prophylaxis. And the timing for the sonography, it is immediately while the patient is not still discharged within 48 hours in a suspect cases of infravesical obstruction, in severely bilateral dilatation like UTD 823 and solitary kidney, and a potential loss of follow-up, that is in a low literature or low educated people. And delayed till a week asymptomatic unilateral hydronephrosis, mild bilateral hydronephrosis. Why we would like to delay? That we want to subject the child who is still having some element of dehydration and oliguria, where we can have a false negative finding. So what we have to look for while sending the patients for sonography, we have to look at the hydration status. We have to insist mother to continue the feeds. We have to explain about the position, supine or prone. Fullness of the bladder means sonologist should mention how much urine is occupied in the bladder, and technique of measuring anterior-posterior diameter, which is very important. Inclusion of any of the extrarenal pelvis diameter can give falsely elevated measurement of the pelvis. So we have to see in an axial plane. This is the axial plane, and this is the transverse diameter anterior-posterior. This is exactly what we are interested here. So, and another picture which is most important is the transverse plane at the bladder level, to get the exact idea about the diameter of increased diameter of the lower ureters. So along with this, we have to take these 6 actually pictures. This is for the axial plane for the AP diameter. Then sagittal plane, generally we took it for the nephromegaly. We have to again see for the central and peripheral callus dilatation and cortical thickness at all 3 poles, and the transverse plane sonography picture at the bladder level. Insist all these pictures to give to you, and it should come from the sonologist in a proper way. And then based on this, we have now UTD classification incorporating all these 6 findings and participated by the 8 societies. So again, I'm not going to repeat this, and based on this, we can have a standardization of the USG reporting, which is very much important. Again, we have to mention about how much urine is occupied in the bladder, then the kidney size on both the side, parenchymal thickness at upper, mid, and lower pole, then pelvic carousels, this cortical echogenicity, medullary cortical differentiation, AP diameter of renal pelvis, as I explained, then the central and peripheral calluses, and ureter as well as the bladder. So insist your sonologist to give all this thing very well written into your report, and that can give you that will save the patient from the unnecessary investigations and haphazard treatment. So based on this, in this index case, we classify this patient into the UTD-P2, which is of intermediate risk, because the pelvis is more than 15 millimeter, peripheral callus dilatation, abnormal ureter, and based on that, we have to decide for the further investigations. Here, the voiding cystoscopy done. These are the other indications, and BCUG was negative. So coming to the diuretic scan, when we all know the newborns, it should be delayed till the 2 to 3 months. Best is after 3 months, because the newborns are having a low GFR, their kidneys are immature, their tubules are immature, and there can be a prolongation because of that, and that can be read as obstructive, and their response to the Lasix is blunted, and premature infants should be even waited for a little longer. And technetium 99 or EC is preferred over the DTPA. I'm not going to go in detail, but the Most importantly is that if there is a reflux, we have to keep the catheter. If there is ureter very significantly dilated in the lower end, then also catheter is required because avoid the overimposition of the bladder. And the not to forget about the post-void in a non-catheterized patient and gravity-assisted picture also we have to ask. That is after the 30 minutes of the Lasix, the child is kept into the erect posture for 5 minutes and images are taken. And if the radioisotope is written more than 50%, then it can give some idea about the presence of obstruction more confirmatively. In this patient, diuretic scan was done too early, 28 days. So there can be very difficult to rely on this. And there you can see on waiting for 2 months and then the serial sonography 2 months in the 6 month, we can see bilateral hydronephrosis is showing the regressive trend. So these are the things very much challenging, very much important, not to jump only on the 1 or 2 investigations and decide the accordingly unnecessary treatment. So last scenario, again here the UTD P3 dilatation postnatal, but the important thing is that infection has come into the picture. This was culture proven, and there you can see we have to do everything. We are avoiding cystolithography after the control of infection, no reflux, and there you can see the diuretic scan, split function is less than 40, and there you have to focus here into the drainage pattern. We have to extend the this scanning period up to at least 60 minutes. And after 30 minutes, it starts focusing on the another region of interest ROI, that is at the VUJ. And so we'll be getting most of the time 2 curves. One is the renal curve and the ureteric curve. These are very important to avoid the this is correlated with the obstruction and this kind of a confusion where you can see in the 30 minutes, just the UPGO-like picture in a poorly functioning kidney is demonstrated. But once we have an idea about the ureteric dilatation, we have to extend the scanning period. There you can see at the 90 minutes and 20 minutes at 2 hours, you can see the whole ureter is seen with the curvature, with the obstructive element because the radioisotope retained or accumulated in the kidney is still much higher in compared to the bladder. And there also it can be correlated with the operative finding. And there you can see both the curves we have to, and both the ROI we have to take into the consideration. Very quickly, again, bilateral hydronephrosis in the sonography UTD P3 with the recurrent febrile UTI, avoiding cystolithography, bilateral dilating reflux, and the scarring as well as photopenic area of representing acute infection. So these are the very, this should be the way we have to consider the sonography in a proper way. And this is another example where you have to small baby, even if the baby is small, considering the dilated ureters of around 15 millimeter, you have to do VCOG. And there you can see the possibility of high-grade reflux with the megacystis, and these patients require intervention. And this is an example of refluxing with obstructive megaureter. There you can see the lateral plate is important to see that whether there is a complete drainage and the lower segment of the ureter. Here you can see the obstructive element in the highly refluxing and dilating the. This is another example where duplex system, which is the merging at the lower ureter, which is showing some sort of obstruction as the contrast is written into the system. Very quickly about the MRI and MRU, which has come into the picture since 86 and 99, and it can be give excellent morphological details. This is the posterior picture. There you can see that this obstructed segment of the ureter in megaureter can be seen. But still, I will say that it cannot replace the sonography, the equal amount of details we can get into the sonography. But in some cases, it can be still considered. The downside of the limitations is the sedation. Preparation time is 45 minutes to 1 hour. And sometimes in a 6-month above boy, it requires general anesthesia. So this is something about the MRI. And last conclusion is the predictive factors. We can say that from my discussion that high-grade hydronephrosis at baseline, dilatation, pelvic acid system dilatation, ureteric dilatation, cortical thinning, all these are important. UTD P2, P3, ureteric dilatation of more than 14 millimeter, split functions. And on the other side, for the resolution, low-grade hydronephrosis and ureteric dilatation less than 11 millimeter. And so I would like to conclude that proper USG examination following UTD classification criteria. Validity of UTD classification is confirmed in last 6 years in clinical setup. Relying on UTD classification and risk categorization, further investigations can be planned to reduce the unnecessary investigations in the treatment. And serial USG is the best feasible and least traumatic modality for follow-up. MRI and MRU can substitute, substantiate the USG findings, but no IVU or CT-IVU. Thank you. Thanks for this opportunity.
Thank you, Dr. Takwani, for making very elaborate discussion about the evaluation and diagnosis of this megaurator. And when we talk about the primary obstructing megaurator, it really becomes little scary for the parents. The moment they come to know about the word obstructive, and the same thing was common 3 decades ago, as most of the pediatric surgeons and the urologists and the other surgeons involved in pediatric surgery, they used to operate these kids. But now the policy over the last 3 decades has largely changed. And now we have Dr. Amila to further enlighten on this observational policies, that is it really worth to observe these kids, or most of these kids have to go for the surgery. So over to you, Dr. Amila. Dr. Takwani, you stop, you're sharing your screen. That
No,
Dr.
I stopped already.
Okay, Dr. Amila.
Yeah, is it
Yeah, please.
recorded presentation, or is it me sharing the screen?
Or you may turn your recorded if directly.
Okay.
Do we have his recording?
I will start. Yeah. Can you see me?
Yes, yes,
Yeah,
please
yeah.
go ahead. Beautiful.
Go ahead.
Excellent. So, good afternoon, everyone. Even though it's quite early here at Manchester, I'm Amila De Silva. I'm one of the locum consultant pediatric urologist at Royal Manchester Children's Hospital. Thank you, Dr. Anwari, for the invitation for me to present. This is actually a Manchester Children's Hospital in a nice sunny day. Right. So before discussing this observational policy given to me, I thought I will discuss a 2-slide presentation on the megaurator, the classification and the pathophysiology. It is important for us to understand to make that decision about conservative or the observational policy. So megaurator defined as dilated ureter, more than 7 millimeter, as Dr. Anil said. Different classifications available. This is one of the classification classified into primary and secondary causes, as well as refluxing obstructing and refluxing obstructing and non-refluxing non-obstructing, which is published in 1980. Now, in regards to the pathophysiology, it is extensively studied. Now we know that the development of the ureter and the muscular development is also important, and it comes from craniocaudal direction. Sometimes this smooth muscle development may take up to 2 years to develop to a normal level. So that is the basis for sometimes we wait for the first 2 years to observe for those to develop normally. Again, it is important that the dysplastic nature of the renal system is varied from one reason to the other, the causes that I mentioned on the previous classification. Now, refluxing megaureter have minimal degree of dysplasia in compared to the obstructing megaureter. There are studies shown that around 20-25% risk of dysplasia. When it comes to the obstructing ectopic, in a duplex system, the dysplastic nature is much more higher. twice as the non-refluxing type of megaureter. So that is again important, that embryological basis for that, which we know where the ureteric bud developed from the abnormal part of the mesonephric duct and hitting on the abnormal part of the mesonephric blastema. So that's a dysplastic nature that we understand. And different classification again available, as Dr. Anil said, that people use IVU a while back to classify this morphology of the renal system. The Pfister-Hendren classified this in 1978 amount and severity of this megaureter. It is again important to understand that, because this is a spectrum which we are discussing. So identifying the patients into conservative management, you need to understand these things. These are very important factors. In type 1, which is minimal dilated ureter, which is only the distal ureter. Type 2 is completely ureter and ureter up to the top to the kidney. And type 3 is a severely dilated tortuous ureter and the renal system dilatation. So today, as we are discussing about primary non-refluxing megaureter. So should once we exclude the secondary causes, once we exclude the refluxing cause, we are come to a decision about non-refluxing. Now again, important to understand this non-refluxing causes includes obstructing causes as well as non-obstructing non-refluxing causes. Obstruction definition, again important to understand. Obstruction, what it really means to classify them as obstruction. Obstruction in definition wise, what we are practicing is in a follow-up for with the time with poor drainage, which can affect the function of the kidney. So to make the functions go down, so that group we consider obstructing. The rest of the things are non-obstructing. So again, with this group, it is a spectrum which we are discussing. So the question that we are having, do we need to operate or not? Yes, well, while back, which is late 20th century, people used to operate on those, as Dr. Anwar correctly said. There are enough evidence and publications. They used to operate, and they say that's it's quite a good option to go ahead. But with the time now, for the last 20-30 years, people practicing observing with the long-term evidence showing that observation is quite good. Mode of treatment with antibiotic prophylaxis as well as regular imaging. In Manchester in 2013, we have gone through, our colleagues Supul Hennaik and Ravi Binduranawaka have done a good study, and we have analyzed our data. And we found 2003 to 2011, over the 9-year period, less than 10 millimeter dilated ureter group on this non-refluxing group and non-refluxing and primary group. None of them had any operative intervention. In fact, 76% we managed conservatively without any, 76% resolved completely. More than 10 millimeter, we manage without operation 79%, but 17% resolved completely. So those group need regular follow-up as long as the patients and parents understand what we are doing. Surveillance during that period was done with ultrasound scan yearly and MAG3 scan 2 yearly. And we have given continuous antibiotic prophylaxis during that period for the first 5 years. Then 2014, where we got this BAPU consensus statement, and that's a very nice paper published 2014, which have gone through all the literature available at that point, and they made a few recommendations. One of them is initial management of conservative. And MAG3 scan, which we use to assess the obstruction, again important here to, as Dr. Anil said correctly, to identify and analyze or interpret the MAG3 very correctly. Now, MAC3 is a radioisotope which we use to assess the kidney function as well as drainage, and it's absorbed into the proximal renal tubule and excrete into the ureter. Unlike the DTPA scan excrete from the GF, the glomerulus into the urine, which is not really assessing the correctly function. Now, even with the MAC3, the area of interest need to be the VUJ rather than the PUJ. Sometimes we interpret it wrongly and make it as obstruction in a rising curve. So that is giving a wrong information on those investigations. So investigations need to be very used correctly and interpret correctly as well, as Dr. Anil said in the previous presentation. Now, 2019, there's a nice, interesting study, Canadian study about primary non-refluxing megaureter. That's a very nice paper analyzing 101 patients. So it clearly says that high-grade hydronephrosis as well as ureteric dilatation more than 14 millimeter associated with febrile urine infections are the factors more likely to undergo surgical interventions. Most of the others can be managed conservatively. The ureteral dilatation less than 11 millimeter was only the independent risk factor associated with spontaneous resolution. So those are very important evidence that we have at the moment. So factors to consider how to select these patients for the observational policy. Size of the ureter as well as the renal system is very important, because that's where we predict how it resolves spontaneously and how much percentage they can go into problems with time. Single or duplex system, we know that the development of these systems, so that risk of problems getting with the observational policy is higher with the duplex than the simplex. Symptoms, definitely with the febrile UTI, we are going towards a surgical option, and initial differential functions and follow-up differential function is again important with the MAC3 and washout curves on the MAC3. Parental choice with the informed consent, it's again important, very important factor. Now, we tend to operate as surgeons mostly, but it is important to pick correct patients not to operate on this very wide spectrum of the disease. So regular radiological monitoring and antibiotic prophylaxis is what we suggest. Now, antibiotic prophylaxis, there are enough studies again work on that, and some studies shows that around 80% urine infection reduction within the first 6 months, and even within the first year, there's a significant reduction of the urine infection while on antibiotic prophylaxis. In Manchester, what we consider trimethoprim 2 milligram per kilogram once daily antibiotic prophylaxis. So patient selection is important to identify the asymptomatic, stable differential renal functions and stable or improving dilatation with the informed consent of the parents. So Manchester now, we are going to revisit that previously published paper, and we analyze the data which we have now for long term from 2003 to 2021, which is around 19 years. We found this is still on the analytic stage, 77 patients with 93 renal units. Interestingly, we found that around 80% less than 15 millimeters, 10 millimeter, as well as 10 to 40 millimeters, we manage without operation, even long run with 19 years. More than 14 millimeter, not much difference. We manage 70% or more without any operations. That's interesting. So we are still analyzing the data. So we will hopefully will publish within next few months. In conclusion, most non-refluxing megaureters can be managed safely without an operation. Patient selection is important, and informed consent with the parents with risks and benefits is important factor. Thank you very much.
Thank you, Dr. Amila. This is a very crisp description about the conservative management of primary obstructive megaureter. Since many of us will be having a lot of questions in their minds, but we are having a series of case discussion. All the questions can be put in those prospective cases. So we will be coming back to Dr. Anil and Dr. Amila during the case discussion. Now we are having Massimo, and he is from Evelina London Children's Hospital. And whenever we talk of about the intervention, and we know that the gold standard for this megaureter has been an open surgical reimplantation. But over the last 2 decades, again, the surgery is also drifting towards the left side, that is to the minimally invasive surgeries. So let us see what is the current status of minimally invasive surgery in cases of primary obstructive megaureter. So Dr. Massimo, all to you now.
Thank you very much. I'm sharing my presentation. Please do tell me whether you're seeing my presentation. Yes?
Yes, it is visible and audible. Yes.
Fantastic. So first of all, thank you very much for the invitation. I'm very honored and pleased to be here and to present what are the justification for the minimal invasive management in the management of the primary obstructive megaureter. As we have heard already, the definition of primary obstructive megaureter is when we have a retrovesical ureteric diameter greater than 7 millimeter in the absence of the vesico-ureteric reflux. We also have heard that there is quite fixed criteria for intervention, and mainly they are the presence of recurrent infection, a worsening dilatation in a serial ultrasound scan, or loss of function of the ipsilateral kidney. As said, classically, the intervention would have been a fenested incision and an open ureteroneocystostomy, where we allow to have the bladder also open for us to detach the ureter, and you can see what can be a very dilated ureter with a 2 centimeter narrow part. Classically, there was a detachment of the ureter and reimplantation in various techniques that have been described throughout the years. This is the one that I'm showing you is the transtrigonal or Cohen, but there have been other techniques described. Now, the first step toward a less invasive approach is the onset of the laparoscopy, where we could avoid to have a big incision like Phanestil, and we could perform the same procedure either with or without opening the bladder, but with the same concept of reanastomosing the ureter. A possible evolution or progression has been also proposed in the form of a neovesicostomy. In this case, the reimplantation is carried out inside the bladder, but without opening the bladder. Basically, it would be just in using the laparoscopic instrument directly inserted into the bladder. One other step in terms of minimally invasiveness has been the onset of the robot. So described series of the help of the robot in the delivering of the laparoscopic reimplantation. It is at the end of the 90s when the first endoscopic treatment was proposed, and in the subsequent 2 decades, the endoscopic treatment has been widely adopted, up to the point where now it can be considered a very popular approach. The first approach, the first technique that has been described is called high pressure balloon dilatation, and involve the use of a balloon that can be introduced within the stricture and open the stricture by increasing the pressure. As you can see, the balloon is passed through the ureteric opening. Once inside, and it could be checked with the help of fluoroscopy, then is blown up at a fixed and high pressure. And this pressure is maintained during a few minutes. There are differences described. Sometimes the decision is to run 2 cycles of this pressure, which would stretch the papillae in order to adjust the opening, and the flow from the ureter will be improved. Another technique which comes after that is what is described as a cutting balloon endoureterotomy. What the difference is, as you can see, I'm showing you the steps of this technique. In both, so this technique together as well as the high pressure balloon, we normally start securing the access to the ureter by positioning a guide wire. This guide wire allow us to have also a ureteric stent that help us doing a retrograde study that confirm the presence of the dilatation. And once we can pass on the balloon, the difference from this technique and this balloon to the previous one that I've demonstrated is that when the balloon is inflated, it also deploys blades. And you will see in a moment that once the balloon is inflated and the blade is deployed, we could also move the balloon slightly up and down to allow the blade, you can see now in the more or less at 12, the blade will be just create also a cut to interrupt the tightness of the ureteric opening. So there will be an association of the stretch and the force created by the balloon, and also the blade itself that can create a interruption of the tightness of the ureteric opening. In both cases, what happened is that at the end of the procedure, we do insert a JJ stent that will be a secure way to allow drainage, and will be remaining for a few weeks in order to have a safe healing of the papillae following the intervention. Now, at the Evelina London Children's Hospital, we wanted to prove and to evaluate the success of this treatment. And we looked back in the last few years. Furthermore, we do perform both techniques that's different from different colleagues. So we had a chance to compare the outcome of the 2 techniques. We looked at the dilatation, both at the level of the ureter and the level of the kidney. We looked at the differential function, and we have looked at the complication and the need for intervention in our cohort. As you can see, we have treated 40 renal units in 35 patients, more or less equally divided between the 2 techniques. As indicated before, the reason for intervention mainly has been a serial ultrasound scan demonstrating increasing dilatation, but also we do have children that have demonstrated reduced function, and in some of them, presence of recurrent UTIs. We do have intervention that has been delivered from the minimum of 2 months of age up to 17 years. In the whole cohort, you can see the complication and reintervention rate have been very minimal. And by comparing the 2 techniques, they've been quite similar with a slightly increased number of reintervention following the high pressure balloon, but without reaching statistical significance. When we have analyzed the outcome measure, we looked at the pre and post diameter, and we demonstrated a significant reduction. When we look at the two groups, no difference was found. Similarly, we looked at the distal ureter diameter, and once again, we have noticed an improvement pre and post, with no difference between the two techniques. As expected, no substantial difference has been identified pre and post operatively in regards to the renal function. And once again, no difference was identified among the two techniques. By looking at our results in comparison to what is published, we can see that the numbers are similar, the success rate is similar. What is interesting is that in literature, the majority of the publication report a high pressure balloon rather than a cutting balloon. So in conclusion, what would be the justification for the endoscopic treatment? Well, this is definitely the most minimal invasive which we can think of, being scarless. The usual admission is an overnight stay. We demonstrated that this is a safe approach with a very low complication rate and a high success rate. And this can be applicable to all ages, as demonstrated in our cohort. We got from 2 months old to 17-year-olds in the pediatric population. Furthermore, when we look at the two techniques, we have showed comparable results, which means that is not one superior to the other in terms of results. So I will thanks again for the attention and the invitation, and I will be happy to answer questions.
Thank you, Dr. Massimo, and we will come to you during the case discussion. We have many questions ready for both of you. So all those will be covered so to save some time. Now coming to the next talk, that is the
Dr. Bhandari Ansari.
Yes, sir.
Now it's your turn to manage how it is different, secondary megaureter, how it is different from primary megaureter.
Yes. So,
MS Ansari.
So it is visible, sir? My presentation is visible?
Yes, sir. Yes.
Yes, yes.
Oh, thank you so much, because this topic is altogether different from the primary obstructing megaureter. And I feel that in developing countries where the presentation is usually late and reporting is late, we encounter more of secondary megaureters, whether it is because of this bladder dysfunction or because of the intravesical obstruction. And the commonest, there are many causes, and among these, the commonest cause which we encounter in our cohort is the neurogenic bladder. And this could be on account of a spinal dystrophism, tethered cord, transverse myelitis. Even some of the kids, they present with a spinal trauma after having a fall from the trees. All the road traffic accidents are less common as to the adult population. While in cases of non-neurogenic, we have this bladder wall dysfunction, followed to this neurogenic bladder in this cohort. And there may be some and postural wall, of course, it is quite common in Indian subcontinent, giving us to many cases of secondary megaureter. There may be less common causes like ureterocele, ureteral ectopia, bladder diverticulum, and even some of the cases with iliac vessel compression of the ureter have also been detected. So as far as the etiology is concerned, and there is no true obstruction as such. Basically what happens, there is a high intravesical pressure. That is, the end filling pressure is more than 30 or 40 centimeter of water. And this is almost 3 to 4 times to the normal pressure what has been recorded under physiological conditions in the ureter. And even in the highest perfusion pressure of that of 10 ml per minute, the maximum pressure has been recorded up to 15 centimeter of water in the ureter. So if it amounts to 30 and above, that it means that it has to ureter has to apply stronger peristalsis to propel the urine across the VUJ, and in which it fails. So there is a passive dilatation of the ureter proximal to that, and this creates a kind of non-compliant column proximal to VUJ, and the VUJ gradually gets decompensated and the reflux occurs. And there are a lot of kinks and the tortuosity in the ureter as well. Further, repeated urinary tract infections as well as the transmucosal infection across the wall of the ureter leads to the thick ureter wall, which further makes it non-compliant. And this keeps a high intraluminal pressure, which constantly keep damaging the upper tract and further resulting into the loss of the nephrons. As far as the management is concerned, there might be some similarity in the workup of these types of the dilated ureters, but the management policy largely differ in these cases, and let us see how it differ. And the basic objective is to achieve the decompression of the upper tract, irrespective of the underlying etiology. And one has to achieve a safe bladder. And what is safe bladder? I will be coming in subsequent slides. And the rule of the game remains the same, irrespective of the etiology, that is the address the underlying cause. And it is also seen that the dilatation largely resolves once the elevated intravesical pressure or the ureteral obstruction is taken care, maybe in the form of ureterous failure. But in spite of taking care of all that, you reduce the bladder pressure to the level of safe bladder limits, or you might take a direct cause of obstruction from the ureter. But even then the ureters remain dilated and it continue to have an altered compliance, and it is because of damaged peristaltic mechanism. A non-compliant ureter still remains even after taking this damaging or this source of this dilatation. So before we go for the management part, we need to understand what is hostile bladder, where we get most of the time these secondary megagureters. It has been defined that when the end filling pressure or the detrusor leak pressure is more than 40 centimeter of water or above, and when it is associated with neurogenic detrusor overactivity and along with detrusor sphincter dyssynergia. So this is the worst conditions where the megagureters and the kidneys are mostly affected. So as I said, our objective to treat the secondary megagureter is to get a safe bladder. And these are some of the parameters which we have been taken from the various authors and the societies, ICCS and the Empire study, which says that how do we define in terms of adequate bladder capacity, where it is greater than 65% of bladder capacity expected for age. And there is no compliance disorder, that is the end filling pressure is less than 25 centimeter of water, or the compliance is greater than 15 centimeter of water, and there should not be any element of detrusor overactivity and no detrusor external sphincter dyssynergia. And they also included in Empire study that the PVR has to be considered as per the age criteria just after the toilet 10 that is in the group of 4 to 6 year old if it is greater than 20% of expected bladder capacity, and while in older children that is between 7 to 12 years of old, if it is more than 15% of expected bladder capacity, then it should be considered abnormal, and lesser than these should be considered as safer bladder. Now coming to the management part, as I said that the management largely is based on the underlying pathology. So if it is a neurogenic bladder or a tethered cord, then you have to characterize the bladder dysfunction, treat it medically most of the time, and most of these children, they respond to clean intermittent catheterization, and there might be expectation that these secondary megagureters may resolve to some extent. If it is a non-urogenic bladder, we all know that the urotherapy is the staple part of this management, along with pelvic floor training, and a strong bowel program has to be executed in this. If it is a posterior wall leading to intravesical obstruction, then ablate the wall, relieve the obstruction, characterize the bladder dysfunction, aid some pharmacotherapy depending on the character of the bladder dysfunction. If it is ureterocele, most of the time need incision. If it is a significant obstruction, cause of significant obstruction, and nearly 40% may need subsequent reimplantation. And similarly, a bladder diverticulum can be managed depending on the this obstructive element. As such, there are no correct data available after taking the primary course, that is when the bladder has been rehabilitated or the bladder has been stabilized, how many ureters or the dilated ureters they basically get stabilized. While in cases of reflux, it has been studied in many cases, especially in cases in series of posterior wall, that 1/4 to 2/3 of these children, they report resolution of the reflux. This may not disappear completely, but definitely there is a decline in the grade of reflux. And there may be some situations when one may consider when to intervene in these children, because there has to be a very high threshold, because these are secondary magorators. There are many technical considerations before we go for the definitive surgery. And I feel that aggressive treatment of with early surgical intervention not to be justified. At many of the magorators may resolve spontaneously once the erring cause is taken care. So these are some of the points where one may consider for this intervention in cases of secondary magorators, like recurrent urinary infection in spite of taking bladder dysfunction, as well as suppressive antibiotic prophylaxis, taking care of high phospholipid residual urine, breakthrough pyelonephritis, fall in split renal function or glomerular filtration rate, or there is an occurrence of the knee scarring on follow-up or DMSA scan, or there is a non-compliance of continuous antibiotic prophylaxis, or if it is a definitive obstruction, like in the last image, you see a definitive obstruction, while the evidence of that in literature is less than 1.5%. So these are some of the situations where one may go for a definitive treatment that is in the form of reimplantation. And before we embark on the surgical correction, we have to take some of the technical considerations, because in primary ureters, conditions are well controlled. Here, the ureters are thick and bulky. While in making dissections, they ooze many times. Bladder capacity is mostly compromised. You have to put ureters into this thick bladder, where it may be difficult to raise a submucosal tunnels. And most of the time you tear mucosa so many times, and the tunnels and the bladder base also bleed in many such cases. So sometimes many authors have expressed that an extravesical approach may be safer rather than going for a transvesical approach in cases of secondary magoureter. And a vesicopexy or a swasich may be helpful in giving better results as compared to the transvesical approach. As far as the surgical outcome is compared, and it is not far from superior when in controlled situations. And these results are in well-selected cases when the bladder dysfunction has been taken into care. If you see that the management of the primary ureter, the success rate of surgical outcome has been achieved even up to 100%, while in cases of secondary magoureter, in highly selected cases, you can achieve up to 95%. So to summarize, in cases of secondary magoureter, underlying cause has to be primarily ascertained. Based on that, treatment strategy has to be individualized. Bladder dysfunction is to be addressed first before embarking on surgical intervention like reimplantation. The surgical outcome is fairly good in well-selected cases. So with this, I thank you all.
Thank you, Professor Ansari, taking this one. Before we proceed, we have a few of the questions.
Yes, please,
if you
sir.
want, I can put those questions to
Yes,
the...
sir, please, sir, please.
this one, number one is that measuring the ureteral dilatation to both Dr. Amila and Dr. Tekoni. Do you consider the emptying the bladder, or the diameter taken is ureteral diameter taken is with full bladder?
So, should I take this question or Dr. Amla? Dr. Amla, you go ahead.
You can, yeah, Dr. Anil, yeah, please go ahead.
So, what we do is that we generally see that the bladder is full or not. If bladder is full, we take that opportunity of measuring the retrovesical ureter diameter, which is if it is dilated, we exactly measure it, and then just on pressing the probe at that particular time, generally child or neonate or infant voids, and we can the same time measure the ureteric dilatation in the empty state. So it is necessary to see all this dilatation in both the phase, full bladder as well as empty, so far so possible.
Thank you, Doctor. Another question is, Dr. Massimo, you see, do you take the length of the adynamic segment? How do you measure the length, or does it make any difference in selecting the treatment of minimal invasive?
That's a very good question. Thank you very much. And well, for what regards the endoscopic approach, you do have not the chance to have a complete measurement. Of course, we do run a retrograde study, and that is giving us an idea of the length of it. So we do tend to perform the procedure, but we are conscious that there is a degree of there is a chance of failure, which might be linked to a very long segment, and those which we fail with endoscopic are those that will be likely to require a classic reimplantation, which is the account for the few percentage of unsuccess that has been described with the endoscopic approach.
So even if it's a long segment, more than 15 millimeters, still you will go for?
We'll try, yeah.
Endoscopy?
We'll try with endoscopy, yes, because sometimes, I mean, we know that sometimes the segment that is adynamic is the problem, but maybe there is a combination of the adynamic and a stricture. So doing the endoscopy is not causing significant damage. Even if you go back and then have to reimplant, you're not facing any complication. You're not compromising your subsequent insertion. So we do perform the balloon. We are carefully monitoring the outcome, and if we do perceive that there's no significant improvement, we then consider the second approach.
Okay. Another question was how long you follow up these patients and how many of them require the surgical intervention? Either endoscopic, minimal endoscopic second one, or the open surgery or minimal invasive robotic or laparoscopic reimplantation.
So the cohort that we presented, we had a follow-up a median follow-up of 16 months, but this is because we do have a few of them that are very little. So that is the screw of that. So we tend to perform serial measurement. Definitely there will be one post-operative nuclear medicine test, which is significantly showing if there is a blockage residual or not. And otherwise there will be serial ultrasound for at least 12 to 24 months. And following that, if we do demonstrate that there is completely resolution of the dilatation, if there is no symptoms and there is proof that the drainage is achieved with the post-operative MAC3 study, at that point we can discharge the patient. So at the minimum will be 12 months at the minimum, but sometimes they take a little bit longer to then have the completely resolution of the dilatation. Sometimes we do have children, depending on the age. If, for instance, they are operated earlier, we might want to wait for the potty training to have more reliable ultrasound scan with full and empty bladder. And sometimes even for what is the the natural delay of follow-up due to the hospital appointment, we do follow them longer than that. The bare minimum will be 12 months to 24 months.
Okay, thank you. Then now you take up Professor Bhandari, Ansari ji.
Yes, sir.
You
One
are
more
going
question.
to synonym
Yes,
to
yes.
Professor Bhandari in SCPGI.
Yeah, thank you so much, sir. It is an honor for me. And Dr. Amila, there is one question for you also specifically. Okay, when in observation policy, suppose the baby on the first scan reports a very poorly functioning kidney. Suppose if it is less than 30%. So will that change your policy?
Yes, definitely. It's a one single factor. Now, as I said on my presentation, obstruction defined as less than 40% generally at the initial differential renal function. That's a real factor to consider. Now, with that 30%, if I say 30% function, then we need to consider how big the dilatation of the ureter, how big the dilatation of the renal system, whether that is single system or two system, whether the child is asymptomatic. So it's all factors need to consider, but initially we tend to do conservative with antibiotic prophylaxis. If this is progressively causing problems, yes, we will consider operative, but to start with, we will do conservative management if the child is stable and the dilatation is stable, even though it's 30%.
Okay, thank you. So we have many other questions which we will be taking up during the case discussion. Okay, so now we are logging in for the case discussion.
We are running short of time. I think
Sir, we will
proceed
just
ahead.
quickly run, sir.
Yes, run, please.
Okay. So it is visible.
Yeah, sir. Yes.
It is visible now.
Yes, sir. Go ahead.
So thank you once again. And Dr. Massimo, Dr. Amila, Dr. Bhatt, Takwani, sir, Dr. Malika Arjun. And so we start with this is a male baby, 1 week old, and it is a full-term baby. Normal vaginal delivery and has a weight of 2.8 kg. Otherwise, it is a healthy baby accepting breastfeed normally. So antenatal history shows antenatal ultrasonography, left kidney is 4.4 centimeter with SFQ grade 2, and the right kidney is normal, and upper ureter on the left side is also dilated.
We lost you, Ansari.
Hello, can you hear? We are not able to hear you, Professor Ansari.
Not able. Okay, sir.
Yeah, now it's okay. Yeah.
So it is a ultrasonography done at 1 week, shows, and the grade of hydrophrosis also increased from grade 2 to grade 3. And the left ureter is also dilated, and the retrovesical ureter, the diameter is 10 millimeter. And the right kidney is normal. So my first question is to Dr. Amila. So yes, what further test do you advise in this case?
Yeah, that's a boy with a unilateral dilated renal system. I would firstly keen to know whether how good the urine stream and whether bladder palpable or not. With those information, I would go for a MCUG first to exclude the valves for that boy.
The mother did not report anything in terms of lower intake symptoms, as well as there was no bilateral lump also in this child, and spine examination was also normal.
Good. So even with that, with the unilateral dilatation, I would still go for MCUG at this stage, and then exclude the refluxing and the blood outlet anyway. And then with that finding, I would do a repeat ultrasound scan another few weeks time.
Okay. So, Dr. Massimo, any change in your policy?
Yes, I'm interested. So why you are suspecting obstruction at this point? We do have a completely normal one-side kidney. We do have dilatation only on one side, no evidence of thick wall bladder, no, or at least not that I got. Why you are suspecting an obstruction at this point?
So, Dr.
Ansari.
Dr. Amilo, so will you take this question because you asked this? Why is saying the ultrasonography is not showing any thickening of bladder wall, dilatation of the posterior throat? So it is necessary to suspect all the time that they will be having some infravesical obstruction.
Well, it's not because if the child is well with a good urine stream and the bladder is normal on ultrasound scan and not palpable bladder, as you said, it's fine, normal. We are not in a hurry to do anything, and observation policy would be the best to go forward without doing anything. But yeah.
Professor Ansari, can I say one word?
Yes, sir, please go ahead, sir.
You see, I think I want one more ultrasound picture. Where is the exact location of the ureter going beyond in posterior urethra? Is it ectopic or not? One question is this one. If ultrasound has this one, then second quiz just to have the renogram at the age of, since the child is asymptomatic, only the functional study from 6 to 8 weeks to 3 months.
Okay.
And another
So
important
as
message which I want to convey from the desk is that 2 o'clock validatory function is going to start. We'll have to wind up by 2 and accordingly proceed ahead.
Okay, okay, sir. So this is, I think this is the renal scan, sir, available. So blue line is of that of left kidney.
Yeah.
We showed the hydronephrosis.
This is question to me, sir.
Yes, sir. You asked for the renal scan.
Yeah. I think this shows the pattern obstructive, but the child is asymptomatic. I would like to put him on prophylaxis, wait, observe, and then follow up with the USG. And if any break occurs, febrile UTI or anything, then further evaluation and accordingly management.
Dr. Ansari, can I ask a question? Very quick question.
Yes, Dr. Takwani,
Dr.
please
Ansari,
go ahead.
in that case, I think Massimo is also agree, and you also. I want your opinion that in that case, what is the problem in waiting for a couple of more sonography trend? Means we can do it at 1 month and another one at 2 to 3 months, looking at the 1 month sonography, and then we can take a call whether to go for a VCUG or renal scan. Why not in this particular index case?
Right. So, Dr. Malika, would you like to add something to what Dr. Takwani is saying?
Yeah, I think there is one important thing in pediatric urology which everyone should know is there is no way that you can quantify obstruction. The only way we can quantify obstruction is by when we detect a loss of renal function. And the whole issue is, do we wait till that particular point of time? That's number one. Number two, in this particular index case, you have said that in a matter of a week, there was an increase in the hydronephrosis. Now, I'm not taking that very seriously, but still, I think all the question which Massimo asked is whether it is an obstructive pathology or not. A non-obstructive pathology is a diagnosis of exclusion. Yes. Whether it is refluxing or obstruction, if we exclude those, then it becomes a non-obstructive pathology. Till such and such time, we need to diagnose the pathology. Whether we would intervene or not is a secondary issue. Whether we should wait or not is one which is based on clinical decision, based on a lot of other things. I think a serial ultrasonography once in a month in the initial phase would definitely help. But these are the basic issues that we need to individualize all these treatments for that particular child. Let's not look at one renogram. Even if you look at this renogram, if you look at the curve of the left kidney, the uptake of tracer is quite slow. It is not the same kind of tracer uptake, the flow which is seen in the right kidney.
Yeah, so I agree with what you said. Of course, my approach would be definitely to have a few, like say a couple, 2 or 3 ultrasound scans to monitor if there is a progression of the dilatation, first of all, which will be a non-invasive way to be monitoring the child. Normally in our center, we do week 1, week 6 as a sort of a standard approach. So we do have 2 postnatal ultrasound scans which we look at. And when I was mentioning about obstructive, I was challenging the post bladder obstruction. So I heard that there was question about like valves, and I was in a disagreement with that regards. That's why I said a early MCUG I would not see. If I do now question whether there is a blockage at the VUJ, so now we are talking about ureteric obstruction, at that point, I will go for the MCUG to exclude the reflux. So that would be my query for the MCUG, if I do have a reflux or if I do not have a reflux. And at the same point, once I have a MAG3 study, which I agree normally not earlier than 3 months, with the combination of delayed drainage and degree of loss of function, this more or less completes the case. So I do have now criteria to worry about an ongoing obstruction.
So let us take this is a non-refluxing primary obstructive megaureter. So how long to follow this baby?
Yes, that's so that's an interesting one. Now, once we make the diagnosis, come to a conclusion, this is primary non-obstructive or non-refluxive megaureter. If the follow-up ultrasound scan, again, it's a spectrum, as I said, depending on how the follow-up ultrasound scan change, we would initially would follow up first year to first 2 years with regular monitoring, in the sense ultrasound scan, ideally 3 to 6 months, depending on the availability, and the follow-up ultrasound scan, how big the dilatation and how the patient behave. So all factors need to consider, how frequently you need to do, and how long we should go. By the end of 2 years, with the parental informed consent, if the child remain asymptomatic, we can make that decision to continue follow-up till the spontaneous resolution. If this is not resolved, then again, if the functions remain stable, we can continue yearly or 2 yearly imaging.
So it is a 40% split function at baseline, and retrovesical diameter is 10 millimeter. So what is the probability or likelihood of spontaneous resolution in this baby to counsel the parents? Dr. Amila.
Yeah, so it's with the current evidence, it's clear that more than 70 to 80%, which we have even more than 10 millimeter, we have a chance that non-surgical intervention would benefit in long run. In the Manchester, as I said on my paper, so which is with a 19 years follow-up, we have found that 10 millimeter to 10 to 14 millimeter, more than 80% chance that we can manage without operation.
Ansari boss. Ansari boss.
Yes,
one
please
small
go
take
ahead.
on. Yeah, one small take on this. Now, we all speak of percentages. Let me get back to it. The bottom line is, I think we need to follow this child up till we have total resolution. So irrespective of whether there is a 70% resolution or a 30% resolution, for that particular individual child, it is the overall resolution. If it does not resolve it, if it starts increasing, the function starts decreasing. When we keep on following up, whether it is 6 monthly or a yearly, depending on how the function is and how the child is doing symptomatically, I think the total resolution is the end point, whether it is surgical resolution or whether it is spontaneous resolution.
So Dr. Massimo, you wanted to make some comment?
Yeah, I'm interested in understanding when people say that we monitor the function, the only way that we do have is repeating nuclear medicine test. And I would try to not be too aggressive of repeating the test so often. So my question for my colleagues is, how often do you think you repeat the MAG3 study to monitor the function?
Can I take Dr. Ansari?
Yes, please go ahead.
So that is very interesting question, Massimo. And my practice, in my initial practice was doing, this investigation 6 monthly or 1 yearly. And then I realized that it was really not necessary in presence of excellent ultrasonographic friend. And you can definitely avoid this radiation involving investigation. And we can just look for all these things into the sonography morphological changes. And then accordingly, we have to decide about the next scan, if at all necessary.
So the final take, yes, Amila, please go ahead.
Yes, I agree with that because it's an individual case basis rather than the guideline of 6 months to 1 year or 2 years. If depending on the ultrasound scan, if you have a good sonographer measuring the ultrasound scan measurements correctly, and if the child is asymptomatic, we don't need the very regular MAC3, and we don't need even sometimes MAC3 scan to assess the function, as long as child is asymptomatic and ultrasound scan showing good renal cortex.
Dr. Takwani, you may give the final take from case 1 so far after listening all the participants.
Actually, Dr. Ansari, that what I wanted to tell you that I would have waited for next scan, which would have done at the age of 1 month. And if that is same or showing regression, then I would have been very happy. Otherwise, I would have then gone for the VCUG to rule out the reflux, as Massimo mentioned. And if there is no reflux, then after doing the 3rd month sonography, I would have taken decision for the diuretic scan. So that would have been my sequence of investigation. And during all this period, I would have continued with the antibiotic prophylaxis.
Right. But with an assumption that because most of the parameters are favorable as the parameters presented by Dr. Amila from their study, and there are high likelihood that this baby is going to resolve without any intervention. And since literature also support that nearly 80 to 90% of such baby they resolve over a period of time. The only thing you have to tailor your this follow-up plan as per the existing scans or subsequent scans.
Sir,
So,
as we are not going to, sir, as we are not going to get any more meat,
we can summarize this one.
I would like to request the audience through you that most of the time, even in this era, we are getting referred these patients with a CT scan or CT IVP.
Okay.
Please.
Over to Dr. Bhatt. Yes.
Yes, this is a very sound and loud message that ultrasound and renogram, MAC3 or EC is the investigation first required. There is hardly any role of CT urogram or IVP. If need be, third investigation is MR urogram. That will help you to get the not only the diameter, the length of the adynamic segment also. So in these is we have to follow the key point is follow with the ultrasound, progression or regression. Regression, you can continue with follow with the ultrasound, any progression, further evaluation with MCUG or renogram, and then proceed accordingly.
So I think both Dr. Amila and Dr. Massimo will agree that there is a limited role of MRU in state case of primary obstructing megaureter, unless there are history of things suggestive of secondary megaureter or some incontinence or we are suspecting some duplex system. Then the MRIU comes into the picture. Most of the time, primarily it is the job of ultrasonologists to help us. Then we can tailor our renal scan also, whether we need it 3 monthly or 6 monthly. It is depending on the radiographic parameters of this baby.
Very right. Very right.
Yes. Yes, Dr. Bhatt, sir, we got the session late. So can we extend to another case for 10 minutes, sir? Or please ask the organizers. We have another interesting case.
I think you wind up, they are asking for this valedictory function.
Okay.
So I think you just take 3 minutes in next one we give, and you summarize and give the
we will just
message to the audience what you want to convey.
We will just go quickly within 3-4 minutes. So this is another case of 3-month male. He presented with fever because this scenario is altogether different. 3 episodes in the last 6 weeks. The baby also had vomiting. And the perinatal history, it was a full-term baby, normal vaginal delivery. And the urine culture shows 5 to 6 high power field. WBC's urine culture was also positive and the serum creatinine was 0.6. This is normal to our laboratory. He showed leukocytosis predominantly with polymorphs. Ultrasonography showed again left kidney dilated, SFU grade 2, and left ureter was also dilated. Here the retrovesicular diameter was 12 millimeter and the opposite kidney was normal. Next investigation. Now the baby is 3-month-old, fever with vomiting. Dr. Massimo, will the approach change in this baby? Now he has come with fever, with 3 episodes, vomiting and documented UTI.
Yeah, I would definitely be more concerned for that child. Absolutely. One thing that we tend to do is an ultrasound scan at the time of the acute illness, which we expect to see with the breeze in the system. That is another clear, direct confirmation of an impacted drainage. So I will be definitely more proactive for this child, more interventional than waiting.
Right. So this was the VCUG, which was done the next after stabilizing the child when the urine became sterile. So Dr. Amila, your thoughts about the case?
Yeah, so as Massimo said, according to the NICE guidelines, we tend to do the acute ultrasound scan immediately to see the debris. Now the ultrasound scan didn't show any debris on the one that mentioned. The MCUG looks nice, clear, regular bladder with good posterior urethra, seems emptying. We would like to see the emptying scan also, and to see the refluxing. So we can't see any reflux on this image. Seems like a good bladder outlet with a primary obstructive megaureter, single urine infection, which is important, significant infection with a febrile culture positive, and got a 12 millimeter dilated ureter and dilated kidney. So once the infection settled, once we treat the infection with antibiotic, I'll keep him on antibiotic prophylaxis, and they do a repeat ultrasound scan another 6 weeks time to see how it change.
Okay, so when would you advise the renal dynamic scan in this baby?
How old the baby is? 2 months now, yeah?
He is already at 3 months.
3 months, yeah. So we will, once the infection settled with after the repeat ultrasound scan, depending on the dilatation, while on antibiotic prophylaxis, I'll discuss with the family about the renogram.
Okay, right. So these are the these are the findings of affected kidney showing 46%. So now, will you continue this baby on the similar guidelines as we discussed in the previous, which did not have any documented UTI, otherwise normal baby? Urinator megaureter with history of recurrent UTI, or you will go next step further?
I would personally, I would continue antibiotic prophylaxis and continue conservative management, supporting that kidney functions remain stable and the child remains stable and asymptomatic while on antibiotic prophylaxis. If the child has recurrent urine infections, I would consider the minimally invasive option.
Dr. Bhatt, your thoughts, sir?
Yeah. I think this patient with the
he had this documented UTI. He had 3 episodes of fever. Yes.
Yeah, re-evaluate again. This is the first episode, or this is the second or third episode?
He had this is third. He has already had 3 episodes of fever.
So I think he needs some, and I will prefer to have minimal invasive methods for this one after controlling the infection and after child is settled.
Dr. Anil Takwane.
Sir, I definitely do not have a much of experience with the minimal invasive, for example, stenting or balloon dilatation. And generally, in my practice, I don't believe if this is the picture in my practice and it is 4 months or 5 months and the bladder is good, once the patient is stabilized in a unilateral megaureter with this kind of a history, I tend to go for a reimplantation, or if not possible because of baby is ill and some doubt about the fitting means doing the reimplantation because of the bladder capacity, I may go for a ureterostomy. But
Dr. Malika
I don't
Arjun.
have any experience with it. But
Yeah,
it works. Any of these things, reimplantation or development works so far. So settling down with the infection and growth of the child in the kidney.
I would probably do a repeat MCU maybe 6 weeks down the line before I intervene, because we may actually miss about 30% of these refluxes. But in case we need to, when still it shows obstruction, I try to intervene, try to put in a stent. If it doesn't go, sometimes it's been there, the guide wires don't go, I would probably do a ureterostomy, let the kidney settle down, infection settle down, no obstruction, and then subsequently reconstruct it.
So, Dr. Massimo, do we need a DMSA scan also? Because he had a documented UTI, 3 episodes of fever.
So going back to the question before, I would definitely go for an intervention, and my primary goal would be the endoscopic intervention. So I do agree with the colleagues about intervening, and the approach we do adopt is intervention with the balloon. DMSA can help to see whether there is any scarring. Usually scarring, if you want to be reliably on the DMSA, you should wait at least 6 months. So at the moment, I would not go for an acute DMSA. We do have a nuclear medicine telling us some function is there. I don't need to know that there is any acute problem. I probably could consider this at a later time once things are resolved.
Professor Ansari, we have a lot of pressure from the local administration. I think you'll have to summarize.
Last word about besides the minimally invasive, is there a role for refluxing reimplantation in this child? Question is to both Massimo and Amila.
I normally don't use this as my primary goal.
Yeah, if this is quite a debris on the system, rather than putting a double J stent, I would go for a diversion. Diversion can be done cutaneous ureterostomy or refluxing reimplantation. So again, discuss with the parents, give them the both option. So we do practice both options as long as the parents understand both the options on the selected patients, not for everyone.
Well, thank you very much. So with this, we conclude this session, and I really thank Dr. Massimo and Dr. Amila, and with the hope that to rope you in again for the subsequent meetings from USI as well as the zonal chapters from Urological Society of India. And it was really a wonderful session. And I also thank our colleague, Dr. Bhatt and Dr. Malika Arjun and Dr. Takwani also. And I also thank the organizers for the North Zone UCI, Dr. Anup and other executives of the committee. Thank you so much. Over to Dr. Bhatt.
Thank you, Professor Ansari. I think we started 10 minutes late. We ended up nicely. And thank you very much. And
with that way, we are punctual, sir.
Thank you. Thank you very much.
Thank you.
Thank you.
Thank you for the great invitation. Thank you.
I'd like to thank convener Dr. Bhatt sir and all the esteemed faculty panelists. And I would sincerely apologize to interrupt you. Would like to hear you more from the stalwarts like Ansari sir and Mallikarjun sir, Takwani sir. But because of the serious time constraints, we need to curtail your session. Thank you very much once again. And I request Dr. Kamaljeet Singh to kindly present the memento to Dr. Bhatt sir.
I think this memento goes to all because I am taking on behalf of you all.
Yes, Dr. Massimo and Dr. Amila.
All of you, so I'm taking on behalf of all of you.
Thank you so much, sir.
Put the picture of all on the. Yeah. Yeah.
Oh, thank you so much, sir.
Thank you. Thank you.
Thank you.
Thank you very much.
Thank you.
So yes, this goes to all of us. Massimo, Amila, Takwani, and Malika Arjun, and of course, Dr. Bhatt. Thank you so much.
Thank you.
Including you, Ansari bhai.
Yeah. Oh, yes. Me also. Thank you so much.
Thank you, sir. And special thanks to Dr. Amilal Bhatt, sir, that he accepted our request to convene the session at the 11th hour. Thank you, sir. And thank you all the esteemed panelists from organizing committee. Thank you, sir. Thank you.
Thank
We
you.
are we'll signing off.
Okay, thank you so much.
Bye. Thank you.
Thank you.
Bye.
Bye.
Bye, Dr. Masimo,
Bye.
Dr. Amila,
Bye,
Dr. sir, and
Bye, Dr.
Malika
Amila.
sir.
Bye.
Okay,
Bye. Thank you. Thank you. Excellent.
Thank you, sir. Good day.
Looking forward to see you again.
Okay.
Yes, sir.
दिखता हुआ है